Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
Hi, I'm Trey Branham. Dean Omar Branham and Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this totally preventable disease.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Yep.
Our immune system. Our immune system protects us from disease, killing bacteria and viruses. Our immune system protects us from disease.
Well, good morning, good morning, good morning, everyone. Good morning, everyone. There we go, just like church, make it happen. Good morning and welcome to the second day of the 2024 International Symposium on Malignant Mesothelioma. Thank you. I wanted to start off this morning again. Those of you who I did not get to meet yesterday, my name is Brian Lepasic, and I am privileged to be the executive director of the Meso Foundation as of 2 months ago. And very thrilled, again, that we're back here all together in Chicago. And did everyone have a great day yesterday? Yes. Probably a day of listening, a day of sharing, maybe a few tears now and then. A day of learning, hopefully, for you all, too. And hopefully you've made a new contact or a new connection. You've grown your community in some way. And that's the purpose of this event, is to keep our community growing and interacting and thriving. So again, thank you for your participation. And we have an action-packed day for you again today as we move into our scientific portion of our meeting. I just want to also welcome everybody who is online with us today. The morning sessions were not online yesterday. They began in the afternoon. So welcome everybody who's part of our virtual community. We are thrilled that you were able to tune in and join us for part of your day. I'd like to also begin to cast a spotlight again on our incredible sponsors for this event. We could not do this without them. They are the backbone to making this event happen. So again, thank you to Bellick and Fox, to Dean, Omar, Branham, and Shirley, otherwise known as Dobbs, to Monty Raichi, and also known as MRHFM, from Merck Pharmaceuticals, Gorey Law, Bristol Myers Squibb, and Early Law. So again, a round of applause for all of our sponsors. Also, thank all of you for your incredible response to our call to action for participants for our Michigan State University and Meso Foundation partnership around the forthcoming CDMRP grant. Again, it's focusing on the needs of the caregivers within our community. So I could just real quickly ask Claudine and Maria to raise their hands again, and Dr. Woodward with them. Any questions about this project? Please just reach out to them, corner them, buy them a coffee in the lounge. It's free though, and I'm sure they'd be happy to chat with you more about the process. And again, if you have not already seen the QR code around a couple times yesterday, there it is for you again on the screen. And there's a takeaway, I believe, out in the lobby as well that folks can take a flyer home with them if they want to think about it more before they go online and decide to participate. Just a quick bit of housekeeping. And I want to thank our board of directors for their participation yesterday in our board meeting, which went for a good 3 hours, but some great work was accomplished for the organization looking ahead to the coming year. Our community advisory board did a great deal of the lift yesterday, and they'll be doing some of that today as well. So I thank them for their participation. And our scientific advisory board is kicking into full gear today with their portion of their meeting that's going to take place down the corridor. I'll talk more about that in just a second. But they'll be coming in here to present at various times on various topics that you've seen in your program. So again, complete listing of that is in your Spiral Bound program if you want to follow along with that. Choose things you want to stick around and listen to, and learn more about what they have to offer for us. Again, keep your QR code for the building handy if you go outside. You're going to need that to get back into the facility. And restrooms are down both corridors for ladies and the corridor over here for the gentlemen. So, again, this morning we're kicking off our scientific portion of our meeting. And I will ask all of the scientists in the room and those participating in the scientific meeting, your meeting room is different than this one. You are down the corridor here to my left, where Julie is standing. And Mackenzie, who's one of our wonderful volunteers, she will lead you down there momentarily. So you can follow her down to that room. And Julie will extract you from that room as we need you back here for your presentations to the larger community group. So again, thank you all for the participation this morning. We're going to kick this off in this room. Julie will be doing Mesothelioma 101, Mesothelioma jargon, and she'll begin that in a moment. So please, I could ask folks over if you're going to move, pick up your stuff and follow Mackenzie. And if you're staying around, you want to get closer, please come in closer to the screens or to the middle to be by our presenters. Thanks. So doctors and scientists can follow Mackenzie. Mackenzie.
Really
Okay.
fast.
There you go. Boom.
Perfect.
Yes. Question?
My son's interested in the science pieces. Is he allowed to join, or is it by invitation of the doctors?
It's by invitation for physicians and scientists altogether. But they'll all coming in here to present a bit of what they're talking about in there. So if there's a topic within the program that you'd like to get more information on, have to stick around in here. The scientific portion is closed to that group for their discussion.
Yeah, it's just a meeting of the physicians, but physicians will be in here all day. This is a scientific meeting for patients, families, anyone else. So good morning, everyone. I'm Julie White, and I'm the Patient Services Director here at the Foundation. Today, I'm doing a presentation on Mesothelioma 101, which is basically just some terms that you might hear during talks today. So just going over some basic information. So we're starting with some basic terms. There's 3 different cell types or histology that are based on the appearance of particular cells that you will get from a biopsy. The first type of cell would be epithelioid. This is the most common cell type. There's in 50 to 70% of all cases, they tend to respond better to treatment. The next cell type would be sarcomatoid. This is found in 7 to 20% of all malignant mesothelioma, and it's a bit more aggressive or resistant to treatment. Last is biphasic or mixed, and this is approximately found in 20 to 30% of malignant mesothelioma, and it's a combination of both epithelioid and sarcomatoid. The pathology report may identify the dominant percentage of which cell type it is. Moving on to staging. There's the TNM system, which stands for tumor node metastasis. The tumor indicates the size of the tumor or deeper tissue involvement. N is node, which indicates regional versus distant nodes involved, lymph nodes, and metastasis indicates that the mesothelioma has spread outside of the region of the primary disease and or to distant organs. So if you put the T and M together, then that gives us the stage, which would be, there's 4 stages, 1, 2, 3, or 4. When you look at peritoneal, you may see PCI, which is peritoneal cancer index. And this is calculated by giving each of the 13 abdominal regions a score from 0, which is no tumor, to 3, which is a tumor greater than 5 centimeters. And a higher score would indicate more widespread and larger tumor. When you add all of these regions, the score can be between 0 and 39, with 39 obviously being the highest. So with staging, this helps to drive the treatment plan. It can decide things like surgery, systemic therapy, combination therapy, or clinical trial eligibility. Looking at some surgical terms that you may want to know. For pleural patients, you might hear PD, which is pleurectomy or decortication. And this is, they call this a lung sparing surgery. This is a surgery that removes the lining from around the affected lung and tumors from the surface of the lung. Then you may hear EPP. EPP is an extrapleural pneumonectomy, and this removes the impacted lung and other structures that are within the chest. For peritoneal, you may hear something called CRS, or debulking, and this is a peritoneal mesothelioma surgical procedure, and the goal for this is to remove all the visible tumor from the abdominal cavity. 2 other terms that you might hear would be HIPEC or EPIC. HIPEC is hypothermic intraperitoneal chemotherapy. And this is the more common of the two, and this is given in the surgical suite directly after the surgery. I'm not going to explain the procedures in detail because all of these things are things that will be discussed by the physicians. I'm just explaining basically what the names are and what they mean. An EPIC is an early postoperative intraperitoneal chemotherapy. This is there's a port that's placed in during the surgery, and then this is chemotherapy that's given usually about 6 to 8 weeks after surgery. Moving on to systemic therapy. This is systemic means throughout your whole system. So your medical oncologist will choose the best therapy for you based on your staging, histology, and any identified mutations that you may have. So looking at systemic, this refers to things like chemotherapy, immune checkpoint inhibitors, which means for mesothelioma patients, basically immunotherapy, things like precision medicine, targeted therapies. So chemotherapy refers to cytotoxic, which stops the growth of rapidly dividing cells. And there are several types of chemotherapy, which will be described later today. Immune checkpoint inhibitors, which is immunotherapy, and this uses your body's own immune system to harness or fight cancer. There's precision medicine, which is personalized medicine based on your tumor's morphology, and targeted therapies, which attack or target specific proteins on your cells. And that, again, is actually a type of precision medicine. Moving on to the types of systemic therapy, there's some terms you might also hear and wonder, like, what do these mean? Neoadjuvant means delivered before surgery. Or induction therapy. The goal of neoadjuvant is to make the main treatment, like surgery, more successful. So neoadjuvant chemotherapy or immunotherapy, is followed by surgery. The next word you might hear is adjuvant therapy. Adjuvant is given after surgery, and the goal is generally to reduce the reoccurrence of the disease. So you may have surgery followed by adjuvant chemotherapy or immunotherapy. So that goal would be to follow up any micrometastasis or little cells that may be remaining in your body after the surgery. So surgery followed by adjuvant chemotherapy. Multimodality treatment or combination therapy. An example would be chemo, surgery, and radiation, or chemo and IO. And when you hear the word IO, that also will refer to immunotherapy. And a lot of times in mesothelioma, it does require multimodality therapy. So, lines of therapy. Lines means how many treatment lines you've gotten. So 1L would be your first treatment mode that you've gotten. So the very first treatment line of systemic therapy would be 1L. Looking at radiation. I am not an expert at all in radiation, but I will go through skim over the surface of it. So there is external beam radiation therapy, which is a non-invasive radiation beam that treats a specific part of your body. And there's several types. There's proton beam therapy. This works by delivering a beam of protons to destroy and disrupt tumor cells. There's, you'll hear IGRT, which is image-guided radiation therapy. And this type works by using imaging scans for planning the radiation and the actual treatment. So each treatment, they're using some type of image to guide each treatment. Then there's IMRT, which is intensity modulated radiation therapy. This method delivers radiation in a customized way using computers to calculate and deliver a higher and more effective dose. These beams can be shaped to match the shape of the tumor and therefore spare some of the healthier cells. And then there's SBRT, which is stereotactic body radiation therapy. This is a very precise and more intense dose of radiation. And there's one type called cyber knife. There's another type you might hear, gamma knife. And those are the external beam. Then there's another type of treatment, tumor treating fields. Example of this could be Novacure, Optune. I believe we talked about this in our patient group yesterday a bit. This is the use of electric fields to exert forces to kill cancer. Some examples could be microwave ablation or high-frequency electric fields. Moving on to clinical trials. There's a lot of terms in clinical trials. Just going to go over a few. The objective, when you hear the objective of a clinical trial, what is that? That is the why. Why are we doing the trial? There's methodology. Methodology is how we execute the trial, how we carry it out. There's desired outcomes or endpoints. That's primary outcome. What is the most relevant answer to the research question? Then you'll see a bunch of initials, and you'll wonder, what are all these initials? The OS, PFS, ORR, CR, PR. So OS, overall survival, how long patients survive. PFS, how long patients survive until progression, progression-free survival. That's what that stands for. ORR, overall response rate. How long in total do patients respond? PR, partial response. Partial response means the cancer has shrunk but not disappeared. And then complete response. Sorry, I went out of order there. Complete response is we can't see the cancer anymore. Then we're looking at arms of a trial. You may hear that you got assigned to an arm of a trial. So participants are divided into specific arms or groups within a trial. There's a control arm and a treatment arm. So in a trial, if everybody got the same treatment, they wouldn't know if it worked or not. So they have to give what they call a comparator arm or control arm and a treatment arm, where they give some people one treatment and the usual treatment and then the trial treatment. And then they do it under very controlled, specific methods to see if the treatment arm worked better than the control arm, which is the usual treatment, to see which is more effective. And people a lot of times ask about placebos. It's not ethical to give someone a placebo. We don't give placebos without people knowing. The only time there'll be a placebo is if it's given in combination with standard of care treatment or given with another drug. But people, they don't do this anymore where people are given placebos without their knowledge. So moving on, there's randomization. If you hear the word randomized, this is where people are divided into groups by chance. This is used through a computerized system usually. This prevents bias. This is why this is done. It also allows for this to happen where we have people in each group and they're divided evenly and fairly. Sometimes they are blinded. Blinded means that specific groups of people, usually the research team does not know what the patient is getting. They can be unblinded if there's an emergency case or they need to know for health reasons. If there's a severe side effect, we can find out if they're unblinded. Non-randomized is where you're specifically put into a group based on a specific mutation or you go into categories based on your type of cancer, so that's where you know exactly where you're going in advance. There's 4 phases of a clinical trial, phases 1 through 4. Phase 1 is where we evaluate the safety and the tolerability of a drug. Phase 2 is where we're looking at the effectiveness and the safety, again, of the drug. Phase 3, we're often comparing the effectiveness against the standard care drug. And phase 4 is sometimes called post-marketing. This is where the drug has already been approved, usually by the FDA, and we're evaluating it in real life. Long-term effects, maybe some rare side effects, effects like with food studies, how things interact with foods. So those are the 4 phases. Now we're just going to barely again look at genetics and mutations. There's a lot to this, and I'm leaving this to the experts, but I'm just going to name a few, scratch the surface here. There's germline and somatic mutations. Germline mutations occur in parents' reproductive cells. These mutations change in the genetic material that the child receives from the parent. This is a hereditary mutation. You inherit these germline mutations from either parent. And there's examples like BRCA1, BRCA2, Lynch syndrome, cystic fibrosis, but there's also regarding our patients, I'll move on. There's somatic mutations, and somatic are changes to a person's DNA that occurs after conception to any cell that isn't a germ cell. And these somatic mutations do not pass from parents to their children, and they're not hereditary, and they happen sporadically or randomly without the mutation existing in a person's family history, and they cannot pass. And I was going to say, with BAP1, they can be either germline or somatic. So it can get a little trickier, and I'm going to leave that to the people who are able to best describe that. So, next generation sequencing is where the testing that people do. There's Foundation 1, Guardant 360. These are some of the tests that people have done to find out if they have mutations. They can use blood, tissue, saliva samples, and these testing can lead to emerging treatment options or clinical trials where we find out. I think I've spoken to several people about this before, but a lot of there's something called actionable mutations. Sometimes people will have a mutation that is able to be used or is able to be harnessed, I guess, for a clinical trial, which is something that will be talked about later today. There's something called novel therapies, gene therapies, which I keep repeating, will be talked about later today. Novel therapies is personalized medicine, focuses on targeting tumor cells and sparing healthy cells. And gene therapy, treatment approach that alters a gene. There's emerging approaches that include immunotherapy, viral therapy, and gene transfer. And I don't know as we have much time for questions, but all of these things, like I said, will be talked about in detail by our esteemed doctors today, and I thank you.
Thank you, Julie. Our next presenter is Dr. Hetty Kindler with the University of Chicago. We've never met. Nice to meet you.
Hi.
Presenting on chemotherapy, immunotherapy, and combination therapies. So please welcome Dr. Kindler.
Thank you so much, and it's a pleasure to be back and to see all of you here today. I know many of you very well, having taken care of you, which means you're going to know my spiel already, and then many of you I don't. So I'm going to be talking to you about tools for treatment. I've combined the first three into one lecture, a lot easier. So what are the medical oncologist's tools for treatment? We have chemotherapy, immunotherapy, targeted therapy, combinations of the above, and in parentheses I've put clinical trials because other people are going to talk about those later today. So what is chemotherapy? Chemotherapy is cytotoxic. Chemotherapy kills cancer cells indiscriminately, usually by interfering with their DNA. Because it kills more indiscriminately, it also has side effects in other organs. Chemotherapy exploits the fact that cancer cells usually grow faster than normal cells. Here are some of the commonly used chemotherapy drugs for mesothelioma. And doctors always use the drug name, whereas patients are more familiar with the easier to pronounce brand name, so I've listed both. Pemetrexed, otherwise known as Alimta, and that was actually initially developed by one of the founders of the Mesothelioma Foundation, my mentor, Nicholas Vogelsang. Then there is cisplatin and carboplatin, gemcitabine, also known as Gemzar, and vinorelbine, also known as Navalbine. What is immunotherapy? So immunotherapy, they are drugs that target the immune system. Logical. So immune checkpoints such as PD-1, okay, allow the cancer cells to be hidden from the immune system. And so your immune system says, hey, this is just Joe, right? This isn't anything abnormal. But the immune checkpoint inhibitors take off the brakes, and suddenly the body says, hey, cancer, you're not supposed to be there, and the body can then attack the tumor. So it's taken the brakes off of the immune system so that your own body can attack your cancer. So here are some of the immunotherapy drugs that are used for mesothelioma. I've listed those that are both in clinical trials as well as standard drugs, but the ones in bold are ones that are actually FDA approved for mesothelioma. And these include pembrolizumab, known as Keytruda, nivolumab, known as Opdivo, and ipilimumab, known as Yervoy. And so the first two target PD-1, and then IPI targets CTLA-4. So do immunotherapy drugs have fewer side effects than chemotherapy? Not really. They just have different side effects, which may be less predictable. So those of you who have taken chemotherapy, you kind of know what day you might have some nausea and what day you might have some constipation from the nausea meds and what day you're going to be tired or not feeling like eating, and then when you're going to be feeling like $1 million again. But in immunotherapy, these immune responses can be activated anywhere in the body, and so the side effects are less predictable. You don't exactly know when you might have them. And so the most common side effects that we can see are tiredness, itching, usually goes away after a while, rash, or decreased thyroid activity. But basically, the immune system can get activated anywhere it feels like it and takes a left turn. Instead of targeting the tumor, it's targeting another organ. If it hits the lung, you get inflammation of the lung called pneumonitis. The adrenal gland, you'll get adrenal insufficiency. The eyes, you'll get uveitis. The mouth, mucositis. The joints, arthritis. The colon, you'll get diarrhea. The liver, you get hepatitis. Pick an organ, add itis to it, you've got inflammation. And people don't get all of them. They get one or two, but it's just a little bit less predictable than chemotherapy, and your doctor just needs to have the experience to monitor it closely so that before it starts to get bad, you know how to attack it. So what is histology? And Julie alluded to this, and why does it matter? So histology is what the cancer cells look like under the microscope. So you can see that purple guy, and that's an epithelioid, and the guy in pink is sarcomatoid. And even without the colors, I think you can kind of see that the patterns are different. And so I tell my patients that there are three main histologic subtypes: epithelial, sarcomatoid, and mixed or biphasic. But I use the analogy of chocolate, vanilla, and swirl because that sticks better with people, you know? And so why does it matter to know whether you're chocolate, vanilla, or swirl? Because chemotherapy and immunotherapy can work better in some histologic subtypes than others. So it's really important these days to know which one. And it has both predictive, it helps you know how the treatment's going to work, as well as prognostic. It tells you how well you're going to do. So it's really important to know that difference. What is a PD-L1 test, and does that matter in mesothelioma? So this is a test on a tumor sample that measures the amount of the immune marker PD-L1 on the cancer cells. PD-L1 testing can be used to find out if your cancer may benefit from immunotherapy, but it's different in meso than in other cancers. If your cancer cells have a high amount of PD-L1, you may benefit from immunotherapy. If your cancer cells have no or low PD-L1, you may still benefit from immunotherapy. So in some cancers, like lung cancer, we use that to direct whether we should give immunotherapy or not. In meso, it isn't quite as important. And that's partly because we have what we call heterogeneity in the expression. Some parts of the tumor have more of it than others. And so we really don't fully know if it matters or not, but we still report it. What is targeted therapy? So targeted therapy targets the biology of your cancer. And in some cancers, certain signaling pathways or molecular on-off switches that will promote cell growth are abnormally switched on or abnormally switched off. And so targeted therapy aims to turn off cell growth by blocking these signaling pathways. A lot of times we identify these by the test that Julie just mentioned, the next generation sequencing. So here are a few of the targeted therapy drugs that are used for mesothelioma. The most common target is what we call vascular endothelial growth factor. This targets the blood vessels that feed the tumors. And here the drugs are bevacizumab, or Avastin, and ramucirumab, or Cyramza. I've listed here others that are used less commonly. One is ALK, and that's in young patients with peritoneal meso, and there are a number of drugs that can be used. And then there are many new targets, BAP1, NF2, MTAP, mesothelin, many others that other colleagues later today will be talking to you about in clinical trials, and I have several patients here who are on trials targeting various of these endpoints. Now, what do we mean by combination therapy? This is logical. Combination therapy combines two or more types of drug therapies: chemotherapy, immunotherapy, and targeted therapy. For example, chemotherapy and targeted therapy combinations would include pemetrexed, platinum, and bevacizumab, or gemcitabine and ramucirumab. Chemo plus immunotherapy, known with the easier term chemoimmunotherapy combinations, include pemetrexed, platinum, and pembrolizumab, while an immunotherapy and targeted therapy combination used in peritoneal meso is atezolizumab and bevacizumab. So how does the oncologist help you decide which drug treatment is best for you? So first, she looks at what drugs are most likely to work in your situation based on data from patients like you who were enrolled in clinical trials, as well as what other treatments you've already received and how well they worked. If the first treatment worked really well and it lasted a few years, you might go back to it. If the cancer grew on that first treatment, you're definitely going to try something that works very differently. Then we're looking at what key characteristics about your cancer might make one treatment more likely to help you, such as the histologic subtype of your tumor, the chocolate, vanilla, or swirl, as well as your overall health. Do you have other medical conditions that could be made worse with certain drugs, or that could affect how some drugs are processed in your body? So if you've got an autoimmune disease, you've got multiple sclerosis or myasthenia gravis, immunotherapy is probably going to make that worse. You don't want to take it. If your kidneys don't work very well, then you can't take a drug that gets excreted or processed by your kidneys, or it could become too toxic. Some older patients might not be able to handle certain types of drugs. If you've got lots of blood clots, you might not want to take a drug that causes blood clots, things like that. And then just your general overall health and what doctors call your performance status or level of activity. If you're spending all day in bed and on the couch, you're not going to be able to take something really, intense. Whereas if you're, playing tennis on the days when you're not in the clinic, then you're probably able to take a more aggressive treatment. And so it's all of these data that get put together in the discussion that your doctor will then have with you about what treatment the two of you should decide you should get. A few more definitions, and Julie already went through many of these. First line or front line is the first type of cancer drug that you receive. Maintenance is what you take to keep the cancer under control immediately after the initial therapy. Second line is the next type of treatment you receive when the cancer worsens. Neoadjuvant is what you get to shrink the tumor before surgery, and adjuvant is what you get after surgery to prevent the cancer from coming back. So these are the key milestones in drug therapy for mesothelioma, and I'd point you to that first column of the year. So that first study from 2003 that got pemetrexed approved, and that was one led by the MARF founder, Dr. Vogelsang, it then took 13 years from that trial to the next positive trial in mesothelioma. And then look how progress has really accelerated. 2 trials in 2020, 3 trials in 2021, and now 2023 and 2024. So really, over the last few years, progress has escalated, and we really are developing new treatments for this disease. And I'm going to talk about some, but not all of these. So let's talk first about first-line therapy options. You've never gotten treatment before, and you want to know what to do. And so these include pemetrexed and cisplatin, pemetrexed and carboplatin, pemetrexed and cisplatin plus the targeted drug bevacizumab, or pemetrexed and carboplatin plus the targeted drug bevacizumab. So that long-standing benchmark regimen, basically the only thing we had for almost 15 years, was pemetrexed and cisplatin. And this was based on a study done in less than 500 patients who either got a placebo, a dummy pill, a dummy IV with cisplatin, or pemetrexed and cisplatin. And for almost 2 decades, this was the only FDA approved for meso. Now, this is what we call a Kaplan-Meier curve. And if you see a difference between the 2 lines, it means that one thing is better than the other. So don't focus so much on the numbers, but just focus on that white space in between them. And this showed us that the combination therapy was better than one drug alone, and was important because it was the first time that we'd ever seen that something helped patients in mesothelioma. Now, cisplatin was what was used in the FDA study, but carboplatin is way much better tolerated. Cisplatin makes you feel like you got run over by a Mack truck. It can cause ringing in the ears, hearing loss, kidney damage, marked fatigue, nausea. And carboplatin is much better tolerated, is equivalent in activity, and in particular in older patients is more commonly used. Now, what about maintenance after pemetrexed and platinum? So there are 3 different options that can be offered. One shouldn't be. One is pemetrexed, one is gemcitabine, and one is bevacizumab. And so most patients will get 4 to 6 cycles or doses, so once every 3 weeks of pemetrexed and either carboplatin or cisplatin. And then their doctor usually tells them, okay, it's time to take a break. Let's go on to active observation, which is a really scary thing because you want to be doing something for your cancer. And so this was a study that looked at, should you just continue the slightly easier drug to take, the pemetrexed, or should you just go on observation? And this study showed that honestly, it doesn't help to take additional single drug pemetrexed. You're going to do just as well simply going on active observation so you can live your life and play with the grandchildren and do all of those things. And then when you need treatment again, you can get treatment again. So we don't use the maintenance pemetrexed for mesothelioma in general. This was a Dutch study that looked at the drug Gemzar. It's called switch maintenance. So let's switch to a different drug and see if that helps. So this didn't help people live longer. It may have helped keep the disease under control for a little longer, but this wasn't blinded. So the doctors and the patients kind of knew what they were getting. So we're not really sure if this helps or not. Not commonly done in the U.S., but it is done outside of the U.S. Now, the first study that was positive that showed improved results after the original Olympta trial was this trial, the MAPS trial from France. And here patients got pemetrexed, cisplatin, with or without the VEGF inhibitor bevacizumab. So this is the drug that targets the blood vessels that feed the tumors. And so either patients got the chemo, followed by observation, or they got the 3 drugs and then followed by the maintenance of the bevacizumab, the VEGF inhibitor. And here you can see again the difference between the lines, that the combination of the 3 drugs helped keep the disease controlled for longer, what we call an improvement in progression-free survival, as well as helping patients live longer. Now, this is actually because it wasn't designed in the U.S. This combination has never been FDA approved for meso, but insurance companies do pay for it. And one thing that we can see is that the patients who got the the chemo alone actually did better than the patients on the original Vogelsang trial from 2003, even though they got the same treatment. And that's what we call a difference in historical controls, because other treatment aspects actually got better as well. So you can't look at a single unrandomized trial and say, well, patients here did better than patients from 10 years ago, because there are other things that occur. That's why we have to do randomization. Now, what about immunotherapy? So the standard approved first-line immunotherapy are the two drugs, ipilimumab and nivolumab, otherwise known as Opdivo and Yervoy, and they have these wonderful TV ads, lots of sunshine and joy and happiness. All right, so 4 years ago this month, the FDA approved the combination of nivolumab plus ipilimumab as first-line treatment for patients with unresectable pleural meso, the first new drug approval for meso in 17 years. And it's not like we weren't trying. We were doing lots and lots of trials in that interim, but this was really, incredibly exciting. All right. And so this was a trial called the Checkmate 743 trial, and it truly transformed mesothelioma treatment. And so here patients received either the nivolumab and ipilimumab or the pemetrexed with cis or carboplatin, and this was in 600 patients. And here we can see, again, that difference between those two curves, that white space between those two curves that showed that immunotherapy improved survival over chemotherapy. And remember, I talked about the chocolate, vanilla, and swirl. And so if you were epithelioid or vanilla, there was a bit of an improvement with immunotherapy, but not dramatic. If you had the chocolate or swirl, the non-epithelioid, you had this dramatic difference in survival. I illustrated to my patients, like, the epithelioids went from here to here, the non-epithelioids went from here to here. And so it's that difference that really dramatically affected patients for whom in the past we said nothing really works. And so that was incredibly exciting. It more than doubled survival in patients who otherwise had a really bad outlook. Now that I mentioned before the PD-L1 expression, that immune marker. And here the difference was a little bit less. If you didn't have the immune marker, you probably did a little bit better with immunotherapy, but not dramatically. If you did better, but again, not super dramatically, but definitely better. And when we look at the results, again, don't focus so much on numbers here, but what we could see was that the epithelioid, the vanillas, wound up having basically equivalent outcomes to the chocolate and the swirls. And so we really were able to equalize outcomes among patients. What we could see then was that this combination was thought to be appropriate to become the new standard of care. What else did we learn? We learned that patients on immunotherapy felt better for longer than those treated with chemotherapy. And that's because patients on these trials filled out what was called a quality of life assessment or patient-reported outcomes. So those of you who have been on trials, you have to fill out all of those things saying, how are you feeling today? That's how we learn stuff about this. And so immunotherapy kept you feeling better for longer, even with some of its side effects. When we then looked a few years out after the trial, we saw again that patients with the epithelioid and non-epithelioid both still had similar disease control over time. And I think a better way to illustrate it is with this patient. And so these are x-rays or CT scans, and many of you have probably seen these before. Your feet are in my face, you're lying on the table, and you're being sliced like a roast beef. And here, this thing is the tumor. And so one thing you can see, black is air, and that is not good. So look at this patient from July to October. You can already begin to see a change. There's much more black there. And then look at him now. This is almost 10 years later. So when you get immunotherapy, if you have activated your immune system, it can be durable. It can last longer. This isn't every patient, but this guy's really enjoying his grandchildren that he's seen born over these years, and he's living his best life. So that is the best response we can get with immunotherapy. Now, immunotherapy, of course, as I mentioned before, can cause side effects because the immune system is more activated. And in some patients, they even have to stop immune therapy because of these side effects. But if the immune therapy activates your immune system to cause these side effects, it's also attacking your tumor. And so one thing that we've seen is that in patients who have to stop immunotherapy because of side effects, they actually do a bit better. And they do a bit better over a longer period of time because their cancer is still being attacked by the immunotherapy. So placing this trial in context, we saw that this combination really improves outcomes in many patients and is clearly a new standard of care. Now, I mentioned before in the chocolate, and swirl patients, in the sarcomatoid and mixed patients, this really revolutionized outcomes. But in the epithelioids, yes, there was a benefit, but maybe not as great. And so are there other options that might actually benefit those patients even more? And the answer is probably yes. And that is our first-line combination chemoimmunotherapy options. And so we have pembrolizumab, pemetrexed with cis or carboplatin, and atezolizumab, pemetrexed with carboplatin and bevacizumab. And so first there were several what we call phase 2 trials, so single-arm trials just testing the new drug in patients. And 3 out of 3 of them showed good response rates, higher than we would get with chemotherapy, and more durable survival than we might expect with chemotherapy alone. And these are what we call a spider and a waterfall plot. Down is good. That means tumor is shrinking. Down quickly on that spider plot tells you that responses are deep and durable. That waterfall plot, or the one where everything's going down like this, that one again shows you that tumors are shrinking. We saw substantial activity of chemo and immunotherapy in pleural meso. But this maybe again illustrates it even more. So this is a patient of mine from March to June. Just look for the black, and you see a lot less of it in March than you see in June. So chemoimmunotherapy or immunotherapy by itself can produce very rapid and dramatic responses. That patient couldn't walk across to the bathroom to brush his teeth in March. And now he's traveling all over the country and, living his best life. So these data led to a trial called the CCTG IND-227 trial. This was a study that looked at the pemetrexed and cisplatin versus pembrolizumab, pemetrexed and cisplatin. This was a Canadian, French, Italian study. And here we saw a difference in the two arms favoring the experimental arm. Nothing dramatic, because after patients who didn't get the immunotherapy completed their chemotherapy, some of them then crossed over and got immunotherapy, and that meant that the difference in the two outcomes was less. Here we can look at the histology, the epithelioid versus sarcomatoid, and here again the non-epithelioids had a greater difference. Here, exploratory outcomes, looking at the PD-L1 status. Again, perhaps here a benefit greater in those who were negative because you're adding chemotherapy in. But looking at this summary, one important thing that I've highlighted for you in dark blue is that chemoimmunotherapy can almost double the tumor response rate, or how much the tumor shrinks. So that in a patient where what you really want to do is to get significant tumor shrinkage because you want to take them to to surgery, for example, then chemoimmunotherapy might be the better option. And so placing these data in context, when we first saw them presented, we said, this is better, but is it better enough to change the standard of care? breaking news. About a month ago, the FDA approved pembrolizumab with pemetrexed and platinum-based chemotherapy as a new first-line treatment for pleural mesothelioma. And so now we have yet another active treatment option. That was pretty darn exciting. Then there was another study, another combination study called ETOP Beat Meso, and this was led by Sanjay Papat, who had up until recently been a very active member of the Meso Foundation. It's a little hard for him in the UK. And this study looked at the pemetrexed, carboplatin, and the bevacizumab, the drug that targets the blood vessels that feed the tumors, and added in plus or minus the atezolizumab, a drug targeting PD-L1, a very close cousin to the nivolumab or Opdivo. And so here we're looking at chemotherapy, targeted therapy, plus or minus immunotherapy. And here we could see, again, you got to squint a little bit, but you do see a difference between those arms. And while there didn't seem to be much of a difference at all with the chemotherapy in the epithelioid or vanillas, there was definitely a difference in the non-epithelioid patients. By the PD-L1, again, a difference here in those who were PD-L1 positive, the opposite of what we saw in the study I've just presented to you. And here we can see the progression-free survival. The patients had disease control for longer. Now, when we look here, this just summarizes the data that we can see. And placing this trial in context, the problem is that the data have been presented at a scientific conference, but have not yet been published. And we as scientists always want to analyze the data, parse it all out, and make sure we understand everything about it before we make a statement about whether this too is going to move in as a possible approved treatment regimen. So right now we don't know, but we can keep the fingers crossed. Now, how do we treat meso that has worsened on or come back after first-line therapy? And that used to be a much simpler question. When all you had was pemetrexed and carboplatin, you didn't have too many choices. But now that we have more first-line options, we also have more choices for second-line and beyond. So your choice of your second-line agent, it depends on a lot of variables. What you got before. Did you get chemotherapy? Did you get chemotherapy and targeted therapy? Did you get immunotherapy? Did you get chemo or an immunotherapy? It depends on whether you responded and how long you responded to your prior regimen as to whether you're going to treat with the same drugs or switch to something new. If the first treatment worked really well and kept your disease under control for 6 months or more, you might want to go back to the same thing. If your cancer grew right through it, you want to switch gears and try something your cancer's not going to be resistant to. And then there is also the histology. If you've got non-epithelioid versus epithelioid, you might not want to go straight for chemotherapy in a non-epithelioid, for example. So we know with pemetrexed-based chemotherapy that if you retreat with pemetrexed or pemetrexed and a platinum, if it worked for a while before, you can be retreated again, and even a third time if you need to. So if the disease was stable or responding for 6 months or more after you stopped it, it is a reasonable option to retreat. Of course, if there's a clinical trial or if there's other options, you might choose those, but that becomes one thing that you could do. Now, what about if you got immunotherapy? Can you then take pemetrexed platinum as a second line? We do it, but there aren't randomized trials to tell us how much better or not that is. But, that's the other option that you haven't gotten. So another option is the combination of gemcitabine and the targeted drug ramucirumab. And this was an Italian trial that looked at gemcitabine with either a placebo, sugar water, or ramucirumab. And people were actually quite surprised. It kind of flew under the radar when we saw that both epithelioid and non-epithelioid patients gained benefit from this regimen. Now, it was a study that was designed in Italy, not with the FDA, and Cyramza or ramucirumab is not a cheap drug, and so insurance companies will not always approve it, but it is a reasonable option. Now, vinorelbine or navalbine is a drug that isn't used too often in the U.S. because it causes a decent amount of toxicity. But there's an oral version that is used in Europe. And so this was a study that looked at oral vinorelbine. And in the UK, they do a lot of studies with drug versus best supportive care. In the U.S., patients are not as eager to just go on, I'll just watch and wait. But this study demonstrated that indeed giving the oral vinorelbine could improve disease control, but it didn't really affect outcomes. So an option if you lived in the UK. This was a study that was also done in Europe that looked at whether patients got single drug immunotherapy or chemotherapy, which group of patients did better. And then if you got chemotherapy, you could cross over to immunotherapy. And here we saw that actually they offered pretty similar control, but if patients responded, they responded for longer if they got the immunotherapy, and they had a higher tumor response rate with the immunotherapy. So chemo can play a role, but you want to be very selective. This was another study from the UK that looked at immune therapy versus sugar water to see whether that after chemotherapy could provide disease control. And here we saw that indeed it did improve survival over not treating, and it did improve disease control. So a single agent immunotherapy after chemo is reasonable. The MAPS-2 trial looked at either single agent immunotherapy or double agent immunotherapy, and again showed that both offer disease control. It was a non-comparative study, so we don't know if one is better than the other, but it told us that that is a reasonable option. So to summarize the oncologist tools for treatment, over the past few years, I think you'll agree that we have finally begun to make real progress in systemic therapy for meso, with many old and new approaches in our oncology toolkit. We've got chemotherapy, we've got immunotherapy, we've got chemoimmunotherapy. But how do we choose the best regimen for an individual patient? Well, some of these treatments are new enough that we don't have the full answer for every patient, and that's why we continue to do further studies. And of course, far more needs to be done. Research into the biology of the disease continues to uncover new targets, and many clinical trials of novel agents and approaches are ongoing. And with that, I thank you for your attention, and if there's time, I'm happy to answer questions.
I always ask this question, but how much can you assume that any trial can also apply? Should I repeat? How much can you assume that any trial you do for meso applies to all forms of meso, or do you have to have separate trials for pleural and peritoneal and others?
So that's a great question, because as you know, there are far more pleural patients around than there are peritoneal patients. Pleural and peritoneal are similar, but are not biologically identical. In the absence of trials specifically for peritoneal meso, we tend to extrapolate and presume that they are similar. I mean, we have patients in the audience today who have tunica vaginalis meso, 20 new patients a year. There are not going to be randomized 500 patient trials for that disease either. And so to a certain degree, we have to extrapolate. But honestly, for peritoneal, there are now enough patients and enough momentum showing activity of agents that there actually are now trials, even a randomized trial that I presume someone is going to talk about later. And so as we learn more about it and refine more, I think that we'll realize that there are some differences. In the absence of data, we go along with pleural, but we need more data, absolutely.
Side effects from Avastin, is there anything that you make want to stop the drug because you're having Can you
So Avastin or bevacizumab is what we call a VEGF inhibitor. It targets the blood vessels that feed the tumors, to be simplistic. And so patients can develop hypertension, high blood pressure, and if you need one drug or two drugs, that's fine, but if the blood pressure is still not going to be well controlled, that can increase the risk of stroke, and so that needs to be managed and monitored. It can cause something called protein in the urine, which isn't usually a problem at a certain level, but your doctor likely checks your urine each time or every other time just to be sure. It can increase the risk of blood clots, and if you have a blood clot, you're on a blood thinner, it's probably okay. Increase the risk of it can affect wound healing, and so patients with certain types of bowel obstructions, it would be contraindicated. But when patients are on bevacizumab maintenance, for the most part, it is much better tolerated. You don't have that fatigue that you get with the chemotherapy, and it's kind of reassuring to take something that is hopefully keeping that disease under control over time.
Wonderful. Thank you, Dr. Kindler. Moving along, we're going to move on to Dr. Keith Single. He's coming in right over here. He'll be talking about, Dr. Single is also the secretary for our board of directors, and he'll be talking about radiology, correct? Radiation. The mind can only absorb what the derriere can withstand. So if you'd like to stand up for a moment and stretch and in place, feel free to do so while we change the slide deck. And if you're ready to go, it'll be the last presentation about our tools for treatment, and then we'll have a short, minute break. Thank you.
Is one of these the advance button?
It's the button right there. Yep.
There we go. I guess I got to stand at the microphone, don't I? So perhaps more appropriate title. So I'm going to try to get a little bit of familiarity with this group about what radiation can and can't do, and sort of just go over the tools we have, and then maybe at the end talk a little bit about where we're going. So a real life picture of me in clinic every day, as you can see. This is really what it's like. You can see, is there a way to... Here we go. Maybe if I stand to the side. There we go. So we can see me delivering the radiation, and this is one of my favorite physicists, Michelle. She helps to keep me honest. But essentially, I jokingly say we control time and space, but essentially what we do is we use spatial conformality to try to radiate more of what we want and less of what we don't want, and then we use different time factors of how quickly you give the dose, how often you give the dose, how much dose you give, all to sort of modify the normal tissue toxicity. The technology we use, I guess the first question that you always get from patients is, I want the best, what's the best for this and that, what's always the best? And I would argue, if you go into your workshop and say, what's your best tool? Well, if you got a nail, you got a hammer, right? If you got a Phillips screwdriver, is really bad for flathead screws. So, I mean, just like everything, radiation is a tool. There are many different ways to deliver it, many different mechanical contrivances to make the radiation do what we want, and some are better for certain circumstances than others. So the kinds of technology we use to control time and the spatial aspect, we can just sort of shine regular x-rays in a 3D pattern, as you can see on the top, and that is going to try to conform radiation around the site that we're trying to treat. You can see, however, the red is the high dose, green and blue are sort of the medium low dose, and you can see with this particular thing we can't get super conformal, but we can completely avoid, say, treating this lung. If you use something like IMRT, which is just a fancier form of X-ray radiation, where we use this contraption called a multi-leaf collimator to shape the beam in space, we can get more and more conformal around a target, but at the expense of dose that ends up going elsewhere in the body. With the X-ray technology, we can be extremely conformal. So, for example, if you're treating a metastasis to a vertebral body here, you can see we can really wrap that radiation very tightly around the metastasis, missing the esophagus in the front, missing the spinal cord in the back, and do a really good job to get a high dose. Noting, though, when I kind of turn that dose color wash a little lower, that you can see there's still at the expense of some of this exit dose that kind of forms a cloud around things. When you talk about the best, everyone always wants the most expensive, which is proton radiation. Sometimes it does you a favor and sometimes it don't. You can see here what you do with protons is you literally can paint a target with radiation. So you're actually scanning a pencil beam through tissue in 3 dimensions to create this dose distribution and sort of paint the radiation there. This would always be best if you were a block of wood. So if you were perfectly square and I knew exactly what you were made of and nothing could ever change or move, this would be by far the most accurate radiation you can get. And essentially, to the extent to which the area I'm going to radiate doesn't resemble a block of wood, near the diaphragm, lots of motion, different tissue densities. There's lung, there's rib, there's spine bone, there's the heart that's beating in and out of that area. I can't be certain what the protons are going through, and so I can't be as precise. And there are times, many times, where that imprecision actually makes it worse than X-rays. So again, it just depends on the site and it depends on what you're trying to do. What we do in terms of time, many of you may remember relatives getting radiated and things, or friends getting radiated with maybe 30 or 40 or more radiation treatments over 8 or more weeks. And we certainly do that if we're going to treat a very, very large field. So if I'm trying to treat the entire pleura, for example, that has to spread out over time. But what we've really gone to now, more and more so, is these fields that are smaller or small-ish and very, very conformal techniques that sort of minimize the collateral damage, and that allows us to get radiation done in a few treatments over just a few weeks, anywhere from 1 to maybe 5 or 10 treatments. We do a lot of different things to stop patient motion or to try to account for patient motion. So for example, in the chest, we frequently use things like compression belts or breath holding technology to sort of try to freeze the motion as well as we can. And as things have gotten more sophisticated in imaging, which you'll learn about more today, we start using all of these different imaging modalities as we try to plan. So it is frequent now that my patients who are getting radiation might have a PET scan, a regular CAT scan, and even an MRI that are all fused together in the treatment planning system. When we can't freeze the motion, we have to account for it. So we have various technologies. So for example, you can see, is that going to play? Yeah, as you can see there, what we've actually done is we've incorporated the motion of the breathing in the scan itself. So it's a 4-dimensional time-based scan, so I can actually account for where things are going to be during the entirety of the time the beam is on. All right, enough of the silly physics. What do we actually do with this? So again, we come to this with both large and small fields. We can treat the entire external pleura, and this is really critical. With modern technologies, including protons, you can do amazing things. So you can see here is a patient who had a recurrence post-surgery, higher dose where the recurrence is, and a generalized low dose everywhere else. And in fact, this particular patient only had 1 kidney, and with protons, I was able to spare that kidney any dose whatsoever. So nearly miraculous. But one of the big issues you face is many patients have disease that is in the pleura that goes into the lungs. So the lungs are wrapped in pleura, each lobe separately. And if the disease is really bulky in this center part of the chest, you really can't spare anything. And so it really knocks this kind of technology out. And this is something we don't really do that frequently. Much more common is something like this patient here, where you can see a recurrence of meso in the anterior mediastinum as a node, and we're able to use this technology to really wrap the radiation around it very nicely. In peritoneal meso, we don't do that much radiation, really. The main reason is the peritoneum is even larger and more complex than the pleura. The organs occupy an enormous amount of surface area. We had techniques for radiating the whole peritoneum many, many years ago, before chemotherapy really was adequate. And it's just very toxic and very difficult. So most of the time in the peritoneum, we're doing things, especially up by the liver, when you have disease that's sort of growing at the dome of the diaphragm and pushing into the liver, causing pain or problems or issues like that are not necessarily easily amenable to surgery. If the patient doesn't want surgery or isn't able to have surgery, we can do that for sure. Where we do most of our radiation now, though, is what one of my patients once affectionately called radiation whack-a-mole. And so you have area of disease that's progressing or growing on treatment, one area of disease that's causing a specific symptom or a problem by compression of that structure, and now we can use this technology to highly conformally irradiate just the area that bothers you, just the area that's growing. Most of the time now I do this in 5 treatments or less over a week, or maybe at most 10 days. And really can sneak this between therapy cycles because it's so conformal and so precise. And small, the side effects are pretty limited. So, you have a 3-week chemo cycle or a 3-week cycle of whatever drug, and in the 3rd week we just sneak a little bit of radiation into the part that's causing trouble. So we do that quite a lot now. And in fact, I show this is that same patient that had that anterior mediastinal recurrence I was showing you, and you can see here this is over about a 5-year period radiated him 4 or 5 times, and every time chemotherapy sort of let him down, we were able to sort of pick him back up. So it certainly can be extremely powerful for some people with certain patterns of disease. So hopefully that's clear as mud. That's why you go visit your friendly neighborhood radiation oncologist, and I always tell people, don't take a plumber's opinion on your electrical work. So other interesting things we can do with radiation, and Dr. Kindler gave a really nice overview of where we're at with immunotherapy. Radiation seems to go together with immunotherapy like peas and carrots. The immunotherapy, if there's an area of the tumor that's not responding, we can just kill it. But oftentimes we'll have patients who are on immunotherapy progressing at multiple sites. We radiate one site and many other sites again start responding. We reawaken the immune response. So we're actively pursuing, trying to do this more on purpose. And then I guess where we're at now and where we're going. So when this particular patient came to see me, I treated him with this. It was the very early days of our proton center. He came down from New York, had to stay in Philadelphia for about 7 or 8 weeks. The technology to do it took me many, 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 many hours, and the dosimetrist many, many hours of work and planning. Where we're at now, I would probably treat this same patient with more like 2 to 3 weeks of radiation with a very highly conformal field. And we have all sorts of AI and other planning tools that are dramatically shrinking the amount of time it takes to give really fancy radiation. So I can now turn these cases around in a couple of days when it used to take me a couple of weeks to do the planning. Where we're going, what we're hoping to get to is sort of day 0, margin 0 treatment, meaning I image you today, I do the plan while you're laying on the table, taking into account all of the organ motions, shrinking that margin that I have to give, in. And then there's a novel thing, which I don't have too much time to talk about, called flash radiation we're working on, which essentially gives the dose in 10 milliseconds instead of 10 days. It seems like it sneaks one past the goalie. It kills the tumor, and it does about a quarter of the damage to normal tissue. We're studying this actively, trying to work on that technology. As you can imagine, it's pretty hard to do things at that time scale. But if we get there, that same patient would come to Philadelphia, lay on the table, get 3 sessions of flash radiation at 10 milliseconds each, and go home with minimal side effects, which is where I hope we'll go. Well, where I really hope we'll go is we'll cure meso and I can just go home and stop all the shenanigans. But in the interim, that's our interim step. So that, I can stop for questions.
Thank you. That was really informative. Do you know anything about the FAPI scans that are being done in Germany? FAPI, F-A-P-I?
Oh, the FAP PET scans.
Yeah.
So that's actually a really interesting area, and I guess think we have a radiologist, a proper radiologist speaking as well today. But the area of functional imaging is becoming really exciting. You can use a molecular target now, and it's pretty easy to create novel imaging agents that then image for a specific protein. So a PET scan looks at radioactive sugar utilization. It's a pretty gross tool. You can do a similar kind of PET scan by taking a molecular marker like FAP or any of these things that we think are cancer specific, and you can hook a PET isotope onto it and use that to detect, to not only find the cancer, but you can maybe interrogate its biology and start to think about how to treat. So early days of this, for example, in patients with prostate cancer or some neuroendocrine tumors, we can use the PET scan with that molecular target to figure out if their tumor expresses something and what pattern their metastatic disease expresses it in, and then use that same exact tag and put an alpha emitter, which is a cell-killing form of radiation, and actually use that to target radiation all over the body. And then typically I follow that up with kind of spot welding the bigger spots, and we're starting to do that more and more. I think it's a potentially very powerful paradigm.
Dr. Single, over this side of the room.
Yes. Is radiation therapy, or more specifically proton therapy, effective with patients with multiple tumor locations?
Can be, and you know, so one of the difficulties we run into now is that I can irradiate many sites in the body at the same time or over time because of the precision that we can radiate. The question I start asking is, I become very suspicious if I'm radiating you because you got a spot and I got a beam. When am I doing clinical good? Am I erasing, are there, and we do this again, 3 sites that are progressing and everything else is being held in check? That's an easy one. Even easier, one of those sites hurts. And so I know even if I'm not changing your story by radiating that site, I'm making you feel better. Much harder when you have 4 or 5 places where I could radiate, but then you're sort of having to think about what does that mean in the overall course of the disease? Is it likely that's the only places that it is that I could erase? Or am I going to finish that? You're going to get your next scan 2 weeks later and you got 3 more growing. And what we should have done was change the systemic therapy. And that's a really difficult thing to finesse for sure.
Okay. It's on.
I'm always thinking about it. You were talking AI. Now, you guys are running it. Now, do you run a preliminary run with the AI and then review what the AI is doing before it does it and watch it and have, because you hear a lot of things on the media and so forth and everything, and I think these people will be more understanding would appreciate the understanding of how you approach the AI approach to go in there and work with that, and your steps of doing it, and when you do finally to go in, what you're doing. And then with that, when he was talking about the spots, my wife had peritoneal. So you have multiple spots all over the place that you got to hit, and I'm sure you get the higher centimeter ones first and leave the other ones alone. So I'll leave you with that.
So, second question first, because I'll remember it better. We tend not to radiate. I don't radiate in the peritoneum also because surgery can be so effective, and once you've radiated in an area and the tissue planes start fusing together, the surgery gets higher risk. And so, like, up by the dome of the diaphragm is a pretty safe place because, you know, if that little area happens to be fused, the surgeon just doesn't go there, right? But when you're down here, and if I create, you know, scar tissue, and then the surgeon wants to operate, it becomes a big deal. So, and then for the AI, so where we're going now with this, you can imagine, how do you know where the kidneys are on a scan? Well, how does the computer know? Well, I have to tell them where's the kidneys, right? So in the old days, what we had to do on every single slice of a scan and every single modality that we chose, you had to go and circle painstakingly every slice where the kidney was, and every slice where the loops of bowel was, and every slice. So, and the more fancy you wanted to get in your planning, you had to have every organ system outlined in the body, and then you have to go through and say what's tumor and what's not, and that's how the computer identifies things. With the new AI now, in the past couple of years, we don't do much with normal structures at all. It basically takes your CT and it identifies everything in the body, and we tweak it a little bit, but it's about 98%. Now it's fantastic. That gets the tumor miserably wrong. If you've got like hardware in you, it gets confused because it doesn't have enough, you know, previous experience with that kind of hardware. But as we load more and more patients into the databases, it's getting better and better. What we'd hope for eventually is I hardly have to tweak in, and that's where you get that zero time. You lay on the table, you get the scan, the computer's like, here's all the parts. Is that what you want? Tweak it ever so slightly, and now I can, and with the computational power that's coming, instead of the plan taking, you know, 10 years ago, a fancy IMRT plan took hours and hours and hours to calculate. Now it can calculate in minutes. By the time we're getting there, it will calculate in seconds.
One more question, then we have to move on to our next speaker. So, who had a hand up first?
Okay. I'll be quick and we can share. Is this on?
Yes, it is.
Just a general question. I don't understand this. We've got radiation, and then there was this big thing about histotripsy of the University of Michigan, which is using some kind of sound waves to treat. Is there any movement of treating this kind of cancer with sound waves? And what is the benefits or the things? I think I understood you say that treatment with radiation is going to generate some kind of scar tissue. I'm just wondering where that's going.
So there are a number of those kind of modalities that use ultrasound or other technologies, and they do a couple of different things, but roughly they use that to create heat to sort of destroy a tumor. They can be focal. They do still generate significant scar tissue, and like next to something like a big vessel, it's hard to get tissue to heat up because the body is designed to redistribute heat. So it's certainly a thing that can be done, and some of the technology is coming along. Again, it's sort of like a tool that for very specific cases can help. Typically not so much for meso, at least for now.
I just have a question about radiating the same place twice. And my other question would be insurance companies not willing to pay for targeted radiation. Is that a fact? Or
So, yeah, all right. So radiating in the same place. So there is no dose of radiation I can't give there's a dose of radiation, I don't think the juice is worth the squeeze. And so basically, if you radiate an area once, I gave you what I thought was the best compromise between efficacy and side effects. If it grows back there, I can give more, but it's going to have a higher risk. And so you just have to have a good reason to do it. In some cases, especially if you got a good run out of the first one, if something comes back, very rare if it comes back super quick, you know, it doesn't seem like a good idea, but like 3-4 years down the road, you know, or a year or two down the road, something starts growing again, I can easily irradiate it a second time. You know, the side effect risk goes up, but no, I think that's become much more commonplace now. And insurance is the bane of my existence. Radiation costs a lot, and insurance companies don't like paying a lot. And less fancy radiation costs less. So we spend a lot of time arguing and justifying my case, and I try to be judicious. Maybe there is a payment model that might take over in the next couple of years where you basically get a lump sum for radiation from the insurance company to the hospital, and I get to do whatever I want with it. And if I choose to do something exotic and expensive that I lose money on, that's too bad for me. So we're trying to actually negotiate that episode of care model to get that whole issue out of things, but it's been challenging.
Let's show our appreciation for Dr. Single. As Mackenzie pulls up the next deck, I'd like to welcome to the podium Dr. Chong Huang, who will talk to us about pleural surgery. Dr. Huang is from the National Cancer Institute. Please welcome Dr. Huang.
Oh, it's great to be here. Can you guys hear me okay, or am I projecting? This is a very difficult room because it's more long this way. So I'm like, whoop, whoop. All right. I'll try and talk. If you can't hear me, raise your hand and I'll yell. Okay. Well, thank you so much. I very much appreciate being here. I don't know, maybe save the best for last. Who knows? Or we'll see. But I was asked to talk about and explain to you some aspects from the surgical standpoint of what is involved in pleural surgery. Again, I'm from the NIH. It's a pleasure to be here. This talk is for you guys, so if there's, I'm happy to make it interactive as well. We can take questions in real time. And what I plan to do is try and give you, from my perspective, an overview of what is involved with pleural surgery, with a focus on the patients and the folks and the community that is afflicted with this disease, okay? So to start out with, again, what drives surgery is anatomy. So to kind of understand what is entailed in pleural mesothelioma surgery, just give me a second to adjust my screens here. We need to go back to Anatomy 101, and here everybody, I hope, can understand this analogy. We have a fist in a balloon, and the pictorial is meant to represent, if you can think of the fist as your lung, then that will help explain what mesothelial and pleural surfaces, and actually this is analogous for the peritoneal situation as well. And what you'll see is the layer of the balloon that sits directly onto the fist or the lung surface in this case is what we call the visceral pleura. And then the other side of that balloon, the other surface is anatomically what we call the parietal pleural surface. And then that space in between is the intrapleural space. And under normal conditions, in humans, none of us have this space. It's a potential space, but it opens up during surgery and when we deflate the lung. But it's very important to understand because it shows up when mesothelioma is an active disease. Okay, so I hope, and then here analogous to that, then now you'll understand what all of these different pleural membranes and mesothelial surfaces that are named according to their anatomic location in the body. And just for reference, this is the front, the sternum, the rib cage, and then all of the blue areas represent these pleural surfaces that are named according to location. All right, so pleural mesothelioma is a very difficult type of tumor. It's a surface cancer. And since these mesothelial membranes cover many anatomic regions, as I've just defined, mesothelioma can form in the left chest, the right chest, as well as the middle chest, which we call the mediastinum. And then, as some of the earlier speakers alluded to, there's many surfaces in the body. So there's pericardium, which is surrounding the heart. So that's a heart form of mesothelioma. And then there's even down by the testes and the ovaries, there's also mesothelial coverings that form these ultra-rare versions of mesothelioma tumors throughout the body. And what or from the mesothelial lining, these mesothelial cells, the tumor grows there, and it often starts out early on as a flat sheet, a thin sheet, and it gradually spreads outward in a centripetal fashion. And then later in the course, only then does it increase in thickness and really become a huge problem. And unlike many, many solid tumors, like breast cancer, colon cancer, et cetera, mesothelioma has a unique property early on that it grows and it stays confined in whatever anatomic compartment that it originates from. It usually doesn't metastasize very early on, and so that forms some kind of unique conditions that continue to challenge us in terms of treatment and diagnosis. Okay, so here I'm going to show you again, and if you hear several speakers repeat the same thing, it must be true. Okay, so anatomic features of this unique tumor are very characteristic on imaging study scans. So oftentimes when patients show up initially, the basic kind of imaging study is a chest x-ray. Here I show some examples. This is an example of a late stage disease. You can see from a front-on view, the tumor kind of forms this envelope. It's pretty thick. It encases the lung. This is the normal lung, and you can see all that hyperexpanded lung, and here you don't. This is actually more often kind of what a lot of mesotheliomas can appear like on chest x-ray. A lot of our imaging studies don't capture the thickness aspect very well, and so here, in fact, a lot of the imaging underestimates the total tumor volume of mesothelioma at any given time. And here you can see what is actually an advanced case of mesothelioma, but it actually appears, it's misrepresented as appearing quite thin. And then commonly patients will also develop a lot of fluid in that intrapleural space. So you've seen several examples of CT scans, so if you haven't had it explained, I hope this drives home the point. These are all computed tomography or CT and positron emission tomography, PET. These are the most common imaging modalities. They take cross-sections across different sections of your body. And here, because you're looking from the feet to the head, the sides of the images are reversed. So the right side appears on the left screen, and then with the PET, you get the color overlay, and wherever there's color, there's tumor. So that, I'm sure, as patients, you've been shown some aspects of these. And then here, let me show you some unique features from the surgeon standpoint. So these are intraoperative views. And remember that fist in the balloon, so the camera is actually physically inside the intrapleural space, and now you're looking outside. So in one direction, you'll be seeing that parietal pleural layer, and then in the other direction, you'll be seeing the visceral pleural layer, which sits on and invests the lobes of the lung. So here, what allows us to get into the intrapleural space is we collapse the lung intraoperatively, and then we're able to look. These examples here show early stage tumors, so they're quite thin. These are the white plaques, so wherever you see white, those are the mesothelioma deposits. You can imagine over time they'll continue to spread outward and coalesce. On this side, I show some examples of more unfortunate advanced stage tumors. Here, as the tumor thickness increases, you have such tumor volume that normal anatomy is obscured. You can't make out ribs, you can't make out muscle. Here you can sort of see lung. In this example down here, you can't even really appreciate what is lung and not lung because there's a fairly thick investment layer on the visceral pleural surface of the lung at this point. Okay, so that's what it looks like in different versions. Let me show you. So in the crux or the Achilles heel for surgery is that the limitation is that surface cancers like this, we have very inefficient ability to remove all of the disease down to the very last cell. So in essence, what we end up having to deal with is residual microscopic tumor deposits. These are usually left behind, and the surgeon can't see it with the naked eye. And so our general objective anytime that we entertain curative intent surgery is to accomplish removal of all visible or palpable tumors. And this is what we term in the lingo macroscopic complete resection, or an MCR. And that's what a lot of the if you read the clinical trial data papers, that's what the surgical objectives are. And I put here everybody, maybe everybody hasn't removed old wallpaper, but that's sort of the physical constraint of what it takes to peel pleura off of the chest wall. And here I couldn't get a good visualization of what the actual tumor is, but I'm showing you an analogous view of actually this is normal pleura, and even then Mother Nature intends for that pleura to stick onto the chest wall, so even the normal tissue is hard to take off. Okay, so just to give you an appreciation of that. All right, so these are the definitions when you're talking in terms of treatment, and for those that do go to surgery, these are the terms that you'll hear a lot of the surgeons bounce around. And so EPP, extrapleural pneumonectomy, what this entails is removing the entire left or right lung, and at the same time, along with that lung comes all of the surfaces that are connected to the lung in the chest cavity. And when it includes the heart covering or the pericardium and or the diaphragm muscle, all of these surfaces are included in what is termed an extrapleural pneumonectomy. This is the most kind of aggressive surgical intervention that we have for this disease. And every once in a blue moon, still in the modern day, we have to rely on this particular surgical strategy to achieve tumor removal. Now, in contrast, the more common modern-day procedures that are being performed in North America and around the world are what are called pleurectomy decortication procedures, PD for short. And in contrast to the EPP, all of these pleurectomy decortication procedures retain the lung. The primary objective is to strip off the tumor from all of those anatomic surfaces that I've mentioned. When the pericardium or the diaphragm need to be removed in the process, this is the big difference between what we call an extended pleurectomy decortication and the standard pleurectomy decortication. Okay, so now I'm going to move you into, so these are what the definitions are, and then hang on here, my slide is not moving. Oh, there we go. Okay, now in the next series of slides, I'm going to depict what are the major surgical steps that are involved in actually accomplishing the hard work of removing the bulk tumor. So to gain access, typically we use what is called a posterolateral thoracotomy. And this involves making an incision along the side of the chest wall, usually at a low level, 6th, 7th, sometimes the 8th rib space. In the process, we actually physically will cut out a portion of the rib, and this will allow us adequate working room for the surgeon to get their hands in as the ribs are spread with retractors. Okay, and this is commonly what's used as opposed to all those video images that I showed you with the camera, which were more in the early stages of diagnosis as opposed to treatment. Okay, and then kind of what is meant by pleurectomy, again, to strip off that entire parietal pleural layer from the bony rib cage. So here the picture shows typically what happens is that the surgeon will then develop a dissection plane between the ribs and the parietal layer that contains tumor. And then here you can see starting from a small space, gradually there will be enough working space in between as the lung circumferentially gets freed off of the rib cage. The surgeon is able to physically put their entire hands inside. Okay, and then once the tumor casing is freed from the rib walls, i.e. the pleurectomy procedure, Then we have to contend with removing the other side of the tumor and peel that away from the surface of the lung. So here again, just to orient you, the white is the tumor completely encasing the left lung. And then the insert here is meant to illustrate, so we're trying to save the lung, and in the process, peel that orange peel or the banana peel, however you want to think about it, and peel that off. This is that visceral layer of tumor from our short anatomy session just a moment ago. Okay, so this is what a pleurectomy decortication entails. And then here, just to depict and explain, so in contrast then, that extrapleural pneumonectomy, at the end of that procedure, there is no lung. Okay, so pneumonectomy means remove the entire lung and all the lobes. And then in cases where we have to remove, completely remove the pericardium and or the diaphragm surface, we'll reconstruct those to maintain the normal anatomic relationship between organs. And most often that's the material that we insert is Gore-Tex material that we will sew in, and that's what these white patches are. Okay, and again, so the major limitation of leaving microscopic residual tumor deposits is that eventually, if you wait long enough after surgical debulking, tumor will regrow. And this is the Achilles heel. I show here an example from some historical case series that the recurrence rate can be anywhere from 20-30% upwards of 70-80% depending on how long you live after surgery. And typically when it comes back, it'll come back in the same area where we did the original surgery. So now I'm going to depart. So that's all of the surgical stuff. And I want to talk about, so that in line with all the previous speakers, I want to talk about some stuff coming down the pipeline. There is a lot of ongoing research in the background to try and really improve the outcome of surgery, because point counterpoint with all of the other speakers, drugs, radiation, etc., we still haven't come up with a good solution to completely eradicate this thing and make it durable. And so there is many types of new technology that are being applied in the adjuvant setting. So adjuvants are interventions or treatments that are given immediately after the primary treatment. In this case, as a surgical adjuvant, there's a lot of kind of new technologies that are looking at novel ways of killing these microscopic tumor deposits. So here, and then again, I'm not going to get super technical, but I'm just going to show this slide for education purposes. I want to briefly visualize and summarize all of the three kind of grand categories of major surgical adjuvant modalities that are being investigated and or currently being trialed in humans. They are adjuvants that involve installation of direct therapeutics. There's a class of agents that rely on a novel type of delivery vehicle to get either a drug or a brand new kind of agent, anti-cancer agent, to the place where we want it to go, and this is the cancer cell in particular. That's been that is a major limitation of all treatment modalities mentioned today. None of the systemic drugs can specifically target cancer cells. Even the targeted therapies like the bevacizumab, anti-VEGF antibodies don't completely concentrate all of the drug exactly where it needs to go. So that's always the Achilles heel of therapeutics. And then the third kind of grand category of adjuvant therapies is what we term drug-device combinations, and I'll show you what photodynamic therapy is. But all of these are meant to improve the macroscopic effect of surgery to be able to target the microscopic residual cells and completely eradicate the tumor. So here, the most common form of the direct adjuvant type of adjuvant therapy is what we call heated intrathoracic chemotherapy. This basically involves pouring in immediately after surgery into the chest liquid drug chemotherapy. You've heard many of them. Cisplatin is the most common. And then typically the drug is heated to a higher temperature, and then it's circulated around the chest for some duration, typically an hour. And what the idea here is that exposure of the cancer and the chest cavity directly to higher concentrations of the anti-cancer drug may have some beneficial effect to killing off whatever else the surgeon could not see and remove during the surgery. All right, and then PDT, photodynamic therapy, what this technology is, very briefly, is what's injected into the body is a special kind of a photochemical drug that circulates throughout the body, and some of it will eventually concentrate wherever the tumor is. And this is given before surgery. Then the patient undergoes surgery, all the debulking is done, and then during surgery, what the surgeon will do is have access to the device part of this strategy, a handheld laser operating at a specific wavelength, and then what the surgeon does will move this laser wand all over the chest where he thinks that there might be residual tumor. And wherever the specific laser light will shine, it will excite that drug that has now had some time to percolate into the tumor. And once that chemical agent gets excited with the laser light, it will cause a photochemical reaction, and then that's meant to be toxic and will kill all cells. Now, the big disadvantage is that this will kill not only tumor cells, but it'll kill normal cells depending on how much exposure to that laser light that the surgeon decides to give. So this is a difficult technology to consistently apply. And then here, I'm going to finish with the future. This is, a lot of this stuff is in the drug delivery strategy. A lot of this work has not reached human testing or trials yet. A lot of it, most of it, all of it is in animal studies, but it's really, really exciting technology where the delivery agent carriers are engineered and designed to zone in specifically on cancer cells only. And here I'm going to show an example of a gel called a surface fill hydrogel. It's engineered to adhere and mold to the surface kind of topology of the human body, of the tissue where it's applied. And then based on its design, it preferentially will stick a little bit tighter to where cancer cells are. And then during the process of this gel being reabsorbed by the body, it will release special type of focused nanoparticles that can carry new agents that can then kill off all of these invisible residual tumor deposits that we can't see. And that's what meant to be here in this cartoon. You can see is that the big advantage is if you can target all of the cancer cells and don't hurt the normal cells, the toxicity level is much better and the efficacy is much greater. A lot of this technology is highly promising, and we're anticipating in hopefully the near future, some of this technology will be reaching folks like you. All right, and that is it. I hope I finished well under time, and we have plenty of time for questions, but again, so what I hope to have illustrated is that this is a very tough surface cancer, very complex because of the anatomic kind of relationships in the body that we're tasked to remove. But currently the surgical objective is macroscopic complete resection. The most common operations are the pleurectomy decortication procedures that are meant to strip off the tumor and preserve as much normal tissue as possible. And as part of a multi-modality strategy, this may be an effective component of treatment that has a clear benefit for certain highly selected patients. And namely, that's folks with early stage tumors, low volume tumors, young patients with mesothelioma that can undergo the rigors of surgery. I think there may be certainly a subgroup that is hard to argue that surgery doesn't benefit. And then with an eye to the future, many surgical adjuvants with promising technology strategies are in development, and I hope they will be available for those in the audience in the near future. And with that, I'm open for questions. Thank you very much.
We have a couple questions on this side of the room over here. Joe Winter? Okay, we'll start here and we'll go that way.
All right, thank you.
It's on.
Thank you. Just a quick question. So if surgery has been done in the early stage, but after like a while and the tumor came back, can another surgery be done, or it has to go through that normal treatment process?
That's a great question. Can we do redo surgery in, again, highly selected, case by case situations? The general answer is yes. The general answer is we do them, and there's another cohort of people that come back for redo surgery as well. But then the question becomes, and like with all the other kind of modalities you've heard, after the second and third line drug, it gets harder and harder. So after the second and third reoperation surgery, it continues to get harder and harder. Same with radiation. Thank you for that question.
Thank you very much for your presentation. My question revolves around, after a pleural decortication, will the lung fuse to the chest wall?
Yes, in the sense, I'll split hairs with you in terms of definitions, but when we do a pleurectomy decortication and strip off all this tumor, there's a lot of raw surface, and so when the lung re-expands, as with all surgeries, you're going to have after surgery scar tissue and healing effects. So by definition, all things will quote unquote fuse. But that doesn't mean that you can't, to address the first question, it is still possible to reoperate, after a first operation. But in general, yes, that's what it's designed to do, is things will naturally scar in, and the lung will kind of re-stick to the rib cage.
Thank you. Thank you, Dr. Wong.
Thank you so much.
Move right along to our next presenter. Next presenter is Dr. Taylor Ripley. And Dr. Ripley is also the vice chair of our board of directors. And this morning he will be talking to us about a case study. Dr. Ripley is from Baylor College of Medicine, and he's going to discuss dual compartment disease. Please welcome Dr. Ripley.
Thank you. I'm going to talk about I was asked to talk about a very specific topic, and we looked at patients who had disease in the chest and abdomen who underwent surgery. So I'll explain how this came up. I have a lot of disclosures, mainly federal grants or clinical trial supports, but not relevant to this. And so something I want to mention before this is, as you guys are keenly aware, that this is a bad disease, and patients' survivals can be quite limited, as many of y'all suffered with. But if you look back at 2012, the patients who had curative intent surgery in ISLAC, which is an international consortium of centers that puts data together in order to study how patients do, show that about half the patients live 18 months or longer in that group. Recently, all this data has been redone, and so the patients that have been treated since 2012 have been added. And fortunately, what we're seeing in this data that was just published this summer with the same organization but with updated data is that survivals of patients who have undergone surgery is vastly better. As you can see here from stage 1 to 4, the survivals are even approaching 60% at 3 years, which is some of the best data we've seen. This is now online in 5 different publications from the International Association of the Study of Lung Cancer. And similarly, I think this figure shows our data very well. Now, right here, this is a combination of patients who did and did not receive surgery, which is showing, fortunately, patients are doing better than they had in the past. If you look specifically at the patients who had tumor defined at surgery, meaning the stage was done when the tumor was resected, so we have the best data for those patients, the most specimens to analyze, it showed that patients with and without nodal disease still had 3-year survivals of over 40%. And I bring this up today because we are now seeing an improvement in survival of patients with this disease, which is really good news, and hopefully we can get this to continue. So I'm going to talk about something very briefly, and I probably made this a touch too scientific, but when patients have mesothelioma and they come to us and say, should I undergo surgery? A part of what you want to do is, 1, name the disease. It's important to get a biopsy and really be sure what it is, and 2, stage of the disease. And as part of that is if a patient has disease in the chest, as many of y'all know, they are at risk for the disease in the abdomen as well. And so if you look only with imaging, meaning a CT or PET, the ability to predict that disease is low, only 17%. Similarly, if it's absent, there is still a large group of patients who will have disease even though the imaging is negative. And so what we do is we put a laparoscope in the abdomen to look. Given that this disease is based on a surface, using scans to look at that surface is very hard. And so if there's suspicion, directly looking with biopsies is much more accurate than using imaging. And so what we've noted is PET and or CT suggestive peritoneal disease needs biopsies because sometimes it's not positive. Suspicious lesions need pathology because about 50% of lesions in the abdomen could be something else, and often they're nothing. And then diagnostic laparoscopy, meaning put a scope in the abdomen to stage the patient, is important before you do chest surgery. So that led to a question. I adopted this practice years ago of looking in the abdomen to make sure the disease isn't present. So what if it is? What do we do with these patients? And so how do we manage patients with peritoneal disease that's detected during staging when we're considering surgery for the chest? And so I looked at this in a small studies to evaluate the long-term survival of patients undergoing cytoreductive surgery for bicavitary meso, meaning in the chest and abdomen. And are there any indicators of patients who would do well and want to do well? And so I looked at the literature, and this study is a mix of about 50 patients who were studied in New York who had disease operating on one site and then had disease in others. And it shows the overall survivals of the people who were diagnosed at the same time at different times based on the first intervention and the second, but it doesn't actually study patients who had surgery in both compartments. So from what I could tell, there's really no report on this. So we look back at all our data, and we use the data that we collect based on that staging system that I mentioned called International Association for the Study of Lung Cancer in our own institutional data set at Baylor College of Medicine. And we really looked at our data from 2014 to 2021. And by that time, we had evaluated over 400 patients, and 3% noted to have disease in the belly as well as the chest, who ended up undergoing surgery. Most underwent surgery of the chest first, or 13 out of 14, and about half, or 43%, had the approach where you take the lung out, called an extrapleural pneumonectomy, and the other half had one where you took the lining out, which Dr. Hong just discussed. And so the patients were relatively similar. They had different stages based on preoperative imaging, but when you looked at the final pathology, the extent of the disease was relatively similar. The T3 stage, which is the more advanced one we can resect, was about 70% in both. The patients had disease in about a third in the nodes, and that changed or upstaged about double that when we looked even more closely. Most patients who have belly surgery, as some of you in the room know, have required different parts of the belly to be managed, maybe the spleen, maybe the colon, maybe the small bowel. It really is patient specific. And we noted that patients did pretty well. Over half the patients lived almost 3 years after this operation, as you can see here. But interestingly, we looked at the patients who had the lung removed versus the lung not removed, or the EPD versus the EPP, the extrapleural pneumonectomy. And we noticed that the patients who underwent belly surgery after having their lung removed did not do nearly as well as those who underwent belly surgery after having their lungs spared, and that the survivals that we saw were around nearly 5 years with not removing the lung, as opposed to just over a year when it was removed. So, and similarly, the disease recurred more frequently in the patients who had the previous lung removed rather than spared. So what we noted for this very small group of 3% of patients with disease in 2 cavities, long-term survival can be achieved with a very aggressive surgical approach in 2 cavities. Patients undergoing the lung sparing approach seem to have much better outcome compared to those having the lung removal approach, and so that's an approach that we take. And so once again, I want to thank my whole team and all the collaborators we have, which is very extensive. And then I want to thank all of you for joining us today at this meeting, and happy to answer any questions.
Any questions for Dr. Ripley? One right here in front.
Yeah, hello. I'm curious about the Mars 2 study because whenever I've been speaking to my oncologist, there's just, and we spoke to surgeons, and there's just a general reluctance to perform this surgery because they just say that the Mars 2 study just showed no benefit of surgery. And then, you know, it's kind of, where do you go? Do you...
Yeah, I wasn't asked to speak on Mars 2, so I didn't bring that up. Mars 2, for those of you who know, compared surgical resection to chemotherapy alone. It was performed in Britain and showed that patients with chemo did a little bit better than the patients with surgery. The study is interesting, and I really applaud the investigators for being able to randomize and study all the patients, but that study had several flaws. One of the problems was the patients didn't do that well at surgery. 9% actually died postoperatively, which is high, too high. And the other issue, to get into the weeds, is the patients were not randomized at the front of treatment. They received chemotherapy, and those who did well then went on to surgery or more chemotherapy, as opposed to enrolling patients when they present and put them in a strategy of chemo followed by surgery. So that trial design really selected for patients who probably did well on chemo, and that's reflected at the survivals on their chemo arm were higher than any other trial ever seen, and they were actually higher than their predicted survivals that they published in their trials protocol, which was published about 4 years before this one, as their expected outcomes. And similarly, the surgical outcomes are pretty low. The patient survival after surgery is really almost identical to the survival after surgery in the 1990s, when the first series came out, before patient selection was better, before PET scans were even used. And what we see in most of our centers, as well as the international data, is that the survivals are substantially higher in the recent decade as compared to the 1990s. And so I don't think we should throw out surgery at this point. And I think that patients who are treated with chemo only in lieu of surgery may miss an opportunity to remove the disease, but surgery is not the only answer. And it's only an answer for a small percentage of patients. And so it's at least worth a discussion in an appointment with people who can offer it. And it may not be the right option for you.
Question down the far end, Dr. Ripley. Locke, do you need a microphone?
Yeah. Just for people online.
Sure.
Dr. Ripley, thank you, first of all, for your presentation and research. Quick question regarding timing of surgery. Is there any evidence in terms of it being more efficacious, like if you do it early in the disease versus later in the disease? Because it feels like you only have so many bullets in terms of surgery. So when do you pull that trigger?
So I'll preface this in the just to explain for a second. The question is, should patients get neoadjuvant therapy in surgery, or should they go to surgery and then get adjuvant therapy? So chemotherapy is administered essentially 3 ways. It's administered before a surgical resection, after a surgical resection, or it's just administered for disease without surgery part of it. And so before surgery means neoadjuvant, after surgery means adjuvant, or adjuvant means after surgery. So should you get chemo and then surgery, or you should get surgery and chemo for patients who are appropriate? What we know is most patients don't respond to chemotherapy. And if patients get chemotherapy and followed by surgery, the chance of progression is about 33 to 36%. I think the best trial for this is really Andreas Remner's imprint study, in which they enrolled patients to get radiotherapy after surgery, but they gave everybody chemo, then surgery, and then radiotherapy. And about a third of the patients progressed and no longer were surgical candidates. Based on that data, a lot of our programs have adopted surgery up front for at least the patients without nodal or advanced disease. Exactly where you draw that line is a bit hard, and it's changed with Mars 2. And so I think surgical candidate operating up front is still probably the right answer. But the approach I'm taking right now is currently we have a trial, I've called it NEMO, meaning neoadjuvant mesothelioma, in which we give 3 cycles of dual agent immunotherapy or dual agent immunotherapy with chemo, followed by surgery, followed by a year of immunotherapy. So my bias is the patients we've seen with the best survivals, overall studies have had surgery and chemo. The best therapies are mostly immunotherapy, although there's some caveats. And so our clinical trial approach for patients with surgical disease right now is to combine those strategies in a fairly intensive approach where we give it pre-therapy, neoadjuvant, surgery, and then adjuvant for a year. And so even though I think operating up front is important, given the Mars 2 data, given the high recurrence rates, my bias is to put patients on the NEMO trial who are potential surgical candidates right now.
Thank you, Dr. Ripley.
Thank you.
As I explained earlier when we began our time together today, we're running 2 meetings simultaneously. And so we're going to take a bit of a juggle in the schedule right now. We're going to take our break right now. And I would like to limit it to 10 minutes if that's possible. We come back from break in about 10 minutes. Please go to the lounge, use the men's and ladies lounge if you need to do that. Grab your snack, come back in. And then we'll pick up with Dr. Patel right after our break, try to get us back on track. The doctors are speaking in 2 different locations at one time, and Dr. Ripley is actually running right now down the hall to make his next presentation. So we're trying to give them a little bit of a break too, but I appreciate your flexibility, and we'll see you back here at 10:43, something like that. Okay, thank you.
Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick & Fox. We support the mesothelioma community by providing first quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
Hi, I'm Trey Branham. Dean Omar Branham and Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this totally preventable disease.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Get yourself settled, and we'll forge forward. Our next presenter is Dr. Manish Patel from the University of Minnesota, and he'll be talking about immunotherapy versus chemotherapy and frontline treatment. Please welcome Dr. Patel.
Thanks so much. Really appreciate the opportunity to be here to talk to you about, we're talking about immunotherapy versus chemotherapy. And for most of my career, we didn't have a choice. It was kind of just chemotherapy. So we'll kind of go through some of the, through some cases and sort of talk about how we kind of make that call. And unfortunately, it's not a slam dunk that we always use immunotherapy in every patient right off the bat. And so we'll kind of just go through that. So these are my disclosures. And so just we'll sort of review kind of how, as a medical oncologist, how we choose the best treatments, what kind of things how we decide, and then we'll talk about a couple of cases, and briefly, in the context of those cases, review the clinical trial data from Checkmate 743, which established immunotherapy as a standard treatment for mesothelioma. And then there's a new trial that was just presented earlier this year. We'll kind of just discuss how that might influence the treatment landscape. So just basic background, this is probably not news to anybody here, but there are a couple of different subtypes of mesothelioma. And it is fairly important, particularly now in light of what we're going to talk about going forward, that, to really make the distinction between epithelioid and non-epithelioid. And non-epithelioid mesothelioma encompasses two different, so there's like a pure non-epithelioid or sarcomatoid, which is depicted here with these like sort of pointy cells. And then these that are biphasic is kind of a mixture. Those get lumped into non-epithelioid just because the non-epithelioid tend to be the bad actors or the ones that behave poorly. So when we talk about how we make treatment decisions, that does become important, sort of how we classify patients. So just basic oncology principles. When we are sitting in a room with the patient, for the first time, and this is not necessarily specific to mesothelioma, but it is important for patients with mesothelioma as well, is really to establish what is it that we're trying to achieve. So oftentimes in medical oncology, we're thinking along the lines, well, do we think we can cure this patient? Do we think we can't cure this patient? And that really makes a pretty big difference in terms of how we view the treatment options. Because if we can't cure a patient, then we really want to make sure that whatever we're doing is not worse than the actual disease itself. So quality of life becomes something that we talk quite a lot about in patients, with patients. With mesothelioma, as it currently stands, we don't really think that any of our treatments are likely to cure. Now, there are certainly some patients that we can get really good long-term outcomes that sort of feel and act like a cure, but we have to really be very clear with patients that we don't think that the treatment we offer is going to cure, but we can sort of, we can sort of push the boundaries a little bit in some patients, and then some patients we might also think, well, maybe it's better not to really push the boundaries. So we're trying to get a sense from the patient also what they would like to achieve and what we think we can achieve, and try to match those two as best as possible. And of course, when we're thinking about that, we're thinking about what are the risks of treatment, what are the potential benefits, what are the side effects that are going to happen, and then also looking at the individual patient, what are their mitigating factors? So do they have good functional status? Are they otherwise ill from other reasons, other heart disease or other kidney disease that might influence how we might consider treatment? And in the area of immunotherapy, it's very important to know if patients have pre-existing history of autoimmune disease, because that certainly influences the risk. And then we also take into consideration just sort of life circumstances. A lot of patients will tell us that they really want to get to their family's wedding, or their loved ones expecting a baby. They'd really like to be there for that, and so take those things into consideration as we sort of make a treatment plan. So I'm just going to start with a case, and this is a woman that was seen at our center last year. So she's a 70-year-old woman, otherwise pretty healthy. She was a chronic smoker and so has some obstructive lung disease, which doesn't really affect her too much. Has occasionally some wheezing when she does a lot of activity, but otherwise really lives pretty normally, retired, recently retired. She presented with left-sided abdominal pain for about a month. It just wouldn't go away. So initially it was kind of mild, then it was associated with some nausea. She didn't really have a very good appetite and had reported some weight loss. And when we did a scan, we saw that she had this large mass in her left abdomen and a few other nodules scattered about her abdomen. Here is just a representation of the PET scan that was done that shows this large mass here. And this is the CT scan portion of it that shows that mass over there. So that mass was almost 8 centimeters in size. And when she had a biopsy, it showed sarcomatoid or non-epithelioid mesothelioma. So we did have her see a surgeon to see about doing debulking surgery. Because of the sarcomatoid histology, they felt that she was at probably too high of a risk. The extent of the disease was enough that they didn't think that it was really valuable to do surgery in that patient. And so she came to us then to discuss what were our best treatment options. So when we think about the treatment options and we want to sort of ask the question, what are our treatment options? And at the time that we saw her, it was really chemotherapy, which is platinum and pemetrexed chemotherapy, which has been sort of the standard for 21 years, or dual immunotherapy, which is ipilimumab and nivolumab, or Yervoy and Opdivo. So how do we go about thinking about that? So as we were looking, so I just will kind of go over some data and try to keep this relatively high level, but this is the trial that was published back in 2021 that sort of established immunotherapy as the standard of care for mesothelioma. And this is just a schema showing that they randomized a little over 300 patients to receive either a dual immune checkpoint inhibitor, that's nivolumab as an anti-PD-1 antibody, and ipilimumab, which is an anti-CTLA-4 antibody, and we can have a long discussion about what those things mean, but I didn't want to really go into too much about that right now, versus chemotherapy, and this is the standard chemotherapy, platinum or pemetrexed, given once every 3 weeks. And what we were hoping to look at is just to see how did patients do. Their overall survival was the primary outcome, but then also looking at all kinds of secondary outcomes, like how did the patient respond, how long do they respond if they did respond, and then how long if they, once they started treatment, did it take for them to then for it not to work. And then also looking at safety. And I think just noted in the box down there that we excluded patients with autoimmune disease from these studies. So just because of the immunotherapy and the association with autoimmune side effects that we knew about, we didn't want to include patients who had previous autoimmunity, previous organ transplants, and abnormal lung organ function. So all these patients had good heart function, kidney function, et cetera, liver function. So rather than just sort of go through all of the results, I kind of wanted to split it apart. So, half the patients got chemotherapy and half immunotherapy. So I just wanted to kind of go through with you a little bit about what the chemotherapy looked like for these patients, because this is kind of how we think about it in terms of with the individual patients. So the chemotherapy, again, is platinum pemetrexed, or platinum Alimta, which is the standard treatment, as I mentioned. It's given once every 3 weeks. It's all IV chemotherapy, and we give folic acid and B12 shots once every 9 weeks while on treatment to help prevent some of the side effects of the Alimta chemotherapy. And we looked at the outcome so this is from that trial that, the patients who had chemotherapy on average lived about 14 months. But there was a pretty stark difference between epithelioid and non-epithelioid, and this has been pretty much true of all chemotherapy trials in mesothelioma really throughout history, that epithelioid mesothelioma do quite a bit better than non-epithelioid. And with chemotherapy, the median overall survival is really only 8.8 months, whereas it's about 16.5 months for epithelioid mesothelioma. So once you start treatment, on average, patients would stay on treatment without having their disease worsen for about 7 months. But when we look at the imaging, we see the treatment, about 40% of patients on chemotherapy would actually have shrinkage of their disease. If you do have that shrinkage of the tumor initially to start off with, then about that lasts for about 7 months on average. And you can see here that at 2 years after you've started treatment, only 8% of patients who have achieved a response are still getting that chemotherapy with good response, or still having ongoing response. So in other words, the vast majority of patients will have progressed after about 6 or 7 months. And so what's the cost of this? So this is, and I'm not talking about financial cost, I'm talking really more about the side effects. And so honestly speaking, in medical oncology, platinum pemetrexed is one of our easier chemotherapy regimens. It's better tolerated than almost any other thing we do. But you can see that there are still a fair amount of patients that have significant side effects. So you can see that about a third of patients experience nausea. It's not real severe. It doesn't require them to go in the hospital and things like that, but it does occur at a fairly high rate. About a quarter of patients have significant anemia, decreased appetite in about 20% of patients. The severe toxicity is mostly related to the blood counts. And while those are not, so anemia, if you have severe anemia, that can make people very symptomatic. A low white blood cell count in and of itself is usually not very symptomatic. And actually the rate of infections that happen with the chemotherapy is actually relatively low. But also there are some patients that have pretty severe fatigue and nausea and vomiting with the chemotherapy. And I think one thing about chemotherapy is that, if most patients that get chemotherapy will experience some of these side effects at some time or another, and some of these toxicities get worse over time. So particularly fatigue get worse the longer you're on the chemotherapy. So what about immunotherapy? So this is where the things were, a little bit better. So if we look at the median overall survival, and so the immunotherapy again is nivolumab given every 2 weeks, and ipilimumab given every 6 weeks, and then you continue this treatment up to 2 years of therapy. And the median survival there was 18 months, which was better than the chemotherapy, 14 months. Again, you see, though, that here you see that the epithelioid and non-epithelioid seem to do about the same. So the non-epithelioid patients actually get a median overall survival of 18 months. If you remember from a few slides ago, that was the 8.8 months for chemotherapy. And so we see that in the non-epithelioid patients, the immunotherapy is having a pretty big impact on outcomes. I think another thing that is, so the response rate is relatively similar, so 43% for chemo, 40% for immunotherapy. But the duration of response, so if you actually have a response, it lasts longer with immunotherapy. So if you respond, you get a response for about, on average, 11 months. And if you remember, the chemotherapy after 2 years, only 8% of patients are still remaining in response. Here you see with immunotherapy, if you get a response, it usually lasts. So at 2 years, about a third of patients are still having that response to immunotherapy. So it also comes with side effects, and I would say that the side effects now really don't have to do as much with fatigue or with cell counts, but diarrhea is a pretty common one with this particular combination. Still, about 17% have kind of mild diarrhea. 3 to 5% here, so diarrhea and colitis is more severe, clinically significant. Sometimes in these cases have to be hospitalized because of really severe diarrhea. It can cause a skin rash, itchiness, fatigue, but does tend to be mild. The more severe toxicities are relatively uncommon. The unique thing with immunotherapy, of course, is that it works by activating the immune system, and that's great when it works against the cancer, but it also can work against individual patients, and so it can unmask autoimmunity that even wasn't there before. So when you have these immune-related toxicities, it usually responds to steroids, so we give people steroids to counteract it. We usually have to hold the treatment then in that case. If you have an endocrine toxicity, which is autoimmune, so it can affect your thyroid gland, your adrenal gland, pituitary gland, in that case, that effect is almost always permanent. And so in that case, we always have to use replacement hormones. So it's very common to have low thyroid on immunotherapy, and then those patients will have to be on thyroid medication really lifelong. Fortunately, severe autoimmune attack on your organs like the liver, heart, and kidneys are relatively rare in the single digits percentage-wise. But if those things happen, they can be very significant and sometimes life-threatening. And at the end of the day, about 15% of patients have to discontinue treatment because of the toxicity. One very unique thing about immunotherapy, which is kind of interesting, is that even when you stop treatment, oftentimes the effect of it can still last longer. So even in patients if you've had a response to immunotherapy, but then you develop one of these side effects, if we stop treatment, it doesn't necessarily mean that you'll ultimately relapse. Questions so far? Yeah.
Is there a reason that you only do immunotherapy for 2 years? Can you do it longer?
That's a good question. I think you can do it longer, and we have. I think what we have learned is that, just as I said, when you stop treatment, oftentimes it doesn't stop working. And so we've made so a lot of times we think that after you get over to a certain amount of response and you don't see any disease coming back, that there isn't really that much benefit to adding more immunotherapy, and there's only risk, because then you're still exposed to that risk of immune-related toxicity, the immune side effects. Yeah.
Is there a certain number of treatments that you think allow it to continue working, kind of going forward after you've had a toxicity where you have to stop? And then if you do have to stop, like, when do you make a decision potentially to re-challenge somebody to come back on?
Yeah, so that's a great question. I think it's one. I think if a patient has a immune-related toxicity that requires us to stop, there are a few things, like if they're a life-threatening toxicity, we sometimes will say maybe we should not re-challenge. Okay, if it's less than that, but it's still clinically significant, you're in the hospital, felt miserable, then we might say, well, okay, you don't really have any sign of active growing disease. And sometimes when that case, it can be really long-lived, maybe we just keep doing imaging, follow you closely, and we don't re-challenge it until we think that it's clinically necessary.
And the other question about how many treatments you think, like I've had 3 treatments, and I had to stop. Just curious.
Yeah, I think I think when you've had only a few treatments, and then I think we're a little bit more eager to re-challenge, like give you a little bit more time with it, because sometimes it works a little bit better over a longer period of time. But there's not a 100% right or wrong answer there either. I mean, I think it's something we have discussion about. Do we feel like we need to go forward if things are stable? But it's an individual kind of decision, really. Yeah.
If you can't tolerate both of the drugs, do you sometimes re-challenge?
Absolutely. Yeah, absolutely. Yep, absolutely. So, the ipilimumab is the CTLA-4 medicine, and that seems to be much more associated with the immune-related toxicity. And so in a case where somebody has like severe colitis or diarrhea, then we'll sometimes resume, but only with the Nivo. I don't think there's a lot of data in mesothelioma about how well that works in that case, but in melanoma, it's very common, and most patients will continue to receive benefit from the nivolumab. So this is just putting the two things side by side, the chemotherapy and the immunotherapy on the right-hand side. And you can see that overall, when we look at the whole patient population, the survival is better. When you look at epithelioid, it's really not that much better. It's very minimally better. And in fact, if you look at the statistics on this trial, it actually isn't statistically significant in epithelioid patients. In the non-epithelioid patients, it's way better. And so I think it's pretty clear if you have non-epithelioid mesothelioma that we're going to probably talk about doing immunotherapy as our number one option. I think, again, pointed out before, but the duration of response really favors immunotherapy. So sometimes we think about it in the context of a patient. What is your goal? And, if the goal is, sometimes they're not that symptomatic to begin with, and they're looking really long-term, like, this is probably going to be something that may last longer. We'll take a chance by starting the immunotherapy first and saving chemotherapy for later. In somebody who's more symptomatic, they need a response right away in epithelioid histology, then we sometimes think about doing the chemotherapy first. So in our patient, she had a sarcomatoid histology, and we chose to do immunotherapy with ipilimumab and nivolumab. As I mentioned, it clearly showed that it's better than chemotherapy with this histology. She actually had a really great response. So within about 2 months of therapy, her pain was gone. The tumor, I'm not sure how good this projects, but you can see on the left-hand side, this is where we started. And after 4 months on Ipi and Nivo, she had a pretty significant shrinkage of the tumor. It's about a third of the size that when we started. So she did really well for about a year. She only side effect was low thyroid function, and that was something we detected on labs. Wasn't symptomatic. We put her on hormone replacement, and she did fine with that. However, about a year into her treatment, she developed immune-related colitis, so she had pretty severe diarrhea. I think she was didn't have to go into the hospital, but was having like 10 stools a day, so pretty miserable. We gave her steroids, got better. She required interruption of the immunotherapy, and then with discussion with the patient, she really felt bad enough with the diarrhea that wasn't really, and she had no evidence of disease on her scans. So she elected to hold off on any therapy, and she's now been off of therapy for 9 months without any relapse of disease. So in many ways, even though she had this colitis, this was kind of a win for immunotherapy in that it really has kept her disease under control for a long period of time. And for that whole year prior to developing the colitis, she had almost no side effects from the immunotherapy at all. So I'll move on to the next case, which is a slightly different scenario. So this is a 71-year-old man who presented to us with worsening shortness of breath. He had a history of high blood pressure, but otherwise pretty healthy guy, normally pretty active. He really loved to play pickleball, so he played pickleball like 4 days a week. And he didn't really have a lot of symptoms other than the shortness of breath, didn't have any chest pain. No weight loss. Really wanted to get back to playing pickleball, and having to get this fluid drained was really kind of a drag on him. So when he had fluid in his lungs, he really couldn't play and couldn't do those things. But when he got the fluid drained, it actually helped. So he was able to kind of go back and do what the things that he wanted. So at the time, he had a thoracentesis, which is to take the fluid off. He had a biopsy of the pleural nodule that showed an epithelioid mesothelioma. On a PET scan, he did have some lymph nodes enlarged. And if we go back here, you can see this area here in the mediastinum, sort of between the lungs, a lymph node that had lit up. I don't think you can see it over here, but there is also a lymph node in the supraclavicular area, like outside of the chest, that lit up as well. So at that time, he was really wanting to be aggressive with his mesothelioma, was really gung-ho about trying to get surgery. We had talked about the pros and cons of doing a pleurectomy decortication. But the surgeon saw that he had these lymph nodes that were positive and said, well, I think you're in pretty good shape. I think we could do surgery, but I would really like to see, how you'll respond to some treatment, because if you don't respond well, you've got this disease that's outside the lung. The time it takes you to heal up from surgery, things might get out of control. So she sent him over to me to say, let's think about doing some treatment first. So what are we going to choose? I think just the way I've framed this talk, you could probably guess, but we actually chose chemotherapy. So again, he had pure epithelioid histology, not that much worse than immunotherapy in terms of the outcome, really about the same. But he really wanted to get to surgery, and so we thought that gave us the best chance of an early response to treatment. And so we gave him chemotherapy. We could still use immunotherapy later if we wanted to. And we had a lot of discussion about it, the pros and cons of each approach, because yes, from the data that I've showed you, you could choose the other way. But we just sort of thought that because of the epithelioid histology that he'd have a better chance of responding to chemotherapy up front. And so we thought we'd go with that. And he actually did have a really good response to chemotherapy. He tolerated it extremely well, was able to receive all his treatment on time. A little bit of fatigue, but he still continued playing pickleball all throughout the whole time that he was doing it. And he did ultimately then get to so you can see here that his pleural thickening here on the left side of the tumor had gone away, and the lymph nodes also melted away with the chemotherapy. So he ultimately did have a pleurectomy. I think one thing that was interesting, that when we did the pathology after the surgery, they did show biphasic mesothelioma, which is again like a mixed histology, epithelial and non-epithelioid. And this does raise an issue in terms of when we get biopsies, we're getting a little tiny piece of tissue, and sometimes it could miss that there's other parts of it that have the non-epithelioid. So I think had we known biphasic from the beginning, we might have changed our thought process a little bit. So we talked after surgery, again, because of this, should we start immunotherapy now? And we kind of, again, weighed the pros and cons of it. He really was like, well, I just gone through this big surgery. I'm recovering. Again, just want to get myself back on my feet. And so he decided he didn't want to start any active treatment at that time. And so he's actually now 6 months or so after his surgery. His most recent scans didn't show any evidence of any relapse. And then we would probably recommend immunotherapy then if he did ultimately relapse. But he's doing well for now. So just with a few minutes, I think probably over time already, but just with the few minutes I have here, I just want to mention the most recent study that was presented this year at ASCO. This was a trial that was done in Canada and Europe, where they used. So you can imagine that we have some questions about how effective immunotherapy is. We have some questions about chemotherapy, but what about if you do both? And this is really standard treatment for lung cancer now, to do chemotherapy with immunotherapy. The difference here is that with the immunotherapy is pembrolizumab or Keytruda, and it's done by itself, not with a second immunotherapy. So chemotherapy plus pembrolizumab versus just chemotherapy by itself. And the upshot of it is that chemotherapy plus immunotherapy was a little bit better, not by a lot, maybe a little bit disappointing that it was only slightly better. So the overall survival was 17 months in the chemotherapy plus immunotherapy arm versus 16 for the chemotherapy arm. The response rate was pretty astounding, 61% with the combination, which I don't think we've seen that in any clinical trials of mesothelioma to date, and was certainly better than just the chemotherapy by itself. But again, you see this problem, this difference between the non-epithelioid and epithelioid. So again, the non-epithelioid patients did quite a bit better when you got chemotherapy plus immunotherapy compared to just the chemotherapy alone. In the epithelioid mesothelioma, the chemotherapy plus immunotherapy was a little bit better, but really not by very much. And in this trial, the epithelioid patients actually did a little bit better with the chemotherapy than they did in the previous trial. One thing that was what was good, there was no surprising toxicity, but not too surprising that when you combine chemotherapy and immunotherapy, you get the chemotherapy side effects and also some of the immunotherapy side effects. The immunotherapy side effects are a little bit easier with this regimen, and that's because we're not including the ipilimumab, which accounts for a fair bit of the immune-related toxicity. So this was just FDA approved in September. So it's in our one of our treatment options now that we can give to patients. This is just another table, just sort of looking at the three different sort of options: chemotherapy, immunotherapy, and the combination. And you can see again that both with immunotherapy, we see a little bit better results with the non-epithelioid patients compared to chemotherapy, whereas with the epithelioid, they kind of look relatively similar whether you get immunotherapy or not. So in conclusion, I guess we have 3 FDA-approved options for first-line treatment of mesothelioma. I think for non-epithelioid, I've hopefully convinced you all that there isn't really much of a choice. We just do immunotherapy, and that's probably our best option. We don't really know if there are cases that would benefit from chemotherapy, but from the looks of the data, it really doesn't seem that way. So I don't think either chemotherapy plus immunotherapy or the chemotherapy arms are really very good for non-epithelioid. For epithelioid, it's still a little bit of a question mark to me. The efficacy is about the same. There are some patients clearly benefit from immunotherapy. We just have a hard time picking them out. But if you do benefit, it lasts for a really long time. And so it really would be nice for us to be able to pick out the patients who are really going to benefit. And then, whether or not to put the immunotherapy first before chemotherapy is sort of a question mark. And I think this is a thing what we do in oncology is sort of really talk about shared decision making, sitting down with the patient, discussing the data, and discussing the goals, and make a nuanced decision for each individual patient. And I guess in that way, it's really nice to have options. So we have 3 different options, and we can kind of talk through sort of what are the risks and benefits of each approach, and really have a good discussion about what we hope to achieve with either one. So obviously, there's a lot more work to be done. I think we want to identify biomarkers that are more predictive than just the histology. So incorporating genomics where we can, expression patterns. I think a really important question for all of oncology in general is which patients need the ipilimumab, because I think we could avoid a lot of immune-related toxicity if we could avoid the ipilimumab, but there are clearly some patients who don't respond to Keytruda or nivolumab and need the ipilimumab, but we have no clue who those patients are. And that's true of all cancers: lung cancer, melanoma, kidney cancer, what have you. And then I think obviously we want to identify better treatments, better immunotherapies. I myself have been involved in looking at VISTA and B7H3 in terms of new targets for mesothelioma, developing newer treatments, better targeted therapy. So with that, I'll finish. If there are other questions, I can take them now, if we've got time.
I don't see any hands going up. Oh, there's one. No, we can take one question. We really need to get ourselves back on track here.
I'll defer to a patient.
Okay, go ahead.
Is there any reason to think that immunotherapy could be used in the heated interperitoneal context like chemotherapy was?
Well, I think it's. I'm not exactly sure what the rationale would be. Maybe for the the inflammatory kind of thing. I think it could be. I think it obviously would have to be something that would be done in the context of a clinical trial. And there are other strategies that are involved using immunotherapy prior to doing a pleurectomy decortication. There's studies that are ongoing looking at those kind of things as well.
Wonderful. A hand for Dr. Patel.
Thanks so much.
As Mackenzie updates the slide deck, we'd like to welcome up Dr. Chris Strauss from the University of Chicago. It's a tall man coming into the room right here. And Dr. Strauss will be kicking off our diagnosis and reoccurrence monitoring portion of our day, talking about imaging.
I have to turn on the mic, and is it working? Yes. Excellent. I am very grateful to be here. I love doing this talk every year, but I also want to say I hate long rooms like this. So if I turn my head or for some reason people can't hear, please raise your hand. Say something. I rather go over many fewer slides really well and answer questions, so interrupt if something isn't clear or confusing, because that's still a better end result than me just running through 60 slides and everyone going like, what happened? And that's the key. So I'm going to see if I can figure out what next is. I usually do this talk with one of my partners, and he unfortunately couldn't make it, so you'll see his name on a couple things, but I am maybe not. Did it move? Oh, there you go. So this is a quick example. Some of these slides go pretty quickly. Again, don't let that surprise you. They tend to be very duplicative in terms of the topic. But the goal for the next few minutes, what they allow us, is going to be basically imaging. And it's basically what has happened in medical care in the last many decades to really shift how we've taken care of patients in a larger way, and most of that's going to translate into different tests that all of you are familiar with in terms of x-rays, CTs, MRIs, et cetera. And we're going to touch on some of the differences and try to give you a little bit of insight into why one test may be chosen over another at any particular time and why we're doing all of this. But in general, this slide is just to indicate we've been looking in the body for quite some time. This goes back to the Renaissance, and we've been struggling to sort of do more, and obviously imaging in the last 100 years is basically due to this guy. Does anyone know who this is? This is Wilhelm Röntgen, and this is a German who actually sat down and won the first Nobel Prize that was ever handed out for the discovery of X-rays. And this is a cartoon example of his lab where he actually had this new device on the left where it was actually producing what was not known at the time, but later called X-rays. And he discovered that it was sort of impacting and interfering the screen on the other side of his lab, and he kept saying, why is it glowing? What's happening? Something's going on between this funny box and the screen. And he's the one who actually sat down and produced the very first X-ray. And this is it. This is actually Wilhelm Röntgen's wife's hand. It's her right hand, because in Europe they put their wedding ring on the other hand, as we do here in America. And this is done about 110 years ago at this point. I'm losing track, maybe plus minus a year. But this actually is the very first X-ray because they were able to look inside the body, which had never been able to be done before. And then they quickly developed other equipment. This is a very early X-ray experience where you'd sit down and actually have the X-ray tube bulb device here behind the patient, this fluorescent screen in front, and you would, as the radiologist, or who became a radiologist, they hadn't been named yet, would be looking at the front and watching these images as they go by, of course getting exposed and everybody getting exposed. We'll talk about that in a minute. Our equipment has gotten so much better, obviously. 100 years later, this is an example of where we have a technologist, and these are known as radiology techs, not radiologists. We'll get into that if you need to. We have absolutely phenomenal equipment that limits scatter and excess X-rays, so the exposure rates are a fraction of what they used to be, and we are very much every day trying to develop new technology, new advances that minimize exposure to patients, and we're going to touch on that towards the end of my talk as well. So different types of images, it's totally a word pool. Not unlike alphabet soup, we're going to have X-rays, CTs, CAT scans. CTs and CAT scans are the same thing for those who don't know. PET scans and MRIs, and we're going to touch on all of them and some of the differences between them. It's totally a word jumble, but what is it? Really, it's about the Wizard of Oz and what's behind the screen and who's the doctor. That person, that's the radiologist behind the curtain, and I'm going to basically expose them for you, all right? And anybody who's a little bit of a certain age remembers obviously Superman and the whole idea of X-ray vision. This was something that certainly has been discussed and described over the last 100 years. Very first 20 plus years of radioactive materials, everyone thought it was the next breakthrough. People were taking it like morning tonics and discovering, oh, it's not so good for you after all. But we were gonna obviously discuss now really what we're doing, and everything in sort of the next many slides is going to be discussing really the last 50 years. So once we got through sort of some of the early breaks, we learned how to harness it, and we're going to start with X-rays because that's really the beginning of imaging. So a little bit of physics I'm going to try to speed through, and I do apologize if I go a little bit fast. Again, I expect a hand in the air if it's uncomfortable because we're trying to make up a little bit of time here. But overall, radiation comes in numerous different wavelengths. And so you'll hear that term occasionally, and depending on the wavelength determines whether it's really harmful, not harmful, and what it can achieve and accomplish. And so the next 4 slides are gonna be just talking about different types of wavelengths. And I think you can, you can understand and see that the narrow band in the middle right here, that's visible light. That's what we see around us every day. It's what our eyes and our brain are able to detect and evaluate, and that lighthouse is sort of to represent that. Radio waves are way down at the bottom. These are long, slow radio waves, and we will then talk about microwaves, which we all heat up our coffee with, and they're actually longer than light waves. But what we're also going to be dealing with as we jump over infrared, TV remote, is X-rays. And X-rays are shorter, higher energy waves, and gamma rays are the things that Superman in theory and stuff that comes from outer space. So these are the ones that cause damage to our cells, and what we're going to be really focusing on in terms of imaging. So a little bit of physics here, and hopefully again this should be more fun. This is a little bit of comic relief, but okay, I've got an X-ray source that's represented by this little square box on the left. It produces X-rays that are sort of being shot through what this looks like. A Christmas cookie, right? Everyone should recognize that as one of those overly baked Christmas cookies we produce for our parents at some point if you have Christmas in your life. And you put a film here, and actually what do you get? And this is what you get, right? This is an X-ray of what? There's the Christmas cookie. And actually, just to finish it up, that's your Christmas cookie, but that's the patient. This actually wasn't a human. This was actually a dog that actually had sat down and wolfed down the cookie without even chewing it. It helped it shape. And the reason I use this as an example is because I think it captures the basic concept. You've got X-rays that are shooting through the patient, and if more X-rays hit the film that's on the other side, or a digital reader, which is what more modern, what happens is you get blackness. So here on the outer edges, all of the X-rays expose the film. And where there's less X-rays, where there's bone, because it absorbed a lot of the X-rays, or in this case, the Christmas cookie, because it was old, hard, and stale, actually it was dense enough to absorb some of the X-rays, it creates a shadow and an outline, right? That makes sense? All right. So what we're doing is, as radiologists, we're doing this on a large, fancy scale. And so in the next many slides, you're going to hear me talking about that as an example. But we as radiologists interpreting studies, that's the trick, right? We want to basically produce images and or studies that actually allow us to detect normal from abnormal, right? Something that belongs or doesn't belong. And that's going to be the real trick and basic fundamental premise of a radiologist's job. This is what? Anybody, obviously, there you go. So we've got some parents and grandparents in the room. They can't get away from this. Every child who has this loves it, right? And if you ever have a child with a Waldo book or Goldbug or some of the other variants, they are what? Insanely fast, right? You put the book in front of me, like, there it is. And you're like, what? I don't even know what page we're on. You, especially when you're older or not used to it, aren't very good at it. But that's another example of what a radiologist is. A radiologist is trained to identify where's Waldo really fast. And even though we can look through the distractions and the clutter, and we know what to look for. We know that he has striped shirts, he's got glasses, he's got a hat, whatever. And we just sort of, whoop, there he is. And you just get good at it. Now, we want to produce images that allow us to do this. So back to the shadow example. All right, so these light bulbs are basically to represent X-ray sources as an example. And if you're shooting X-rays through this three-dimensional person, and in this case, she is standing obviously with her arms out or with holding different pieces of fruit, depending on the direction of the X-rays, right? The shadow that actually is generated will identify, say, the pineapple, but you can't see the banana, and vice versa in the other direction. So this is my way of explaining to the group that radiology isn't just a single image. It's not just black and white, one shot. We often have to do numerous tests or many pictures within the same test to help three-dimensionalize and understand what we're looking at. So we're able to, in our minds, say, this is normal and this is abnormal. Is everyone tracking so far? Am I going too quickly? Great, all right. Am I going too slow? Maybe too. All right, so this is a standard chest radiograph, 2 views, standard. So when you sit there, you're like, why are they taking a second view? I'm too tired. Well, we want that second view because one view really isn't enough. It's always, one view is no views in our mantra. We always want at least 2 views, or preferably CTs and PET scans, and we'll talk about those in a minute. But in this particular case, we're going to talk about different densities. I'm going to try to speed through this a little bit because it's not really super important, but there are 5 main groupings of densities on this image. And that means they're clustered information that we have to deter. We talked about how air is black because there's nothing absorbing the x-rays. It just shoots all the way through the patient, hits the film, and there's an example of the lungs. And there's very little information and very little body tissue for x-rays to be absorbed, as opposed to fat, soft tissue, bone, and metal, metal being the marker up here where almost all the x-rays are absorbed. So all of our information is going to be designated as one of these 5 different categories on a chest x-ray. All right? And it's the difference between one group relative to the other that gives us edges, contours, and shapes. And that's what's going to let us say abnormal, normal. And this is where we get really good. So now we'll go back to another fun thing. Okay, group, what is this? Everyone, or at least many of you knew that, right? There was no debate. Why? You recognize it. That's a great answer, honestly. I know what it is. Well, that's the same thing, right? We know what the heart, we know what the brain, we know what these things look like when you're really good at it and you have lots of years of experience. So you want somebody who's really good at it as opposed to somebody who's just sort of getting used to it. But in general, this baseball bat, there are lots of additional pieces of information. You're using the shape, you're using the density towards the end. You know that it tapers towards the handle. If you actually look carefully, it gets thinner towards the edge, so you can sense that it's fatter and it's round, right, because of the density differences. You can actually see the grain of the wood running through it if you really sort of get your nose into it. And all this information are examples of what we do with radiology and images to also help interpret. So we're actually using more than what you might see initially. And for those who are actually baseball fans and Chicago, this was actually one of Sammy Sosa's bats. If you remember correctly, and somebody just groaned, there was an incident where he had a corked bat. And so guess who got called? I got called and imaged all of his bats at 3 in the morning with a CT scanner to make sure that they weren't corked, which of course none of them were, we all knew that. And we just like, they gave me new bats. I'm sure they weren't the ones they was using, who knows? But that was bat number 4. So I use it as an example. So CT scans is really where I want to spend a little more time because that's what you're getting done predominantly. And CAT scans or CT scans, again, synonymous terms, is basically x-rays and x-ray images, so like the one you see here on the left, turned into slices and images that are very, very numerous. And we're going to be looking at the whole body somewhat like a loaf of bread, and I'm going to go into a couple examples. All right, so how does this done? It's numerous slices, and when I was much younger and starting out, our CT scanners were super slow, and it would take 5 seconds to get each picture, and they had to hold their breath. And now we can do the entire body top to toe in less than just 3 or 4 seconds. The scanners and our equipment has transformed immensely over the last several decades, and it's incredible what we're able to do and reconstruct, et cetera. And we'll give you some examples. But overall, what we're doing is we're 3-dimensionalizing the body tissues when the prior examples in the x-ray, which I showed you, is 2-dimensional, right? It's flattened, everything's superimposed on each other. You get good at differentiating something that may be on top versus something that's separate. CT helps us say, oh no, there's a little tiny dot in here that was overlapped by a rib and we didn't see it on the other. And it gets a much more sensitivity and what we call accuracy in terms of our imaging. The way that works is that we actually, inside the machine, there's an x-ray source, there's a huge donut of detectors, and actuality, there's an arc of detectors, and sometimes you'll hear them say it's a 240, whatever, that number you hear after the scanner is the number of detectors. And what it is it's spinning very fast, and that's what allows us to do imaging of a patient as the table moves like a corkscrew. They're going through and they're getting pictures, thousands and thousands every nanosecond, and we reconstruct all those images into pictures. All right, so back to our bat. I know I'm jumping back and forth. Basically, we cut through the bat. If it's three-dimensional, right, we know it's going to be round, right, because the bat is round. Same with if it's cut obliquely versus length, etc. These are things that we are doing in our head when we're interpreting chest x-rays and chest CTs. In this particular case, I take with my students, I actually took the treasure box, put it into the CT scanner with a whole bunch of stuff from my desk, my secretaries, etc., and I ran it through the scanner. And for many years, before they outlawed it, I would bring a bottle of wine to my medical students and say, okay, everyone, you've got 24 hours, make a list of everything you can identify in this scan. And it was a great sort of fun game, but in reality for them, they actually sat down and had to sort of identify different items. And you can identify one too. If I sat down and said, where's the slinky? Where would you say the slinky was? Which quadrant? B, very good. You know what a slinky looks like. It's metal and it has a shape, and we'll get into that another point. So we basically will slice up scanners, slice up images like a bread loaf, and we can look at things. You can see like a vase with a potpourri and a pine cone. That was off my secretary's desk. And then we could also look at different things like, ooh, there's that, and change the shape and or direction. We can reformat images. That's manipulating them after the fact, and there's a cat, hence it's a CAT scan. That's a joke, you're supposed to laugh. But that's what we're doing in reality. Now notice only the first time, this is the first patient I'm actually showing you. This is mesothelioma. And the reason I wanted to go through those first many slides is to sort of really launch you into thinking of how we look at the images as opposed to just looking at them and saying, yes, no, black, white, here's a number. It's not that simple. There's an art to interpreting scans. It will be different. I will look at the same scan a week apart, and whether I had coffee in that morning or had a fight with my mother that night or whatever, it can interpret. It can infect your interpretation. Obviously, those are really good, and those who are more experienced, there's a lot less of that. You know how to manage yourself, and you stop working. I mean, I know radiologists that say, not today, I need an hour, I'm gone. I need to go work out. And we learn how to optimize our interpretation skills. And that's one of the main reasons why radiologists are really the best at this, because we train ourselves, and we actually study not only how to make great images, which we do, interpret great images, which we do, but we actually are studying how the brain actually interprets the dots and the data that your eyes are actually sending to your brain. It's all part of our field in terms of trying to optimize and not become victim of bias and other things that we know how to bypass because we've trained ourselves to. That makes sense? So in this case, image like a whole body here, we look at it axially, that's cross-cut. We look at it cut like vertically and from the side, and these are called axial, coronal, and sagittal images. Don't let those terms bother you. Just know that we're looking at things and three-dimensionalizing what is a very, very complex, difficult tumor. And that's what makes meso so special, a very misused term, but the bottom line is most tumors, especially like lung cancer, there'll be a dot, a small focus that grows. It grows like into a small blueberry, into a cherry, into a walnut, right? It just grows out bigger, might be up against something, but it's round and it has sort of that shape. Mesothelioma is thin and filmy at first. It grows in predominantly, if it's pleural mesothelioma, it's thin and it grows in the space around the lung and the lining of it. And so as it grows and expands, it gets thicker and lumpy, but it can go up and down, and it sort of hides against all these other structures that can be very hard to follow and track, and hence why we really specialize our efforts in terms of interpreting them, and we'll go into that as well. But these red arrows of the next 3 slides are actually identifying areas of tumor as opposed to fluid and effusions and other things that can grow into the chest wall, it can grow into the bones, it will grow through the diaphragm here, and invade other compartments within the body, and all these things are part of what we're looking for and trained to look for on a continuous serial basis. And that's another reason why you tend to get scans. I have a feeling I'm talking to an audience that knows your scan every 6 weeks, every 2 weeks, or 2 months, or whatever. You got a timing. Stick to it, because it's those serial images that are equally important for us to detect, not just a single example and not a single study. all right? The other thing that's also really helpful is get it done at the best possible place. That may not be the place next door or the most convenient. You want to have your scans preferably done by the place, in the same place, so they have them, all the images, and they are doing the same routine over and over. They're much more likely to pick up stuff as they go forward. So we'll get questions in a minute. So as we're going through report, I'll just be really fast. We compartmentalize our reports. I think it's pretty self-explanatory. It helps our doctors, both interpretation and in terms of our referring physicians, to fully appreciate and find the information as they need to. So you'll see different things in different sections. Though that shouldn't scare you, but it should also be something you see. If you see a report that does not have sectioned and or reports that have been optimized in a structured way, find me. I want to know where this is, because get your scans with me or something. Get your scans with somebody else. This is standard practice in this day and age. Positron, I'm going to jump a little bit towards PET imaging next. Anyone had PET scans at this point? A couple? Okay. Yeah, there you go. What's different about PET scanning? X-rays we talked about, CTs, which are a form of X-rays, just done with lots of computers and lots of images. PET scanning is where we're actually injecting you, and those in the room know, with radioactive glucose. And that actually circulates through the body. We image you a period later, usually about 1 or 2 hours later, as it goes around to the different tissues. And we've discovered that this glucose goes to tumors along with infections and a lot of other things. It's not very specific, but it goes to tissues that are chewing through glucose very fast. And that tends to be an earmark and quality of tumors versus regular tissues. So it helps us identify really subtle areas where we might not have otherwise been able to see it on, say, a chest or abdomen CT in particular. So these are examples of PET scanning and lymph nodes that are sort of outside the field and looking at the whole body. PET scans basically then are a form of imaging function as opposed to the form and the shapes of the organs and the tissues. And that's why it can be really special. PET scans are technically is just looking at those little dots, and that's actually the scan, but you're used to the one I just showed you with the orange on it. Those are actually combined images with a CT that's done in combination with the PET scan simultaneously, and we merge and overlay the images on top of each other so that we have the benefit of the CAT scan knowledge, i.e. the bones and the heart and the solid organs. So when we see, in this case, an orange dot, we can say here it is relative to these other structures. All right, but technically the PET scan is the orange only, not with the other stuff. And so you have to have, again, good quality scanning equipment that allows you to do that sort of thing. This is an example of a glucose. We just replace it with radioactive fluorine, and most importantly, and we'll get into the physics, why it works. So I can get into it if anyone has a question. MRI is the other thing you might have had done that's certainly a more advanced, that really came on board about 30 some years ago. It's actually where we use magnetic qualities of tissues. Okay, every atom, every structure in your body is made up of atoms, and those atoms have a polarity to them. And if we put you into a huge magnet, and that's what an MRI is basically a big magnet, and this is to pretend to be a magnet here. We're doing is we're taking all of those atoms in your body and we're putting them into a single direction. It forces them to line up with the polarity of the magnet. And then when we turn it off or change the strengths of the magnet, we're getting to so that it's sort of beyond this particular talk. But what happens is the atom itself goes what we call rings down and goes back to its standard state. And that change from polarized into single direction to standard normal state is called ring down. And actually, it's because we listen to it. We have very special antenna, essentially, that are in these MRI scanners as they're ringing down like bells or like bottles that you would sit there and look at. And we're able to turn those into images. And it's extremely good and effective at looking at soft tissues. It's not good at looking at bone. It's not really great at fat and a few other things, but looking at things like the brain and the muscles and the soft tissues, which you remember on the X-rays and on the CT, they all sort of looked like the same blurry level of gray. There was not a lot of differentiation in those tissues, and this is our way of looking at really good differentiation of soft tissues. And in this particular case, that's a side shot of a brain. Here's the back of the brain, spinal cord. These are the vertebrae with bone marrow. And here's an example of a tumor that's growing and started within a vertebral body, growing out. And MRI is just the best way for us to capture where's it going, what tissues is it impacting. In this particular case, you can see it engulfing and disrupting the nerves that are coming off of the spinal cord that were feeding the person's lower chest and the like, and it accounted for symptoms, et cetera. And this is, again, what we're doing. We're often taking the patient's presentation, we're doing imaging, trying to find a cause and underlying result, but more importantly, we're tracking and able to look at these scans over a period of time so we can actually make sure that we give the physician, the referring physician, quality information to say, not only this is what it is, here's a diagnosis or potential series or short list of diagnoses, but more importantly, is your treatment working and where the patient is going from then on. Tumor response is actually then the next step. And how am I on time? I'm doing well. Okay, good. Oh no, I heard that. Thank you. I got my hand signal. We're getting nearing the end. All right. The tumor response then is really the big issue with you guys, is that we're actually trying to really evaluate the size with CT and the response and change over time. So the serial images, hence being done at the same institution time and time again for consistency and clarity, is really going to be key. All right, we'll talk about different protocols and response criteria. It varies tremendously if you're on special protocols, special research projects, or depending on who your physicians are. But on the whole, the concept is the same. We're just looking for differences as over time. We look at and measure different tissues. I'm going to jump over this, but it's really, for mesothelioma in particular, thickness at 6 different locations. We're actually going to be adjusting this very soon. We have a paper coming out, also the 9th version. We're always trying to revise our imaging characteristics so that we're able to track across the entire country and world in a similar fashion so we can actually use data and combine data for research purposes. And you're going to be hearing about that hopefully in about a year. Response then basically gets 30 or 20%. You might hear these numbers when you talk to your oncologist, but we're just looking for progression, stability, or the like. And these graphs are just identifying that. You'll hear about different numbers. Different drugs have different potential, and you'll hear that mostly from your oncologist. We use contrast in particular to help make our images more sensitive, to actually subtly looking at edges so we can actually get more accurate measurements scan to scan. So if they sit there and say, please let us do an IV, and you have no contrast allergies or kidney problems to prevent it, the answer is yes. I know it's an IV, it hurts, it's not fun, but it really makes something that's blurry, fuzzy into something much sharper and distinctive, and we're more likely to find things like lymph nodes and other smaller areas of involvement which we might not otherwise have seen. Radiation exposure, my last 3 slides, and I just wanted to touch on that because I sort of drill down to one of my most commonly asked questions, and that is, I get all these scans, am I just making things worse? Okay, and I want to reassure everybody in the audience, the answer is no, not likely. What we have in front of you is a graph. The image on, the axis on your right, this is the risk of cancer, essentially, i.e. the likelihood of developing a cancer with exposure of radiation versus age, which is across the bottom. And if you actually look, if we expose babies and young children and teenagers to high levels of radiation, the risk of disease is much higher, by the way, for women than it is for men. But as you age, and especially when you start getting towards 50 and onward, that risk is just nominal. We're talking just 1-2%. I mean, it's not much. And the risk of developing a complicating issue related to the radiation is just minuscule compared to all the benefits that you're actually going to get from the imaging. So it's a trade-off. Nothing's perfect. But in this particular case, we're all at this end of the scale. We're not at this end. So keep your babies and young women, and especially your teenage girls, out of the scanners. But that has to do on the difference, by the way, between men and women is almost entirely breast tissue. Breast tissue is very sensitive to radiation relative to other body parts. So that's the piece we need to keep out and try not to scan. So that's us at that end of the scanner. This is my I always love The Simpsons. But basically, a couple examples in terms of how much radiation you're actually getting with a CT scan. I would sit there and I just want you to know, natural background, just living your life, right? And it's worse than if you lived in Colorado than if you lived in, say, Massachusetts, actually, places with mountains tend to have more radon and other things that are coming out of the dirt. But on the whole, the amount of background varies a little bit, but you can see it's not that different. And I just give you a couple of examples. Smoking cigarettes, I mean, literally just a few cigarettes a day is more than equivalent to a scanner. Or flying to literally not even to another continent, just talking across the country is basically the equivalent of a scan. And we do that every day without thinking about it. So here's some examples, and I always like 40 tablespoons of peanut butter. Who has not eaten 40 tablespoons of peanut butter? But that essentially is, you're exposing yourself to radiation, but people don't think about it, all right? I'm just trying to give you some ideas that the imaging source of radiation is relatively small. So on that, I hope we're getting a little bit closer on schedule, but I definitely want to entertain some questions because I have a feeling I've generated a few.
We can take a couple of questions.
Yeah, and let's start on this end because I've been very unfair to you guys. Okay.
And you can feel free to stand up if it's more comfortable.
I have a question about PET scans and like previous pleurodesis, so like a 30 years ago pleurodesis, and then that lighting up on a PET scan for meso. So would you recommend like tracking everything through CT, or would you go with the PET scans?
I would basically probably a combination. I wouldn't say that it's all one or the other. You're going to be followed with CT. Invariably, because it's easiest, it's relatively simplest, it's not as involved. PET scan will certainly give you a certain amount of confidence that there's nothing hiding potentially in a lot of scar tissue, depending on the pleurodesis. Some leave you look sort of like the way you started, and others you look like someone's been in there mucking around. And so those can be a little bit harder to be confident there isn't something lurking in a corner, and the PET scan may help you there. But overall, it's really going to come down to serial imaging and looking for change over time.
Okay.
Great question. There's one more right next to you.
One more?
Yeah. And I'll stick around a little bit after if need be.
With the amount of data you're looking at with all these scans, how much of a role is artificial intelligence playing looking at this?
I should have assumed I was going to get this one. The answer there is AI is our friend. Radiologists have been using AI. I started working with the first AI program 30 years ago. We actually invented it at the University of Chicago. It's the top breast imaging, it's now a company, that actually can go off and assist us to be more sensitive and more accurate in our performance in doing screeners. So it's not something to be scared of. It will not replace us. There is so much complexity, and I think the average use of AI and the way you see it in social media and stuff, obviously it has a huge play, but when it comes to medicine, it's just amplified 10 times, and we're using it as a tool to make the radiologist more effective, efficient, and basically get through what used to be 10 images in an hour. Now we're actually having to look at 1,000 images in the same amount of time as 20 years ago. We have so much data to look at because our equipment has gotten so much better and fancier, and we're doing more studies. But we, as the number of radiologists, obviously stayed pretty similar. And AI is going to be a help. It's going to be the next real advancement in the next 10 years in allowing us to become and maintain our effectiveness as interpreters. If that's sort of a quick answer.
Okay, one more, but really have to.
I'll catch you later.
Will be available after as well.
How often do you factor in the volume rather than a slice?
That's a great question, and again, the whole room, I'm sure you've now heard imaging, volume versus non-volume. And there is a big debate over really what is most accurate. And I will say that on the whole, you are talking with somebody at one end of the spectrum. I have to identify, I'm not a pro-volume or anti-volume. I'm just saying it's not the answer or end-all be-all. I want to re-emphasize what I feel, and again, this is me, needs to be discussed is change from scan A to scan B, your baseline through a series of protocols. Is it working? Is it not working? That's really what your oncologist needs. The actual volume, and people get hung up on it for a good reason, because there's some earlier studies that showed this treatment was effective when it's under 500 milliliters versus if it's bigger or more, et cetera. And surgeons, of course, like to quantify, but it's part of their job. but in reality, it probably isn't. There isn't this stern cutoff. It's like, we had 550. Are you in a different category? The answer is no. It's really a question of identifying more as we go forward. Genetics, where is it located? Are critical structures involved, et cetera? Can we do a surgical intervention, whether it's palliative, curative, or whatever? I mean, those are all sort of variants in the same scheme. But what can be given systemically, if we're at that stage, which not infrequently you are with meso, and will it be effective? And getting you targeted into the right category, which I know is Hetty Kindler's talking, several talks you've already had, right? Immunotherapy versus other, et cetera. But from an imaging perspective, it's really about change, no change. Can I, at the earliest possible time, maybe even 3 weeks later, is this working? Keep giving it. And obviously, hopefully you don't have repercussions or complications related to it, but stay on course. Or no change, and if we don't, we've proven that you need to switch to something else, right? We got 3 other choices, let's use the other one. The key is to individualize the care, not lump you into a broad category which you may or may not fit. Does that translate? Okay.
Thank you, Dr. Strauss. Applause, please. Next, I'd like to invite up Dr. Andrea Wolf from Mount Sinai to talk to us about biopsies.
Oh, do you want to use this? I don't know. I think it's either or.
Okay. If we were to both use this, I'm guessing it would go lower for me. It's usually a safe bet. Good morning to everyone, and thank you. Thank you to Julie and to the leadership and the participants in MARF, and especially to those of you attending the conference in today's session. So I'm here to talk to you about the diagnosis of pleural mesothelioma. And to cut it short, diagnosis requires biopsy, and that's why this talk is about biopsy. As we surgeons like to say, tissue is the issue, and we'll see if the pathologists agree, but I suspect based on these pictures alone that that is the case. Just trying to figure out. There's the pointer. So diagnosis requires biopsy because biopsy is what distinguishes cancer from non-cancer. And patients often ask me if the imaging, as just discussed by Dr. Strauss, why isn't that enough to tell whether I have cancer or not? And it's just plain not. There are too many things that masquerade. Importantly, in pleural mesothelioma, we need to distinguish a primary cancer of the pleura. That's what pleural mesothelioma is, from cancers that spread from other organs to the pleura, which is actually stage 4 or metastatic cancer. And that's one of the challenges to our pathologists, but requires tissue. Tissue and biopsy are also required to figure out the cell type, epithelioid versus sarcomatoid versus biphasic, and some rarer entities. They behave differently, they respond differently to treatment, and it's important for individualizing care. And as testing becomes more sophisticated, biomarkers and next generation sequencing and protein and genetic expression are all becoming relevant for treatment and patients, and are helping patients survive longer, which is the ultimate goal. So your perspective on how to biopsy or what to biopsy sort of depends on who you are. The radiologist might say something different than the surgeon, might say something different than the pathologist. But really the one that matters most is the patient. And if I were the patient, I would want the biopsy that is most likely to yield an answer and be most likely to be successful with the least risk. And I generally think about that in terms of invasiveness. So from least invasive to most invasive, the biopsies can be of the pleural fluid. So often patients will come in with a pleural effusion or fluid between the chest, the rib cage, and the lung itself. And some information may be obtained from that fluid, or a needle biopsy of the tumor, or an incisional biopsy. And so we'll talk about those. So the pleural fluid, this is actually a Wikipedia diagram that I thought was pretty good. There's amazing what you can learn. The chest wall and the lung, that space in between is the pleural space. And in healthy patients, that is a non-existent space. But if fluid or anything else accumulates in there, that becomes a pleural space. And when that's fluid, it's called a pleural effusion. And that can get analyzed. A lot of times our pleural mesothelioma patients present with a recurrent pleural effusion. And many people might have that story where it's been drained and analyzed. Unfortunately, about 60% of the time, it'll come back benign, even if there's cancer. And so the sensitivity or the likelihood that the test will show cancer if someone has cancer is pretty low. And so then there's the needle biopsy. That's a little more invasive. That's actually biopsying the tissue. And pleural mesothelioma is a pleural-based disease, which is generally the outside, as we saw in Dr. Strauss's pictures, the sort of outside of the lung and very close to the skin. It lends itself to a percutaneous or skin-accessed biopsy, image-guided, ultrasound or CAT scan, and that can be done with a tiny needle and a little few cells aspirated called a fine needle aspirate, and that gives cytology, which is similar. It has some limitations in what that can show, or a slightly bigger needle, but still done under local, even without sedation, can give tissue. And kind of old school teaching was that the architecture of kind of the tissue itself is actually important for a lot of cancers. And in fact, this is one of my patients who has the patient's on his belly. And so this is the left side of the chest, and this is an area of nodularity that was suspicious for mesothelioma. And it was accessed by the radiologist under some local here. This was not painful for this patient. The nice thing about and then we got surgical pathology. We got actual tissue from that. He was actually enrolled in a clinical trial of mine in which we analyzed that tissue, and then we used that same needle to inject poly-ICLC. It's a protein-based vaccine that we're finding stimulates the immune system. So patients 2 to 4 weeks before surgery underwent biopsy and then injection of this vaccine. We enrolled and closed accrual with 19 patients, which completed the study. It was safe. Some of them had fever for about 24 hours, but short of that, very few symptoms. And what we're finding now that we have analyzed some of the earlier patients from 4 years ago is that this seemed to turn the tumors on. So we're looking at this in the lab, and it has converted the tumor microenvironment to a more immune active environment, and they seem to be more responsive to additional therapies down the line. Then we come to this sort of most invasive form of biopsy, and that's an incisional biopsy. So these can be small incisions, but that's required and gets larger samples of tissue, which by definition, by sampling alone, are more likely to give you an answer. And surgically, we consider pleuroscopy a procedure with a tiny incision that we can actually stick a mediastinoscope, which is this rigid scope through, and you directly access the extrapleural space where that tissue is and can get samples and an answer that way. Many times patients undergo VATS. VATS is video-assisted thoracic surgery, and that's keyhole surgery. I usually do it through one small incision. And I do that. It can be done under sedation. If the patient tolerates general anesthesia, it's a little more comfortable. It can be done on medical thoracoscopy is sort of the term that the interventional pulmonologists use, where they stick a little scope in the pleura, but it's really the same concept. And I usually reserve that for patients who I'm unsure what this pleural process is, and mesothelioma is in the differential, but it could also represent infection, or it could represent another cancer, and I want to get some samples. If I see tumor, obviously that's what we sample. If sometimes patients have a sort of irritated pleural process that's suspicious possibly for mesothelioma, and you want to get some random samples. And the nice thing about VATS is you can explore the entire chest through that. Now, thoracotomy is the most invasive thing that can be done, and sometimes they are done diagnostically. Sometimes we term it an exploratory thoracotomy. Usually for pleural mesothelioma patients, that would be in the setting of someone who came in with what was thought to be an infection. And this story, and it may have happened to some of you, is where somebody has a cough and some shortness of breath, is thought to maybe have pneumonia, and they have a pleural effusion, and it's thought that this was a complication of pneumonia, something called a pneumonic effusion or an empyema, and they ultimately find their way to a surgeon who would try to sort of peel the rind and process off the lung to try to expand it or decorticate the lung, and the pathology shows that this is actually cancer, and it wasn't really infection to begin with. But this does happen. It does provide a lot of tissue, but is by far the most invasive thing that can be done to make a diagnosis. I put this in the category of other. So bronchoscopy is not usually useful for the diagnosis of mesothelioma because the airway is the most central portion and the furthest away from where this pleural process happens. But sometimes if a patient has some airway issue that needs to be evaluated, or in particular if tuberculosis or some infection is thought to be the etiology, this is how that diagnosis is made. Usually, so a scope is put in through the trachea and can evaluate the airway. Endobronchial ultrasound, that scope has an ultrasound on it and can see next to the trachea, and that's really more useful for a lymph node assessment. We'll talk about that in a second. More sophisticated tests are coming down the line and are being used, especially for patients whose tumors have some signal in their blood. We call it liquid biopsy. There's circulating tumor cell DNA, there's cell-free DNA. There are other biomarkers that are relevant, especially in certain patient populations. That's not routinely used, but is becoming more and more useful. So just a quick word on staging, because biopsies are relevant to that as well. Staging is very important. The sort of workhorse of staging at this point is clinical staging through a PET CT, as Dr. Strasser discussed, and that is helpful, but again has some issues of sensitivity and specificity, meaning not everything that lights up is cancer. Someone brought up the pleurodesis from 30 years ago that will light up and they may not represent cancer, and not all the cancer lights up, unfortunately. So there is pathologic staging, meaning actual biopsies, and I think it's becoming less and less commonly done routinely. But where I trained, a mediastinoscopy or an incisional surgical biopsy was done to evaluate the lymph nodes in the center of the chest or the mediastinum. Now we have endobronchial ultrasound that can do that through that scope that I discussed before. And some centers still do staging laparoscopy for all patients with pleural mesothelioma. They assess the abdomen with a laparoscopy. I reserve that for patients who have evidence or suggestion of possibly having tumor in the abdomen. We want to distinguish it from an unrelated cancer or some other process. In particular, if I have patients with lymph nodes near the liver or the stomach or intestine, I might evaluate that with laparoscopy. But some people still do stick a scope in, wash around, and send that fluid for analysis. Diagnosing recurrence. In an ideal world, you would have tissue. And so if the tumor is accessible, it sort of depends on the risk and benefits of biopsy and whether it will affect the decision your treating doctor is making. So if having the tissue or not having the tissue doesn't affect the treatment that you're going to get, it may not be worth any risk. But if one course of treatment, if the tumor shows this, or one course of treatment if the tumor shows that, or whether it represents recurrent or progressive mesothelioma at all. For example, some behaviors are weird. I have had a patient who tumor was showing up in the muscles of his back, and it was kind of hard to believe it. Not in the space where he had surgery. It was, I think, in his leg, or someone had in the back, another person had the leg. We do see metastases, which is unusual. So confirming that is cancer and confirming that is mesothelioma is important. And sometimes for cell type or genomics, this is relevant. And again, the liquid biopsies are becoming more sophisticated and very helpful, in particular for patients who have some signal in their biomarkers in their blood. But the most important thing is still multidisciplinary treatment. Having a surgeon, a medical oncologist, a radiation oncologist is very helpful. We have a great team at the New York Mesothelioma Program. I'm very grateful to them. And in conclusion, you want to start for biopsies and diagnosing pleural mesothelioma. You start with the procedure that offers the highest likelihood of success with the lowest risk. This may include drainage of the pleural effusion, image-guided needle biopsy, or surgery. Tissue is the issue. Recurrence or progression might require biopsy, and multidisciplinary expert care really is paramount. And just thank you to all of you. I welcome any questions, and a quick shout out to my team at Mount Sinai.
Thank you, Dr. Wolf. You have time for one question. You have your hand up here first. I saw you.
How do you deal with a laparoscopy for a peritoneal recurrence when they have a lot of scar tissue, and they did one laparoscopy already before they knew the scar tissue, and they went into the small bowel, but so now they want to do another laparoscopy? How do you deal with that if you know that there are scar tissue in the?
So I'm a chest surgeon, so I don't have expertise. I do laparoscopy in the setting of pleural mesothelioma, but so I would defer to the surgical oncologist in the room. But I think it's an important question in general in the concept of risk and benefit, because a small bowel injury or an enterocontinuous fistula that might develop as a result is significant. And so that is an important point, but I would defer to the surgical oncologist in the group. I would definitely ask Jason or Travis.
Wonderful. Can we have another round of applause for Dr. Wolf? And I'd like to invite to the podium Dr. Jennifer Sauter from Memorial Sloan Kettering, and she will discuss pathology. We're going to try to get 2 more presentations in before we break for lunch at 12:30, so 10 minutes for Dr. Sauter and 10 minutes for Dr. Bueno, and then we'll move into lunch. We'll be a little bit behind for our afternoon sessions, but we will also maybe be able to end our award ceremony slightly early, and we can move forward with that so we don't keep folks much past 5 p.m.
All right, thank you so much. Thank you for the invitation to speak at this summit. It's been a very enriching experience, and it's been really wonderful getting to meet some of you over the last day. Before I start, can you see my arrow? You can't. Okay, that's fine. We'll go without. Oh, give me a second. Okay.
Looking for this arrow?
Yeah, this is going to be really hard.
Here's your red dot.
Super. Thank you so much. Okay, can you all see this now? Super, super, super. I won't dance it around too much, but it helps to show you what I'm trying to show you in the pathology images. So as you know, pleural mesothelioma is a rare cancer arising from the mesothelial cells of the pleura. There's an aggressive tumor with poor survival. So early and accurate diagnosis is critical in order for patients to receive the appropriate treatment. However, the diagnosis of mesothelioma is very challenging. In my opinion, it is one of the most challenging diagnoses in pathology for many reasons. There's multiple pitfalls in the diagnosis of mesothelioma, and there's multiple mimics, both for other types of tumors that look like mesothelioma, but also benign entities that look like mesothelioma. So it's very challenging in pathology, and it requires pathology expertise. So it requires pathologists who've seen many cases of mesothelioma. So just briefly, in general, we prefer a biopsy in order to make a diagnosis of mesothelioma. But because it's invasive, not all patients can undergo biopsy. And so if we have a cytopathology specimen and that's all we have for the patient, we will do the best we can to make a diagnosis on cytopathology as well. So here you can see this is an example of cells in a pleural fluid specimen under the microscope with mesothelioma. And then here's an example of tissue, a tissue showing mesothelioma from a biopsy specimen. In this talk, I'm going to be focusing on how we approach the diagnosis in biopsies, but everything we do in terms of approaching the diagnosis of mesothelioma in biopsies, we also have a similar approach in cytology, although there are more limitations in cytology. So the role of pathology when examining pleural specimens is to confirm the diagnosis and to distinguish from other diseases. Pathologists also identify prognostic features in tumors that can help guide management decisions, and we also identify biomarkers in tumors to help guide treatment and or enrollment in clinical trials. There we go. So first, I'm going to explain how we diagnose mesothelioma. The first task we have as pathologists is to determine the origin of the cells. Are they mesothelial or are they something else? And the reason for this is that metastases to the pleura are more common than mesothelial primary tumors. We use morphology to look at the cells, but it can be very difficult on morphology alone to determine the origin of the cells. Here's an example of mesothelial cells that are lining the surface. And you see some areas here where mesothelial cells are a little bit deeper. These cells are very round and regular, and they sort of look like mesothelial cells. So based on this image, the morphology is probably mesothelial. But some metastatic tumors can have this appearance. In this example here, this is a very aggressive appearing tumor. It's very poorly differentiated, meaning it doesn't look like anything. The tumor cells are bizarre, and you can see tumor cells like this in a carcinoma, a lung adenocarcinoma, or a mesothelioma. We can't tell by morphology. So in most cases, basically all cases, we use immunohistochemistry to help us determine the cell of origin. And we always correlate with clinical and radiologic findings. It's useful to know, does the patient have a large lung mass and a history of lung adenocarcinoma, and now we're looking at a pleural specimen? Or does the person have diffuse pleural thickening and no mass in the lung? So immunohistochemistry is also referred to as IHC. Sometimes you may hear of it as referred to as staining. We stained the tumor. And this is a technique that uses antibodies to identify proteins that are expressed in cells. There are several antibodies available with high sensitivity and specificity for determining mesothelial versus carcinoma. Mesothelial origin versus carcinoma. So 2 antibodies that we use very frequently, I'm sure you've heard of them, are calretinin and WT1. They both are mesothelial markers. They're very sensitive for mesothelial origin. Calretinin, here's an example of a mesothelioma with positive calretinin staining, which you can tell it's positive because you see the brown color in the tumor cells. There are a number of antibodies that can be used to determine carcinoma origin. They include, this is just a few of many, Claudin-4, BRAF4, MOC31, and CEA. Here's an example of a lung adenocarcinoma. And I would not be able to make that diagnosis just based on this morphology, but I can see that it's positive for Claudin-4 by this dark brown color. And it's also positive for TTF1, which is a nuclear marker that's very specific for lung adenocarcinoma. So once we've determined that the origin of the cells are mesothelial, we now need to know whether the process is benign or if it's malignant. This also is very difficult because many benign reactive processes can mimic mesothelioma. So this is an area of pathology that's very difficult. I can show you a few examples. We do look at the morphologic features before we do anything else. So in this example here, you see fairly bland appearing mesothelial cells lining the surface in a single layer. The cells are round and regular and a single layer of cells. This is most likely a benign process. In this example, we see tubular formation of tumor cells that are invading deep into the tissue. We also see them invading in the adipose tissue over here, these little white circles. So this is compatible with a malignant process. Under no circumstance would this be benign. But this example here is where it gets tricky. You see proliferation of mesothelial cells at the surface. There are some benign reactive processes where we get this piling up of mesothelial cells, and you can't tell without seeing deeper into the tissue if this is benign or malignant, because you need to see if there's an invasive component. But sometimes in our specimens, what we see isn't deep enough to assess that invasive component. And so in these cases, it's impossible for us to make a definitive diagnosis of mesothelioma versus a reactive process. Again, we have ancillary studies that can help us, which I'm going to talk about, and we always use clinical and radiologic correlation to help us. So there are several antibodies for IHC that also have high sensitivity and 100% specificity for mesothelial, for malignant mesothelioma. So this is a typo here. It should say malignancy. So the antibodies that we commonly use are BAP1, MTAP, and NF2. And what I mean by 100% specificity is that these antibodies are going to detect molecular alterations in cells. And if that alteration is present, that is 100% specific for malignancy. However, they're not perfectly sensitive because not all tumors have a BAP1 alteration or not all tumors have an NF2 alteration. So if we see the alteration, we know it's malignant, If we don't see the alteration with the immunohistochemistry, we can't say whether it's benign or malignant based on that immunohistochemical finding. Here are some examples. Again, immunohistochemistry is brown staining. So in these tumor cells, you see no brown staining. So this is an example of BAP1 loss, which means the BAP1 protein is not expressed in these tumor cells. It's abnormal and it's compatible with malignancy. Here are some examples of mesothelioma with retained MTAP and NF2 expression, which you see by the brown staining. And then here are some examples of mesothelioma with loss of MTAP and loss of NF2 expression. So we use these to help us determine whether reactive proliferation or whether something's a reactive proliferation or if it's a malignant mesothelioma. Once we have a diagnosis of mesothelioma, we must identify and report prognostic features that are helpful for management. The most important is the histologic subtype, which I'm sure you are familiar with. We have epithelioid, where the tumor cells are round in shape, sarcomatoid, where the tumor cells are spindled in shape, and then biphasic, where we have a component of both round and spindle-shaped tumor cells. And this is very important because histologic subtype is prognostically significant, as you know. Patients with epithelioid tumors have longer survival compared to those with biphasic and sarcomatoid tumors. Also, in the era of immunotherapy, we know biphasic tumors tend to respond better to immunotherapy. So when the pathologist gives a report and gives the histologic subtype, it might be helpful in getting patients to the right treatment. Within the epithelioid group, there is a broad range of survival. So in recent years, we've identified ways to improve risk stratification of these specific tumors. One is tumor grade. So tumor grade has prognostic significance in epithelioid mesothelioma. Tumors with low grade are associated with longer survival compared to tumors with high grade and or the presence of necrosis. Necrosis just means dead cells, and we can see that on morphology. Additionally, tumors with pleomorphic features tend to have worse survival compared to other epithelioid mesotheliomas. And so pleomorphic features are just these bizarre, abnormal-looking tumor cells. They're giant. They have multiple different nuclei with lots of different nuclear features, and one cell looks different than another. They don't look similar. They look very different, and that's what pleomorphic is. Finally, pathologists also have a role in identifying biomarkers in tumors to help guide treatment and clinical trial enrollment. We do this both clinically, but we also help in the development of biomarkers in our lab. So some of the antibodies we use to help distinguish benign versus malignant are basically antibodies against protein expression against genes that could be therapeutic targets. So both MTAP and NF2 are potential therapeutic targets, so we can potentially help identify tumors that might respond to those treatments, both with immunohistochemistry, but also molecular testing. And so we have next generation sequencing panels that detect 500 plus molecular alterations in tumors that in the future could be potentially useful for targeted therapy. So just to summarize, the role of the pathologist is to confirm a diagnosis and to distinguish mesothelioma from other diseases and benign entities. We identify prognostic features in tumors to help guide management, and we also identify biomarkers in tumors to help guide treatment and or clinical trial enrollment. So thank you for your attention. Yeah, so in our institution, about 30% of our patients have a diagnosis elsewhere before they come to us. But before our clinicians will treat the patients, they need to have MSK pathology review the slides. So the standard procedure is to have the slides come to us, we review them, and then we do send them back. We also digitally scan them before we send them back, so we have a record of those slides. Yeah.
Thank you, Dr. Slaughter.
Thank you.
Slaughter. I'd like to invite next to the podium Dr. Ralph Bueno. Dr. Bueno is from Brigham and Women's, and he's presenting on biomarkers and genetic analysis. Please welcome Dr. Bueno.
Thank you for inviting me to talk to you today. And I should always note that I received a MARF grant early in my career that helped push things forward, so I'm obviously grateful for that. Let me just make sure that what I press. So I'm going to expand the talk you just heard a little bit on biomarkers and how we get there. I'm a surgeon, but I also do a lot of research on the genomics of mesothelioma. So I have a lot of conflicts because that's how I fund my research. And I have a deal whenever a company or someone wants to fund me for lung cancer because they want to collaborate with me on lung cancer research. I said, yes, as long as you also found a parallel mesothelioma research. That's what's necessary because we gotta do that. So let me expand a little bit about biomarkers. Biomarkers can be anything that's biological, that's in us. So, and it can be used for many things. So you can do early detection. You can take a population and screen them for the presence of whatever. So when your primary care doctor checks your sugar level and hemoglobin A1C, that's a biomarker for early diabetes. It can be used for, and when we see patients with plaques, they come to us, we follow them, we check mesothelin levels, we check CAT scans, because they're concerned it might progress to mesothelioma. So biomarkers can be used for early detection, for diagnosis, to figure out prognosis, which is how is the tumor behaving, to predict therapy for specific therapies, to do surveillance for recurrence, and to look for some genetic abnormality in your germline that might predispose people in your germline, in your biological relationship, to a disease. So those are most of the biomarkers, and it can be tissue, it can be blood, it can be tumor, it can be normal, it can be saliva, it can be a scrape. Pap smear is a biomarker. So biomarkers are all around us. It can also be in the blood. So you can do a whole bunch of stuff on the blood. You can look at the DNA, which makes up our chromosomes and our genes. You can look at RNA, which get translated from our chromosomes to make protein. So you can look at any of them. You can get CAT scans, and that can be a biomarker. It's called radiomics. Any radiological biomarkers is radiomics. And I'm sure there's stuff that I haven't thought about. But the police can use a biomarker when they swab, if you get in trouble, and they swab you and they check your DNA to see, and then they found that some relative did something bad many years ago. But hopefully that doesn't happen to anyone here. But that's a biomarker as well. So you just saw the slides about the 3 types of mesothelioma, and that's the subtype of mesothelioma is a diagnostic biomarker because it tells you that you have mesothelioma, or whoever gets it has mesothelioma. It tells you what type, so it's a diagnostic. Now, patients, if you don't treat anybody, patients with epithelial mesothelioma do better. So that's a prognostic biomarker. And then if you want to have immunotherapy, people with biphasic or sarcomatoids mesothelioma do better. So it's also a predictive biomarker. So that's a simple way to say that the same thing can be powerfully a biomarker. Now, I'm old, so I've been doing this for a long time. So how do I think about how to connect biomarkers and prognosis and therapy, et cetera? So I think a lot of stuff in medicine depends on the therapy. There's this circular argument. 100 years ago, the number one cause of death was infection. There was no antibiotics. There were no treatments. So more people were dying from infections and for the consequence of infection at that time than anything else. And people started staging the result of infection. So there is primary syphilis, there is secondary syphilis, there is tertiary syphilis. But now we have therapy for syphilis and for lots of other infection. So it doesn't matter what stage you are. We can give you antibiotics and cure most of you if you get an infection. So prognosis is related to therapy. If you have therapy for the condition, then things change. But we use staging because it produces the expected survival, the expected therapy, and we have recommendations for that. So that's the other side of the coin. And we believe, as you've seen in the previous lecture, that biomarkers can be helpful, and they are slowly, in many cancers and many other diseases, being inserted into the staging system to make them more relevant. Because you can have stage 4 cancer, but if you have a biomarker that tells you that you have a drug for that, well, you're not going to have the same effects as someone with stage 4 who does not have that. So that makes a difference. So that gets inserted. So as I think about prognosis, I think about the disease, how advanced is the stage. Then I think about the tumor separately. Does it have any particular markers for aggressivity or for benefit from therapy? So you can have stage 4 something, and if you have a drug for it, that stage 4 doesn't mean the same as if you don't. And then it has to do with the patient, because a lot of the treatments we use have toxicities. So, and so the question is, how well is the patient? How is the patient's nutrition status, the frailty, the other comorbidities, the age? How does that interact with the patient? So I've started over the last decade or so really distinctly separating that, because we and other in many diseases have shown that your nutritional status is as significant in predicting how well you'll do as you stage. Now, this is a heavy slide. We published this about 9 years ago or 8 years ago. And this slide shows all of the genomic understanding of mesothelioma at that time. And we first sequenced the DNA, the chromosomes of 211 patients who had mesothelioma after we curated the specimens to make sure that mostly cancer were presented. And we looked to figure out the prevalence of various mutations in them. And you heard about little mutations again from Dr. Soder. And we found, as being suspected, the most common mutations. And that led us to map the 5 or so pathways that the cancer can take to cause issues. And by defining the pathway is what's the metabolism or what's the function in the cell that requires these proteins. And once you understand the pathway, then you can see how the tumor interrupts the pathway at different places. But you also can see how you can overcome it with specific medicines. So you've seen that when we looked at MTAP and BAP1 and those mutations that you can identify kind of guide you to specific drugs for therapy. So in that sense, the mutations, the alteration in the tumor can either show you potential therapies, and with BAP, it can also show potential familiality of the disease. On the right-hand side, it's the transcriptomic, and that's the RNA. So what we did, as many other people do with RNAs, the RNA is the messenger RNA. You all know about it from COVID vaccines, RNA-based. But it basically copies the gene and makes the proteins, and the amount of RNA in the cell differs in different cells, and the levels in cancer is different than the level of normal. And it can give you a certain fingerprint of the tumor. And what we found is if you look at those 211 patient specimens, that the tumor progresses from the epithelial part, where the cells are rounder and happier, to the sarcomatoid or mesenchymal part, which the cells are more aggressive, and that we call EMT. And that is a significant prognostic marker. That is the issue, and how it does that is one of the mysteries which we're trying to unravel in mesothelioma, and I'll talk about in 4 slides, that let us identify targets for therapy to kill it, to Achilles heel, if you will. Now, we talked about staging. This is the IASLC, so it's the International Association for for Study of Lung Cancer, and even as we are putting the next staging, and the staging system is what every institution uses to say, this is this stage, this is how we should do it. And we're on that committee, and I just wanted to show you in item 2.4.3 how these biomarkers are being used, because they're going to be very important for diagnosis, prognosis, and treatment. This is a study that we published a few years ago showing how we can use the biomarkers that we define to predict outcome in patients who have surgery in this kind. And that's how we identify people who do better with surgery, that being one therapy for mesothelioma, with surgery followed by chemotherapy. And you can see that the top curve, so this is what we call a Kaplan-Meier survival analysis. Let me see if I can figure out how to, which one is the, okay, I'll go back. I'm looking for the arrow. Oh, I found the arrow. So I can do it on one slide, not anywhere else. But so you remember I showed you that this is basically non-epithelial disease, and this is where the nutrition comes, the albumin. But the group that has the fewest unfavorable points does the better. So this is everybody's alive here at time 0, and you're looking at how people do up to 5 years. And you see the people who have these characteristics do much better at 5 years than the people who don't. So this is where biomarkers can have, in combination, prediction of prognosis of the patient from a specific therapy. Now let's go to something new and exciting. And we published recently, and we have it in press as well, a study of single-cell sequencing. And the way you do what's single-cell sequencing? When you look at RNA, you just take the tumor piece, you take a small piece of it, you grind it up, you make RNA from it, and you look at the RNA, and I showed you those 4 squares in various shades of blue. But what we have the technology to do now is to take the tumor and solubilize it and dilute it to a way that each separate cell gets coded by a QRS code, if you will. Simplifying it to use words that we can all understand. And then you multiply them by DNA sequencing, and then when you sequence them, you can go back and see which are from the same generation of cells, and then you always know by their sequencing if they're cancer cells or non-cancer cell and so on. And that lets you look at the cancer elements separately from the immune elements, from the fibroblast elements, for all the elements but surround the tumor, because the tumor itself is made up of cancer cells and everything in it and around it. So it's not just tumor. And we're finding in many cancers, including mesothelioma, that those other cells inside can feed the tumor, make it bigger, make it smaller. And immunotherapy is basically a way to manipulate that. But there are other things to manipulate. But what was exciting is that as we looked at about 100 cases of single cells, we found that there is in what looks like a new cell in mesothelioma. Because here is you're looking at everything I described from sarcomatoid to epithelioid, and there is a type of cell tumor here that's, we call it uncommitted because it can't decide whether to become sarcomatoid or epithelioid. And we found that mostly in biphasic tumors, but also in some sarcomatoid tumors and epithelial tumor. And I'll show you that in a second in the last slide. What's interesting is when you look at the slide that, like Dr. Suter showed, with all the stains that we currently use in mesothelioma, they all look the same. And then we stain it with the stain that we found based on this, and some get stained and some don't get stained. So it's not the pleomorphic or anything else, but it looks a little different in every case. Now, we did it at the protein level, and we did it at transcriptional analysis using RNA. And what I'm showing you here is what we call a core. And the core is, you take a needle of a certain size, you put it through the tumor, and then you put it in paraffin. And then you can slice the paraffin and make many slides. And you do it hundreds of times, so you can have on one slide 100 tumors. Now, this is mesothelioma. What do you think, Dr. Sutter? It's biphasic, or what do you think it looks like from there? Yeah, biphasic. I gave you a gimme. I'm just giving you a hard time. But all the pathologists, when you put two pathologists together, they're 80% the same. Yes, it's in the mail. I gave you something better. Spatial transcriptomic with 500 transcripts. So the 500 genes best expressed on single cell analysis are here. And we can select which we're showing, but these were the epithelial. These were the sarcomatoid, and these were the uncommitted. And you see how heterogeneous the tumors are. And you see even there, you can see some of these cells here. So, now, unfortunately, cancer research is, as important as it is, it's almost like peeling an onion. You peel a layer, you cry because you worked hard, and then there are lots of other layers underneath. And that's what we keep trying to do. But we believe we found a new cell in mesothelioma, and perhaps it may be a cell or a cell state, but this might indicate that there is an opportunity to treat another cell, because we right now are focused on either treated with chemotherapy for epithelial, immunotherapy for biphasic, but are we missing some of those cells because of the heterogeneity? So that's what's coming up in mesothelioma. As we peel the onion, we're discovering new things, and we're studying how we can treat these cells. So in conclusion, genetic analysis is becoming central in centers of excellence And from people you heard today, we do the genetic analysis routinely. Biomarkers do help define therapies. There are a whole bunch of specific trials for some of those biomarkers. Precision therapy is the future, and more exciting information is coming, and I thank my faculty for making things happen. So thank you.
Thank you, Dr. Bueno. In the interest of time, we will forego questions from Dr. Bueno at this point, and we'll bring on our next two speakers. And Dr. Bueno can field some questions if you have them during the lunch break today. Our next two speakers joining us today are Dr. Jason Foster from the University of Nebraska and Dr. Travis Groats from the Mayo Clinic, and they'll be discussing peritoneal surgery and HIPEC. Welcome, Dr. Foster and Dr. Groats.
Well, thank you guys for having us. I'm Dr. Foster. This is Jason Foster, and this is Travis Groats. And, I was kind of tasked to do it, so I kind of put it together, and Travis was willing to share and stuff. So most of this is going to come through me on this, but we'll be here to answer questions. So first, I want to just say, having been to this meeting, this is one of the biggest groups I think I've ever spoken with. This is a beautiful thing to just see so many faces out here, which is good. So it's just a testament to things. Let me see if I know how this works. There we go. So I've given this talk before, just about what I think are important to patients. First, is anybody going to be bothered with any actual images of procedures? Is that bothersome to anyone in the audience if you see some of this stuff? No? Okay, because I'll just give you a message to maybe look away as these things come through. But I think talking about this space with peritoneal disease, to give some perspective, and I share pretty openly with patients about this too, about what we're going to do and what you may see. So I think it all starts when you get your diagnosis and treatment, how you prepare for this therapy. And then I want to talk a little bit about the medical and surgical therapies, and then some common questions that come up for patients that have been through this, that I face through this process. And I guess as I talk to the room, how many folks here are related to peritoneal disease versus? So that's probably about right in terms of the proportion of the frequency of this. So when I think about this disease, it's sort of the smaller subset of pleural disease. We talk about 3,000 cases, maybe 5,000 cases of pleural disease. There's about maybe 500 cases per year of this, so it's a fairly rare one. And when we think about it, it all starts with the histology. Most of our patients are in this more favorable tumor type as we talk about it. Many of you are probably knowledgeable as this epithelioid type. But then there's these two other categories that tend to have a more aggressive streak and are a little more challenging in terms of what we're going to do from a surgical standpoint. But again, this is a disease where we use a lot of the tools of surgical and medical therapy. So this is something that I'll walk you guys through, because I think conceptually when I think about peritoneal disease, the peritoneal cavity is an organ. It houses your stomach, your liver, everything that's in there. If you're a woman, your uterus. If you're a man, your prostate. It all lives in there. And what keeps it alive are these lining surfaces. There's a peritoneal lining on your organs, and there's a peritoneal lining on your muscle that's on the other side of your skin. And this is exactly where the tumors grow. Actually, the tumor of origin is from the mesothelial cell that lines that organ. And this is just my cartoon rendition that I've had since I came out of fellowship that I show. It's just this idea that once one forms, these little kernels of tumor, I use those, if there's some folks that have been my patient, I talk about spilling rice in your kitchen. Like you spill a grain of rice and those little seedlings go everywhere in your house, from your garage to your kitchen to downstairs. That's what these tumors can do, that this slide was kind of showing through there. And while it sounds simple, the biology of this is very complex, and there are plenty of people who are researching that. So what drives the implantation phenomena? There's integrins and integrins and receptors, and the immune system all play a role in this process. And this is totally different than other cancers that spread through the bloodstream, where there's a different set of mechanisms at play. So what I'm showing here, as I step away, I didn't realize the setup was like this is what we're talking about, and what you're seeing in this picture is a picture of a peritoneal cavity. And those little white dots are the peritoneal implants. The other unaffected areas are the peritoneal lining that we're dealing with.
Give you a digital pointer. How's that?
Oh.
Digital pointer.
Oh.
Tap on that. Tap on laser pointer.
Oh, this is high
There you
tech.
go.
Very nice. I never knew that existed. So yeah, what you can see here are these this is the normal peritoneum, and all these are the little nodules. And just like that concept, here's some implants on the mesentery of the small bowel. So we're often trying to figure this out for patients, and there are some other things before we go to a laparoscopy that allow us to predict where the disease is. So when we meet a new patient, we take a history and physical. Starts with every doctor visit. So knowing the story. I spend a lot of time trying to get people to articulate when they first notice symptoms, because this can be very indolent. People may have had a symptom 6 to 8 months ago. They may have noticed something. They may even have seen a provider for some ache on their side. And that may be, for me, some sense of when these things start, because that's always a question I get back. When did this all start? Was it a short course and it grew quickly, or was I having symptoms for a year or two before I built up this distension and everything? So I think that's critical for me to get a sense of maybe when it started and where we are in the spectrum of management. And then the other thing I'm thinking about is, as we're talking with patients, there's no doubt this is the most stressful time for patients. And I always talk to patients, and many of them are already prepared and knowledgeable about this, is you want to come in with your network to this first visit. Whoever your person is who's going to be listening and taking notes and listening to the whole picture, because if you're newly diagnosed, part of this is you're not going to resonate on everything that's said at that visit. So having somebody there is important. Getting your network to understand the disease outside of your diagnosis once you've been diagnosed is important. This organization is a good example of that, using all the resources that are at play. And then again, testing, or not testing, but just asking your physician about what's going on, getting a better understanding of the biology. That's part of our role, is to be that repository and resource for you to understand where you are on the spectrum of it. And then the other thing is going and understanding the disease. You don't have to have an MD degree to understand this disease and understand what it's capable of doing and where you may fall. But leveraging all these resources, I think, is very important. When we're trying to figure out what we do with each new patient, certain things come up. One is blood tests, just general labs, understanding where you are, your level of fitness, your level of nutrition. And a cancer marker that has had an impact is the CA-125. The other thing we do, everybody gets a CAT scan or has had a CAT scan before they've seen me. The other thing that we do are MRIs. I'll talk a little bit about that. That's a common question as to, is MRI better than CT, or how do you manage that? How do you choose between those two technologies? And the other is, everybody with peritoneal mesothelioma needs to have a full chest scan, because there is a small percentage of patients that may also have what we call bicompartment disease. Now, just like that picture I showed, there's diagnostic laparoscopy, and that, to me, for anybody that's never had a surgery, if there's not a reason to not do it, meaning you've had major surgery that makes the procedure a little bit more challenging or a little higher risk, I tend to do this because we know our scans can underrepresent the disease burden, and it allows me to have a much more full-throated conversation about what's going on with your disease and what it may require. Also, how we may start this exercise, whether you're going to have surgery up front or whether or not there's a role for medical therapy before we go to surgery. And sometimes, if someone's obviously not diagnosed, that's how we get at the diagnosis for patients. So many of you know about diagnostic laparoscopies. When we talk about that idea that you put a scope in the abdomen with air and gas that allows us to look around. So this is kind of, again, a little bit different than the others. You're seeing peritoneal involvement and now small bowel surface involvement in this particular picture. So after we've done all of these assessments, take the family history and you look at this, maybe try to link it up to some exposure. Did you work on breaks? Did somebody work with asbestos? Which, again, in the peritoneal world isn't always as connectable. We go to our decision-making parts of this, which is, are you a candidate for the debulking surgery? If we do the debulking surgery, then we're most likely going to give the intraperitoneal chemotherapy, or 100% in my case. And the other question is, what is going to be the role of the systemic therapies that we have, in terms of, is there going to be a role for it up front? Is there going to be a role for it after? Or are you in that subset of patients where it's not needed at all? There are places that also offer intraperitoneal chemotherapy as part of their intraperitoneal therapy protocols. There are not a lot. I think the group here in New York, or not here, but the group in New York was a big proponent of using IP chemotherapy in the intermediate and going back for second looks. There is actually a study going on at Memorial where they're offering it and they're comparing 2 arms of IV and IP chemotherapy. So there are some places that are trying to figure out what its role is. And I'll try to break that down at least where I think we would use it much more regularly. And I would put in here that this is something that's being done more so on trials. So the bulk of what we're going to do for patients with peritoneal disease, and the most important thing, is getting a quality debulking. Like, it all starts with removing the macroscopic disease. If that doesn't happen, then the tumor does not go away. And again, this is where there'll be some pictures just to give a perspective, because everybody's a little bit different in terms of common things that happen. So we often take out the omentum, spleen, maybe a little bit of the pancreas. That's probably the number one organ that comes out. The idea that we can take that peritoneal inner skin, it's that layer that's behind the muscle where we can strip things away. The other things are, there are different levels of bowel resection. Some people come in with bulkier disease, sometimes it's finer disease. And then in women, it's very common, particularly if women are postmenopausal, we will take the ovaries if they're not involved because they are a hot spot, but generally they can be involved pretty commonly. So the other part of this is the HIPEC. So I tell folks that they're always asking about that, but the most important thing when you're assessing your provider is, am I going to get a quality debulking here for my procedure? That's the most important thing if you're going to undergo this procedure. But the HIPEC is what locks in that cytoreduction. And the way that this works is that we can administer chemotherapy directly into the peritoneal space. And the way that it works is that your peritoneal space is kind of like, we talk about something called the blood-brain barrier. There's a lining or a partition where drugs don't get into the peritoneal cavity as easily as they should from the blood vessels, meaning you need a tumor of a certain size with a certain level of vascularity to get that full response. On the flip side, drugs like this, based on their molecular weight, the larger the drug, the more likely it's going to stay and exert an effect up to about 8 millimeters on the surfaces of the peritoneal cavity to address those micrometastatic cells that have been kicked up with the debulking, or some of those areas where you couldn't quite get every nodule. These therapies can work, and as a singular therapy, they can work pretty well in our own data. This I got from Travis. I think this is a great illustration of the challenge. So you have to put the chemotherapy into the bloodstream, and then that sort of gets disseminated to these vascularized tumors, whereas we are putting the drug directly into the peritoneal space, and those cells that are circulating are going to by osmosis absorb it and undergo the cytotoxic effects of this therapy, as well as this will penetrate some of the surfaces up to about an 8 millimeter level, and your peritoneum's a pretty thin layer. So the other part of this is, in addition to giving the drug, is the synergism that you get with temperature. So when we talk about these temperatures, we're heating this space up to 108 degrees Fahrenheit, 42 degrees Celsius for 90 minutes. And we know from long time ago that cancer cells are very thermally sensitive. And there's a window where you're not destructive to normal cells. If you go much above 42, you hit 43, you're going to start to denature your normal cells, and things don't go well for patients. So this is the window. And this is really important in the sense that there's a duration of therapy. So most of us do 90 minutes. Some people do 120 minutes. You can do 60 minutes when you look at the data. You get into this cytotoxic window. But there is this synergism where you get a 3 to 5-fold cytotoxic effect of the drug with the chemotherapy. And that's conceptually what's happening with this therapy. Now, not every cancer is going to respond to this therapy, but a high percentage of mesothelioma tumors will. So this is just sort of an illustration of what we do. The hard work is taking the tumor out. At the end of that, we put catheters in the abdomen, down in the pelvis and up over the diaphragm. We temporarily close the skin, and then we put this on a circuit, and we are literally shaking the abdomen for 90 minutes straight while the drug is being administered in this solution, balanced salt solutions, and being distributed from the fluid into the peritoneal cavity. So again, there's lots of new data, but I think the data that came out early sort of set the tone that prior to offering surgical cytoreduction, and we just did palliative chemotherapy for all comers, the median survival for this disease was quite poor. But once we identified that by removing these tumors, and not just removing them, adding this concept of intraperitoneal chemotherapy, we start to see the 5-year survivorships get reported, and patient selections play a role in this, which is part of why you're here to kind of talk about this. So some of the questions that I get asked are, again, the first one I start off with is MRI or CT. What should I be getting to best assess my disease burden and my follow-up? I personally do both. I tend to test them both. If one does stand out as the better predictive tool, both at diagnosis when we're looking at, because both patients will have had both, I'll stick with one. The reality is that CT scans are very accessible, and if patients pop up in another institution, having some CTs for comparative sake are very useful. But I find there's no data that says that MRIs are better, but I will say anecdotally I find the MRIs to be helpful in a subset of patients, particularly around the small bowel disease assessment. And I guess I'd ask Travis, do you have a preference?
Yeah, I think when I get asked this question, I think I just say it really depends on the institution and their experience and their protocols. So I think if you have an institution that does MRI a lot, they're going to be really good at it, and they're going to be able to use use that effectively. But if you have another institution that they've been optimizing their CT scans, and they know how to identify these things on CT, then they're going to be good at that as well. So, and that's why we can't show any difference, in studies, because I really think this one really is just, I think, preference of the institution and how good they are as the radiologist and the surgeon together in looking at these different modalities. So I differ. I prefer CT scan, but we have a very protocolized one where we give oral and IV contrast. We have certain cuts. We give glucagon to slow the bowels down. So we have a very protocol specifically for the peritoneal diseases like this to optimize our reporting. And then our radiologist also has like we call it a synoptic, but a very templated report. They're going to report on all the different areas that we as surgeons are interested in. So I think it's just each institution has their own way they've optimized it, and that's I guess how I would answer that question.
No, I think that's great. I think one of the limitations of MRIs, if any of you have had them, is they take forever. And that, unless you're a patient who can hold still, the data is degraded. So that's another factor for me. So we get great imaging and great results, but and some people are claustrophobic. Like if you're claustrophobic, we're going to have to put you to sleep to get it, so it's not worth that kind of level. But both tools work. So when we have sort of the patient that comes in that is a surgical candidate, it's the patient who has low to moderate burden of disease. We can see that our opportunity to get them to optimal site of reduction is there. These are often patients, if they've not had prior surgery, we've done a laparoscopy, and we can have a very specific conversation about what kinetic energy is going to be required to get this tumor into remission. For those of you who know about peritoneal disease, you're probably aware of what's called the PCI score, where the abdomen's divided into these 13 zones, 9 of which are here in the abdomen, right here, and then you have 4 along the small bowel. And our goal is to remove the disease, but we're also assessing the tumor burden, the bulk, the confluence, which allows us to come up with this grading system. And low to moderate burden is somewhere between a PCI score of 15 to 20 is what most would say, is the group at which we'd say, these patients, this is a patient I would take for upfront debulking. When you get above 20 and you're looking at the distribution, again, if this is a epithelioid tumor and not one of the other rare subtypes that are like a multicystic peritoneal case, then the thought about using some other upfront therapies would be a consideration for me in that group. So our goal is to say, can we get patients down to the minimal tumor burden? And there's a couple of scores that you may hear depending on the institution. The CC score is where you can either get it to no burden or you get it down to 0.25. I think this is kibitzing. There's an R score that says it's less than 5 millimeters. I now probably put both of those kind of descriptors into my notes now, just because they both exist. But if you can get these things down to minimal burden, there are areas that you just can't debulk along the small bowel because it's incompatible not to have your small bowel. And this is a disease where the intraperitoneal chemotherapy can have efficacy along with systemic therapy to trigger a complete remission for those patients in that circumstance. And then the question that comes up is, if I take a patient up for debulking first, what should I give adjuvant therapy? And I have a few rules for myself, and they come from some of the guidelines that are out there. So some of it is your tumor type. It's obviously epithelioid is the number one tumor type, but if you're a biphasic or a sarcomatoid and you get debulked, you're going to be getting chemotherapy based on that tumor type. But there are things about Ki-67, which is a proliferative marker. They say about 10% is consistent with a more aggressive biological characteristic. If I leave residual disease, if I don't get a CC0, then we're going to be thinking about chemotherapy. And those are often people, if I don't get a complete debulking at that level, I may be thinking about coming back for a second look to make sure that we've triggered the response. If we're going to do a debulking, we didn't quite get it all, we're going to give chemo, there's an opportunity to come back. So those are all factors, and your PCI score. So if your burden of disease was higher than I anticipated, and now you're, up in the high 20s, then we're going to have that conversation in a multidisciplinary conversation with our medical oncologist. So there are several things that go into the calculation about adjuvant chemotherapy. But I would say for every patient that I see who is a candidate out the gates, there are patients that aren't. And we have to start this conversation with neoadjuvant therapy, because we look at the scans, and even in the absence of being able to do a diagnostic lab, we may say there's tumor over the diaphragms, over the small bowel. We need to get you started on neoadjuvant therapy. And most of us would give neoadjuvant IV chemotherapy, although places that have neoadjuvant protocols to give part of those agents or one of those agents into the peritoneal space would also be an acceptable way to onboard neoadjuvant therapy. And this is Alimta, cisplatin, or carboplatin are by far the standard approaches that we use. There's also now, with the data with immunotherapy, when you can get it approved, and many of you that have been diagnosed with this may have faced the reality of getting the immunocomponent approved, can be a process. It's much easier to get people rolling on their chemotherapy, but when we can work that into the mix. And again, that's a multidisciplinary discussion about what we think is the best neoadjuvant approach. And there's unquestionably, this is the first step for anybody who we don't deem a surgical candidate because they seem to be unresectable, and those patients can move in and out. I've seen some pretty remarkable responses, particularly with immunotherapy changing that tide. This is also a group of patients who can have symptoms that are limiting their ability to stay on therapy, and we get in the conversations about the role of surgery for that, knowing that we're not going to get it all, but it's almost impossible for people who are having chronic bowel obstructions to stay on therapy and not get hospitalized to get the benefits of those therapies. So we have to have a strategic approach. And again, these are patients where IP approaches, particularly if you're not getting the response you want with IV chemotherapy, may come about. And just to mention, there are other immune modulators. There's biologics such as Avastin we may put patients on during their course. And there's something called PIPEC, which is this aerosolized therapy that's now being used. And there are protocols out there where people are seeing what it can do, particularly for patients who may have an unresectable case, to try to control ascites or symptoms. So these are all available, and there are places around. So I put this in there. I know I have a lot of pictures, but I think one of the things that's always a challenge, even with the laparoscope, I don't always feel like I see everything that I can. It doesn't always resonate through the camera. So you can go in with the best plan, and I always tell patients, I may see more with my eyes than honestly with my feel as I go in. Your eyes and your hands are working together. And this panel on the left is like two patients that went in up front. This patient looked like a good candidate. You do your laparoscopy, but this one, it's hard to see, but there is just subtle mesenteric disease all up and down the small bowel mesentery. So this is the type of patient I would debulk, do the omentectomy, do the bulk, try to do some destruction, but plan on coming back with the plan of giving that patient chemotherapy. This one was, again, someone with ascites who had pretty limited disease in the omentum, scattered disease on the resectable areas of the peritoneum, and didn't need anything else but observation. This group, I wish I could add them before and after, was someone who got neoadjuvant therapy for bulky appearing disease, and also had a recent other medical condition that precluded, that's another factor in when you go to surgery, and ended up just needing the omentum, and the spleen was the bulk of the disease, and again did well and completed their adjuvant chemotherapy on the back end. And then I mentioned this as an example of palliative. This was a patient with just bulky disease, not a chance to get the therapy because they were not in any shape. So we needed to intervene in someone not at their peak, but they were able to get that freedom to get on to therapy. So patients can come in a variety of presentations, and these are the things that patients need to be aware of as their options. Generally, the complications for these are related to the procedure. Bowel resections can have bowel leaks, bleeding to have to go back to the OR. You open the fascia, you can have a dehiscence or a hernia that needs to be addressed. Those are short term. I don't see a lot of long-term complications from the therapy. I don't see a lot. I was just talking with you about some of the toxicities of the platinums and things. I've not seen anybody have any ototoxicity. I have seen in the short period you can get some nephrotoxicity where you have some kidney dysfunction, and it's well published that some people who push the therapy can have permanent renal dysfunction. So you have to be thoughtful about this and about the patient when you're dosing these things. But again, some people who require bigger bowel resections can have problems with diarrhea. You can get stricturing from bowel resections and other things that could become long-term issues or things that surgically need to be redressed. There are patients who have a chronic pain component, and I will say many of them get relief, but a subset of them will have some echo of that chronic pain, but it's in a much better place. So I would say that's another variable that comes up for patients. I think the big issue that all cancer patients faced is the risk of recurrence, the fear of recurrence, and the emotion that goes around that for patients. And I find that, to me, is what I spend a lot of time talking with patients about. And then clearly, if you've got residual disease and you're in remission, that's always in the back of your mind, and those appointments always trigger those same feelings. So I think it's important for us to make sure that patients are supported in those elements as well as with the people that you surround yourself with. Another common issue that comes up is, could I get another HIPEC? And the answer is absolutely. That's called an iterative HIPEC. Sometimes it's planned, where we do get a certain level of debulking, give some therapy, and go back. We don't often do diagnostic laps. We already have a sense of where you were, and we're working more off the imaging. So like I said, and then there's the other folks that are clicking along well, and then 3 years later, there's a spot. And then the question becomes what to do with that spot. It's very much case by case. Sometimes there's this singular change. I may watch it for a cycle because sometimes we don't want to rush in because we don't know what we're rushing into. Sometimes there's just scar and other things. Sometimes if it's accessible to a biopsy, we will have our IR team biopsy it. But the second takebacks are a function of how long has it been since you've come off therapy? What's the bulk of the disease? Can we get our arms around it again? And then your fitness at that point. Are you a candidate to go back and have another surgery, or is there some other medical issue that we need to address for patients? And the idea that if you can have two, you can have three. So I would say I've had one patient that every 2 or 3 years there have been some singular things that I've taken out, and I think 3 is the most that I've done in this space. And interestingly enough, the patients who do get the iterative debulkings tend to be the ones who have the longest survivorship too. It's another tool, just like medical therapy, that you can use for patients. And sometimes those recurrences are in conjunction with more medical treatment. Sometimes they're just isolated resections, depending on the bulk and the site. The other thing I mentioned is that there are this is a rare category. I've not seen someone in a while personally, but you can have bicompartment disease. So you can present with both pleural and peritoneal disease, which can be a significant task. You can have an isolated peritoneal recurrence and have good pleural control for patients. And then you could have a two-field recurrence if you're a pleural patient. I think the challenge for this is the disease amenable to surgery, but if you're a pleural patient who now needs a surgery in the abdomen and you've had surgery for your pleural mesothelioma, then I think one of the things we challenge that's a challenge for anesthesiologists is this single lung ventilation. So there's another level of selection because these can be operations that go 10 to 12 hours or longer for patients. And the idea of ventilating a lung, the fluid shifting can be very challenging if there are people in that category. But there are options on the surgical side for that. And if we have bicavity disease, that's just me to say, we would do the peritoneum first and do the lung second if surgery is a recommendation. So I just think the key for everyone is to really, like you're at this meeting, is just educating yourself on your disease. You get knowledgeable about your disease, knowledgeable about the therapies, utilizing resources like this one to have conversations. And I also think, there's not a ton of people who are in this space, but you have the freedom to talk to as many people as you want before you decide you want to move forward with the therapy. And I think patients should exercise those choices and be comfortable with their providers, their surgeon, their medical oncologist. And that covers my area. I'll take any questions. And Travis, is there anything else you think? Did I cover it pretty comprehensively?
You did a good job, yeah. No, let's take questions and happy to chime in.
Sir. Yeah, there you are. I remember you.
We might have spoken about this
yes.
Several times, but so I had the second look after the HIPEC and the adjuvant therapy, and they found one dot. And they obviously took the dot out, and I've been net ever since. And you kind of answered my question at the end there when you said, well, if we see a dot, we'll just watch it for a while. So that one dot would have been enough to actually foster a recurrence or
you ask, I think one of the challenges, not just in this disease, is what do you do with the single recurrence that's small and is gettable? And depending on when it happens and who it happens to. If I have a good relationship with the patient and their biology has shown itself to be a slow actor, I will often wait a cycle of imaging before I go in, but we're going to go in at some point. And sometimes it is, that's a 5 millimeter spot. That could just be scar. Let's see if it becomes a centimeter. Let's see if let's see if something else grows up that makes it more global recurrence. Because I think one of the trickiest things for us with peritoneal disease is that smoke the sign of a bigger fire. And you don't know what fire you're about to land in the peritoneal cavity, because sometimes that little dot could be that there's a more global thing going on that you can't get your arms around, and then you're backing off and you're going on the medical therapies and you're coming back again. So really, how do we come up with the singular plan for someone who's in a very favorable state after their disease in that decision making? And you with Dr. Tao, you went through that. Like I think I don't know if anybody's continued that work, but that was a very it was a very viable path, and he had the institutional resources to pull it off, where he would take an index debulking, leave a catheter, and give you a HIPEC at the beginning, give you a catheter, then bring you back, complete the debulking, and then roll out. And I think there are probably there's a subset of people where that might be, and I think there's efforts to do trials in this space to get at that. But next to that is the reality that I see a lot of patients who index surgery, debulk them, and they don't need anything else. So I think this is it's a small disease, and there's an opportunity for us, and Travis and I have been talking about this, how do we kind of get each other together to really get a sense of the spectrum of patients, to figure out the tools we need to put together to best serve this community. And I think that's what part of this meeting is. But I would say overwhelmingly, unlike the pleural space, a good portion of our patients are good surgical candidates, and they get a lot of longevity out of this. And there's a subset of people who are not in that category, but they still need a surgical intervention for quality of life and for disease extension. You're not necessarily cured, but you're getting survival time out of this.
Yeah, the trouble I have is when I come to these sessions and somebody says, where were you treated? And I had the second look, and I think they were the only ones that did the second look. And you gave a great answer, and the whole presentation was fabulous. So
thank you.
It's just that answer. I was looking for the answer for why I got the second look and nobody else did it.
And I'll let Travis speak to his, but I have a low threshold, not just like there's other diseases in the appendicial world. I have a low threshold when I find myself, whether it's at the index surgery or following somebody who I know I'm taking, and a high percentage of those people who are getting upfront chemo, I'm breaking them out after 2 or 3 treatments. They're getting half their chemo, and I want to debulk them because I want to see what is the lift, because that's very similar to tau but slightly different without the IP catheter. That we're giving some systemic therapy, we're getting the omentum out, we're doing the bulking, and then I can come back a second time and I can set the stage for each patient. I think I could get back in. If the chemo doesn't clear up that small bowel mesenteric disease, I have tools that I can use to ablate, or potentially if you get capture, and let's say I can bring bevacizumab or some other drug immunotherapy in, that changes a lot of things for patients. And I've even seen, as I said, I've seen people that I've deemed unresectable get on immuno, and I've gotten this opportunity to get in there to have an impact. And I think we are armed now with some better medical tools, which are great for patients. And if anybody knows anything about immunotherapy, sometimes the double-edged sword of immuno is you get it and then you get a toxicity, and that becomes a problem when you can't keep it going. That I've noticed that can be a challenge too, just sort of setting the picture for everyone.
We do have one question from our online community, and I'll have Julie read it.
We have a live stream, and the question is, I'd like to know if either doctor has ever seen or heard of a peritoneal patient being cured with no reoccurrence. So I guess they're asking if maybe one and done.
Always hard definition of cure, but
you go first.
Yeah, no, I mean, I think when we talk about this, I mean, I do think it is a potentially curable disease for peritoneal mesothelioma. I think, and there probably are some long-term survivors in this room. So I do think it happens. And so, I mean, that's our goal. It's, it's always hard because you have to follow people for 5, 10, 15 years to confirm that. So, so it's hard to give you hard numbers, but I do think that, I mean, this is a disease we can.
Yeah, I'd agree with Travis. I have some people that, their PCI is 10 and they show up every time and their scans look clean. I think what we face is then once you hit the 10-year mark, do I keep seeing you? And that happens in a lot of our cancers. So the answer is yes. I tend to stay connected to those because you just don't know, particularly if they're on the younger side, because you don't know when the shoe's going to drop. I may even, I don't know about you, I'll push the imaging out to every 1.5 years or something to give them, or if they miss a cycle, we'll figure something out. But there are, I kind of had this conversation, I had this moment when I was walking around the hospital. I think cancers are just like people. Like every face is different, every person is different. And even though we have guidelines, that's the thing that every time I treat a patient, the arc of what's going to happen is so different. And, you have people on that side of the ledger and you have people who unfortunately get everything and rage through it. And we're just here to try to understand what those drivers are and hopefully change the paradigm for the folks that aren't the responders, and how do we best identify them so that they can get a shot at some new pathway of management. But I mean, it's one of these things. So the answer would be yes, of course, there are those.
Wonderful, thank you. We have a round of applause for Dr. Groats and Dr. Foster. You've been incredibly indulgent, so thank you for your patience. We're going to be moving into lunch. I'm going to ask folks to make their plates and bring your lunch back in here, and we will have a working lunch for our awards luncheon today. So please take a quick break, fill your plates, get your beverages, come on back in, and when the majority of folks are back in the room, we'll start.
Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick & Fox. We support the mesothelioma community by providing first-quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
Hi, I'm Trey Branham. Dean Omar Branham and Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
our sponsors for the wonderful support they have given the organization over these many years. Let's start with Bellick and Fox, and then we have Dean, Omar, Branham, and Shirley, otherwise known as Dobbs, MRHFM, Merck Pharmaceutical, Gorey Law, Bristol Myers Squibb, and Early Law. So again, please a round of applause for them if you have a free hand. I'd like to now invite up my colleague, Carolyn Shields. Carolyn's our development manager for the organization, and she has a very special awards presentation to talk about this afternoon.
Hello, everybody. Like Brian said, my name is Carolyn Shields. I'm the development manager at the foundation. Today, I have the honor of recognizing a family, and specifically a young man whose legacy will have a lasting impact at the Meso Foundation. Last November, I received a deeply moving call from Carl Rosenthal a few days before Thanksgiving. He spoke about his son, Brett, who tragically passed away at the age of 31 after a long battle with mesothelioma. We spoke about Brett's life, the impact he had on his friends and family, his relationship with the Meso Foundation, and ultimately what he wanted his legacy to be. Through our conversation, it was clear that Brett ultimately wanted to help young patients like him have access to their needs without finances being a barrier. In the months that followed, we met with young members of our Meso community to better understand their unique needs. Things like the cost of fertility preservation, expenses related to additional caregiver support and child care, and integrative medicine were a few things that came up during these conversations. The financial toxicity that comes along with a cancer diagnosis is profound at any age, but especially for young patients who are just starting to build their lives and their savings, it can be especially devastating. Carl, his wife Sherry, our patient services director Julie White, and myself worked together to create the Brett A. Rosenthal Patient Assistance Fund, a fund created to offset the cost of physical, mental, social, and spiritual needs for patients aged 49 and younger. The Rosenthal family's generosity will provide patients and their families with a respite from the financial burden they experience through mesothelioma. We welcome our community to contribute to this fund. This is something that we all can maintain and grow together moving into the future. But Carl and Sherry and Dana, thank you for sharing Brett's magic with us, his spirit and his enduring message of resilience and hope. It is with great honor that I present you with this memento in recognition of your extraordinary generosity and Brett's lasting legacy at the Mesothelioma Foundation.
I want to thank you very, very much. We are honored to be here at this very informative and important Mesothelioma Symposium. 11 years ago, our son Brett was diagnosed at the young age of 23 years old, and he did survive 8 years. He was very, very involved with the Mesothelioma Applied Research Foundation, getting a needed direction and support from the entire, anyone who would listen to him, especially the nurse at that time, Mary Hesdorfer. And he had a lot of conversations in the chat room with other afflicted patients. Got a lot of directions for this treatments, for the support system that he's going to have to battle with. He learned that he has a very, very difficult illness to deal with, that someday, he's going to have to learn how to manage this illness. Ultimately, the decision was to go with the cytoreductive surgery and then follow up with the HIPEC having that heated, topically applied chemotherapy. And later on went through treatments with IV chemotherapy, and then went even on a clinical trial at the NIH with T-cell therapy, then back on IV chemo, and later, and at the end, immunotherapy. So he did a lot of different procedures to try to continue not only quantity, but quality in his life. He learned how to manage the illness, gaining, again, this information through the Meso Foundation, which we're so grateful for. And he learned about, and he had chest, meeting the pleural catheters, and later the insertion of the abdominal catheter so that he can learn how to manage it at home as opposed to going through procedures in the hospital. Brett went through multiple treatments, not only with the hope that it would help him, but the fact that hopefully it will help others because they can learn from these procedures that are being performed on him. And that was the quality during his life where he always provided support to others and was caring to so many of his friends and family members. As a true leader, he wanted to show his gratitude to the Mesothelioma Foundation, and he wanted to make sure that a significant donation from his estate would be established in creating this fund to help other misfortunate patients and their families for their various needs of what he believed in comfort care. So we're very, very proud to have established the Brett A. Rosenthal Fund, Patient Assistance Fund, in helping those in need, as we're very grateful to keep Brett's fight and memory alive, as he will always be in our hearts, and show our gratitude for the care, the direction, and the support that the Mesothelioma Applied Research Foundation provided for Brett. We want to thank Carolyn, we want to thank Julie, the entire Mesothelioma Foundation team for your care, for your love, for your cooperation, and the creation of this fund. We are so grateful, and this is on behalf of my daughter Dana, my son Aaron, my wife Sherry, and myself as Carl. We want to thank you all.
What a wonderful tribute, indeed. We have the pleasure of honoring a few specific volunteers and their contributions to the foundation. Our first award this afternoon is the Pioneer Award. This award honors individuals who are pioneering scientific advances in mesothelioma research, treatment, care, support, and advocacy. At this time, I would like to invite Dr. Tobias Peikert, co-chair of the Scientific Advisory Board, to present the Pioneer Award. Please welcome Dr. Peikert.
Thank you very much. And it's a great honor and a great pleasure for me to present this award today to a very well-deserving individual. And she certainly is very well represented in the line of prior recipients of this award as well. Dr. Marjorie Zauderer. She received her medical training at Columbia and then did her medical oncology fellowship at Memorial Sloan Kettering. And really, since that, has dedicated her career to mesothelioma. She published close to 80 peer-reviewed papers. the majority of these papers are actually dedicated to mesothelioma. In her capacity as a medical oncologist, she's provided care to many mesothelioma patients and has changed many people's lives with that. In addition, she's been a very active researcher, as is represented by these papers that she published. She's led a number of clinical trials, and her main focus has been to try to individualize the care for mesothelioma patients and really advance the care to hopefully get to a cure for this disease. In addition to that, she continues to serve and has served as the director of the board chair of the board of directors for the Mesothelioma Foundation, and in that capacity has really made a huge difference of keeping this organization alive and keeping it going as it has been for the last few years, and again has had a tremendous impact on mesothelioma as a disease. And so with that, I would like to present this award to you, Marjorie. This is
So I know many of the people here in the room, and those who I don't know, I'm happy to see you all here. And I'm not going to say much, but just thank you. And what I love about this organization and these conferences is that meeting with all of you and being here together reminds me what it's all about, right? Which is about the people we care about, family, friends, loved ones who have this disease, and making life and treatment and what happens to those folks better, right? And I think that sort of moment always grounds me. And this is my 15th conference, so I come every year, and that's what I always come back to, and why this organization is so special. Because for us as scientists and researchers and clinicians, it's one of the really unique, rare opportunities where we're here together with the people most affected. And many of us have personal connections to the disease, but we also get a lot out of coming together with all of you. So thank you for recognizing me in this way. I hate being the center of attention, but thank you. And I'm just happy that you're all here today.
Congratulations, Dr. Zauderer. The next award is the Klaus Brock Above and Beyond Award. This award is named for the first volunteer of the foundation. It is given yearly to an engaged and exemplary individual who has worked to advance the foundation's mission by sharing their time and talent as a volunteer. I would like to invite last year's recipient, Claudine Benmar, up to the podium to present the Klaus Brock Above and Beyond Award. Please welcome Claudine.
Thank you. Reading glasses. So Vicki could not be here with us today, so I'm accepting the award on her behalf. But just a little bit about Vicki, because she is amazing. Vicki Slagle started the John Slagle Memorial Golf Tournament in 2012 after she lost her husband to a 4-year fight with mesothelioma. She and her sons wanted to honor his legacy and life in a beautiful way through something he loved. That tournament just finished its 13th year, which is amazing, and it's grown exponentially each year. Vicki could not be deterred by COVID and kept the event afloat when many others fell through. Her constant commitment to her late husband and his memory has created a beautiful event full of love and honor that has raised well over $65,000 for the Mesothelioma Applied Research Foundation. So, yay, Vicki!
Thank you, Claudine. And again, congratulations to Vicki. Hopefully she's watching us on the live stream and is in the comfort of her own home. Our next award is the Bruce Vento Hope Builder Award, named after the beloved Minnesota congressman who lost his life to meso in 2000. The award honors an individual who, through advocacy, works to achieve our mission of eradicating mesothelioma. This time I would like to invite last year's award recipient, Jessica Blackford-Cleeton, to the podium to present the Bruce Vento Hope Builder Award. Please welcome Jessica.
Good afternoon. It is my profound honor to present the Bruce Vinto Hope Builder Award to a truly inspiring young leader, Mackenzie Thomas. This award recognizes individuals who bring hope to mesothelioma patients and their families through unwavering advocacy. Mackenzie's journey into mesothelioma began when her father, Colonel Doug Thomas, was diagnosed with pleural mesothelioma in 2020. At just 17, she faced the heartbreaking loss of her father, and shortly after graduating high school. Yet, in the face of this tremendous loss, Mackenzie found her voice and purpose. Now a political science and French major at the University of Notre Dame, Mackenzie has dedicated herself to upholding her father's legacy by raising awareness about mesothelioma and advocating for essential research funding. Her impactful journey began with an internship at the Mesothelioma Applied Research Foundation, where she discovered that mesothelioma had been excluded from the CDMRP funding list. Determined to change that, she reached out to congressional members and, at just 20 years old, advocated for the desperately needed funding. Her relentless advocacy helped to connect Senator Moran and Senator Chuck Schumer's office, leading to a renewed commitment to include mesothelioma in the CDMRP research funding. Not an easy undertaking. Even while studying abroad in Paris, Mackenzie has continued her advocacy efforts, proving that her dedication shows no bounds. As she prepares to graduate from Notre Dame this spring, we are excited to see how she will further her mission to bring hope and change to the mesothelioma community. Please join me in celebrating Mackenzie Thomas, a beacon of hope and unwavering advocacy for those affected by mesothelioma.
Thank you so much, Jessica. I know that I'm just going to get up here and probably bawl my eyes out, so I'm just going to make it known before I start. I just have a few things to say. I'm so honored to be here today as a member of this community. As you know, my dad, Colonel Doug Thomas, was diagnosed in 2020, and he passed away in 2021 when I was 17 years old. My dad, throughout our lives, my brother and I's lives, taught us this philosophy that he used in his Army career called the Thomas Leadership 6. And I just want to share these 6 things with you that he used in his career, with his soldiers, his family, and finally with his cancer battle. Number 1, be aggressive. Number 2, keep it simple, stupid, or KISS. Number 3, have the right attitude. Number 4, have moral courage. Number 5, keep your family first. And number 6, have fun. I've attempted to carry these 6 things with me throughout my college career, in all of my jobs, and when I was on the Hill last fall with all of you. That was an endeavor that felt so grand that I didn't think I would be able to do it. When my dad died, my life as I knew it was over. I remember telling him, as he was dying, that his story couldn't end here. There was something more, and I didn't know what it was, but I kept rambling on about something. There had to be some hallmark of achievement. There was going to be some big statue somewhere in his honor. And I just remembered that recently. Fast forward to now, or I guess last summer, when the people at this foundation had faith in me and they believed in me, in order to give me a job and also to help include me in this advocacy project that's so important to make sure that there's continued funding for this research for this relentless disease. So I want to thank the staff members at the Meso Foundation. I want to thank my dad's doctor, Dr. Ripley, who was the one to reach out to tell me that I should reach out to the Meso Foundation. And I want to thank the community here today. I have found such welcoming arms within this community with each of you here. And even though my dad isn't here today to share his own story, I know that he would have loved each and every single one of you. And his legacy lives on. With each of your stories, I remember why this is of such importance. And I hope you don't mind me being here and being a sob fest every time I get up and talk, because I'm here to stay. And I will continue to be here every year that I'm able to. Thank you again for having such faith in me and for inspiring me to be a force for good. All I can say is that this is something that's pretty damn good and pretty damn close to that statue that I told my dad that there would be in his honor one day. So thank you so much.
Thank you, Mackenzie. Thank you. I just had the honor of meeting this lovely young woman this morning, actually yesterday, and immediately was impressed when someone's a double major and one of them's in a foreign language. I can't even manage my own native tongue, let alone another foreign language. So always impressive. The next award was created just a year ago in memory of one of the foundation's biggest supporters, Bonnie Anderson. Bonnie was a 21-year warrior, relentless advocate, staunch supporter, and most gracious friend to the foundation and so many of its members. There's no better way to describe Bonnie than a changemaker. To present this year's Bonnie Anderson Award, Changemaker Award, I would like to invite up Bonnie's husband, John, and her daughter, Darcy.
All right, everybody. He's talking about Mackenzie crying. I'm going to break down. My wife passed away a year and a half ago, and it wasn't a good thing. Brian did a good introduction. As a reminder, we supported 4 full grants for this organization. We also, Bonnie insisted we invested outside in the biomarker field, outside the organization, and did investing in there to get things done. Besides throwing lots of money into this place. You'll hear more later. Bonnie was a terror on the Hill. We used to have our appointments with senators and congressmen, but there was also doors that were closed to us, and we used to go in our free time knocking on the closed doors and say, hello, is your medical liaison in? Someday I hope all you have a chance to do it and knock on those doors, because we used to call in South Jersey, do you live in this area? We don't know you. They didn't want to talk to me. But I showed up when it came to that issue. Bonnie was a terror. Never took no for an answer. Dealt with many doctors, worked with this organization. And I'll cut that short a little bit. Let's talk about the award that's going out, because I could probably talk for a half hour and Brian hasn't given me a bad look yet, so I'm happy. In 1206, was it 1206? And yes, Rich Moscow was presented with peritoneal mesothelioma. And I'm going from notes, cuts and pastes and so forth. And then what happened after that? Okay, I'm lost for a minute. Okay, Rich served many roles in the foundation. The board, the CDMRP, which you hear a lot, Congressional Direct Medical Research Programs, reviewer, patient advocate, and besides, through it all, Laura, his wife, was a supporter. Together, they met with countless newly diagnosed patients and their caregivers to mentor and give them hope through the tough battle ahead. They also met us on the Hill, and that's what started Rich and Laura going off, because coming back from our meetings with senators and congressmen, they started talking, and from there on, our friendship for many years. Family. This is such a strong family. It's phenomenal what they can do for you. So, they met Bon Johnny walking from Capitol Hill at the first symposium that Laura attended, recognized the need to volunteer, started by helping stuffing envelopes, which she doesn't remember, but Rich constantly reminds. And she denied it. So she said, no, I didn't do that. She was too busy monitoring Rich and stuffing envelopes. Okay. She advocates every year. She attends every symposium except for the COVID years. Represented the foundation at local fundraising events, all the while battling her own personal cancer. Gradually, Laura realized her focus should be on the caregivers. And all you caregivers, remember this. Don't take it from the patients. You are there. You are their soul. Guide people through all this traffic that you got to go through. And I'm throwing words in as I'm trying to catch them. All the while battling her cancer. Gradually, Laura realized, recognizing they are unsung heroes. Laura had new caregivers and spouses of mesothelioma patients throughout the years, leading a monthly support group solely for caregivers. She also was a founding member of the Community Advisory Board, which are several of us here are on it. So anytime you people need to communicate with the organization, besides going through all the avenues, come and join us. We also have community socials a couple times a year. Get on board with that so we hear you. We can have discussions. Meet your family again. Say hello. You're on California. We're in New Jersey. Zoom is a blessing. Okay, she is also founding member of the board. Okay, chair of the CAB. She's the chair. She's our police officer. I've been knocked down many times. Most of you that do know me understand that quote. As the advisor foundation on community needs and wants. She moderates caregiver call session, reaching out to newly diagnosed patients and recognizing their struggles, their fears, their doubts, and developing a supportive relationship with them. All these things while serving as chair of the Community Advisory Board. Laura, and I'm going to make this short, I got a lot of little notes and we're going to be doing something later. Laura is a definition of a compassionate and dedicated caregiver who worked tirelessly for the Meso community alongside me, my wife and me. John, okay, read my own notes. No one is more deserving as the second person to receive this award. And I'm done, come on up. If anybody else wants to know more, later. It's been many years. Family.
Thank you. Well, I'm just going to put that down.
I made it.
You did. Wasn't sure.
Huh?
Barely. As John said, first time we met Bonnie and John, Rich and I were walking back from Advocacy Day, and we hadn't met a lot of people yet. And John and Bonnie were on the street, and Bonnie was like, hey, you know, I know you guys. And she just took us in. And Rich always called Bonnie Hugs. And I guess I never asked him why he called her Hugs. He had her in his phone as Hugs, and he would say, oh, I have to call Hugs. And I asked him the other day, I said, why did you call Bonnie Hugs? And he said, because she said, I always have to give a patient a hug. So that every patient needs a hug. So I always give a patient a hug. And that's why he called her Hugs. And that's who Bonnie was. She always gave a patient a hug. She always reached out to every patient, anybody who needed anything. And John took away some of my thunder here, but she never took no for an answer. She would knock on doors. She would relentlessly pursue politicians, newspapers, anybody to talk about meso, to get that Meso Awareness Day proclamation, to get funding, to just get the word out about mesothelioma and awareness, and to make sure that everybody knew about the disease. Bonnie battled, unfortunately, lots of cancers, but meso was her main focus, and she always wanted to have everybody be aware and always looking for a cure and treatment and research. And as John said, they put their heart and soul and money into that area. When Rich was first diagnosed, I remember coming home from the hospital and sitting and doing what we all should not do and getting on the internet. And the stuff was not very pleasant. And we didn't find out about the foundation until much later into the journey. And it was a very lonely journey. So when we found the foundation, it was just so rewarding to be able to be with other people and have the support and, as John said, find family and friends. As John said, we became friends with John and Bonnie. It wasn't just our meso family, there was also friends. And that's why I've tried to give back over the years, because I took so much, I wanted to give back something also. So I'm very honored to be blessed with this, and thank you very much. And thank you, Bonnie.
My big feet are in the way. Okay. Thank you so much to John and Darcy and Laura. Congratulations. Again, to all of our awardees to this point, let's hear a round of applause. As I've said many times during the past 2 days, events like this do not just materialize out of thin air. They take a lot of planning and a lot of coordination and a lot of support. And that support often comes in the form of finances. And we have sponsors that are very true to the organization. Carolyn picks up the phone, reaches out, and asks for their assistance and support, and they respond. And they say yes, again, and again, and again. And so we are very grateful again for all of our sponsors here this afternoon. But there are two that I wanted to cast a special spotlight on. And one of them is Bellick & Fox. Bellick & Fox is a returning sponsor who has been with the foundation for a number of years, and they have again and again said yes. And that's unusual. Those of us who work in fundraising often get, call me again next year, or maybe, but they've said yes. And so to that end, they are one of our returning top sponsors for this organization, for this event, for this year. So again, I would just like to invite, is Joe Bellick in the room somewhere? No? Maya? He stepped out. Okay. Well, I got a chance to meet Joe Bellick on a phone call on my second week at the organization. And Joe is a warrior. Just like everyone in this room, Joe fights for what is right. And I was very pleased to meet him and to learn of their considerate support and their unwavering support for the organization. And the second organization we would like to honor today is a new sponsor to the organization, and that is the law firm of Dean, Omar, Branham, and Shirley. And I am wondering if Kathy is here. Kathy Farinas, I say that correctly? Farinas. We called. Dobbs responded. So again, I would just like to, on behalf of the foundation, on behalf of the board of directors, on behalf of the patients, on behalf of the caregivers and the advocates and everybody who contributes to this community, we thank you. We thank you from the bottom of our hearts, and we hope your support for many, many years to come.
Thank you for allowing me.
If you'd like to say a few words, you're welcome to. Please do.
We're running so far behind. I don't want to take up time. I just want to thank you for letting us be here and letting us and be part of this community, because it's so very, very important. And the people that put their trust in us to help you out in the kind of the worst times of your life sometimes. And that we don't take that lightly. So thank you so much on behalf of everybody at Dobbs.
And Joe Bellick will be part of the legal panel later, so we'll get a chance to say a few words as well. I'd like to bring back up to the microphone John Anderson and Maria Tao, who have a special call to action for the community around advocacy. and they will be our final presentation this afternoon, and then we'll move right into our next piece of business. So I'll give the microphone over to you guys.
All right. One thing or two things I didn't tell you about Bonnie. With a few people from the organization, they were able to institute September 26th as Mesothelioma Day throughout the country. Not a proclamation which you can do every year with your local politicians, governors, senators, and so forth. She was also able, and it took us 3 years of politics, to get September 26th in New Jersey as a permanent day, as a thing that was done. So I challenge you all, go after congressmen and senators and tell them what you need to do and what needs to be done. Now I'm going to tell you a thing about, it's on the screen, is June Bennett. She was with the organization from the beginning. My wife was here 23 years ago, the second and third year of the organization's start. And so was June. June used to go on Capitol Hill. She was a terror. And she had pleural mesothelioma. And she still smoked to the end. She smoked. She used to go to the symposiums. Then the hotel used to holler at her because they booked her extra for smoking in the room. She didn't care. Her doctors told her, you're not smoking. This is the last good thing in life. I don't care. So if you have a few quirks that you like, go for it once in a while. Enjoy life for a day. If you need a cocktail and you're not allowed to have it, go out to that back porch and have a couple. Your doctor will forgive you once in a while. Don't make it a habit. So June went on. And then what happened as things went on, June passed away. She used to drive around in a Segway after a while and then go hopping around and get to the steps and people would help her. And you can't go to this park with that. Well, guess what? June was a warrior also. When she passed away, the coat was passed on to my wife, Bonnie. When Bonnie was on Capitol Hill, this is where we have previous patients that have died from mesothelioma. If you would like to join, if any of your spouses that have passed away from meso or people you know, you're more than willing to pass on to Maria some pictures of your spouse, and we're going to get them on the jacket because Maria does go on Capitol Hill. She's been there, and that's why she's got this award. So I'll let Marie talk. She can put it on. She's the model of the day. And we just wanted to tell you about June. You see the pictures? This is when, there would be we have 5 busloads of people going on Capitol Hill back in the early days when asbestos was really on top of the media. And this is what we used to do. We were very outspoken.
John is a very hard act to follow, and in the interest of time, I'll keep it short. But last year when he gave me this jacket, I was speechless, and I still am today because I just know the legacy of June, the legacy of Bonnie, and this, I feel like, is a legacy that belongs to everyone in this room. It's a jacket that belongs to the community because it represents the people who have lived through this experience in all different, as a patient, caregiver, bereaved member. So I just want to figure out how we can give this jacket to the community so it stays in the community to be a symbol of hope, inspiration, and proof of all the hard work and dedication this group has done. So if you do want to have your loved one on the jacket, please reach out to me. And we'll figure out how to get a photo and how to add people to this jacket who deserve to be honored and remembered.
Okay. Go ahead, Doris. And this was in discussion, and my daughter, if she stops crying.
You can stop. I'm good. I'm good. So on behalf of the organization, as a board member, as a caregiver, as a daughter, I'd like to ask you to consider advocacy of the organization itself. I give to the organization every year, as have my parents through the years. If you can give a little bit or a lot, we do ask that you help fund the organization throughout the years. I wanted to commit to the organization that over the next 6 months, between Dad and I, we will give $20,000 to the organization. The reason I wanted to get up in front of everyone especially is my company match is 2 for 1. I happen to work for a wonderful company that does that. But if you give to the organization, if you're able and willing, also make sure you look at your company match sites, because you can double and triple the money that goes to the organization just by either putting your credit card into their system and going through them right to MARF, or by submitting it after the fact. So I just wanted to remind people of that. We reminded our board yesterday as well, but company matches are a really good way to get some extra funding to this organization. The money comes back to all of us in one way, shape, or form, and research. You know, we were talking about grants this morning. So there's lots of opportunity to help the organization between fundraisers, direct contributions, and we have wonderful Carolyn to work with on that. But I wanted to kind of get up and say, we're going to make the commitment over the next 6 months, probably shorter than that, but we'll figure it out, for our donation, and then just to ask, whoever could join along. And don't forget the company match.
And as usual, I always have something to say. Well, keep the fight on. Don't give up. Keep going forward, please.
I'm taking John with me to Capitol Hill next time. So this concludes our award portion of our afternoon. Let's take 10 minutes, and if we could, I know that the staff of the summit would like to help, would appreciate a little bit of assistance in clearing out what's in the room in terms of plates and cups. There are carts outside of the doors. If you are going out for just a few moments, please feel free to put your plates there. And we'll reconvene here at 2:30. So give us about 8-10 minutes or so, and we'll be back at 2:30 with the rest of our program. Dr. Zauderer will be presenting.
He's back in the room now.
She was over there, so I bet she stepped away.
Okay.
Good.
We'll get Joe Bellick at the panel.
Okay. He walked in right after.
I know. Okay, folks, welcome back. If I could have you take your seats, and we'll continue with our presentations. We're moving on to the clinical trials realm. If you could please join me in welcoming Dr. Marjorie Zauderer, who is the chair of the Foundation Board. And she is from Westchester Medical Center to discuss immune checkpoint blockades and targeted therapies. Please welcome Dr. Zauderer.
All right, thanks everybody. It's always a little bit hard to think about this talk in the context of you've already met with a bunch of other people already today, and you've heard snippets of the things I want to cover. So I'm going to go quickly through, the things that'll be review, and try to spend some time on focusing on the novel information. By no means am I presenting a comprehensive list of all of the ongoing studies in this space, but kind of walking you through how I think about this and how I think about whether a particular clinical trial is something that I want to get involved with or that I would recommend a patient go and seek out somewhere else. So we're going to start with the checkpoint inhibitors. So I know you've had a great talk today already about sort of where checkpoint inhibitors fit, but I want to hone in a little bit on a conversation about how they actually work. So I hope you guys will indulge me in this short video.
Our immune system protects us from disease, killing bacteria and viruses. It also helps fight cancer. A T cell is one type of immune cell that does this. T cells have proteins on them that turn the immune system on when it needs to fight infection, and other proteins that turn the immune system off when it is no longer needed. These are called checkpoints. Cancer cells can trick the immune system by turning the T cell off, stopping them from recognizing and attacking the cancer cells. Drugs called checkpoint inhibitors turn the T cells back on. So they can recognize and attack the cancer cells. For more information about checkpoint inhibitors, click here.
Quick overview of how the checkpoint inhibitors work, and everything always sounds better with a British accent. So, and it also had captions in case the sound didn't work, because that's the first time I've actually embedded a video in PowerPoint. So my kids had to show me how to do it. So just to take a little bit of a deeper dive into what we're talking about here. There are multiple different checkpoints in this immune system. It's the whole training camp. It's the whole kit and caboodle that teaches your immune system when to act up against something versus when to say, oh no, this is pancreas. It's supposed to be here. Don't attack it. So 2 of those checkpoints are PD-1 and CTLA-4, and we focus a lot on those because we have drugs for them. We have lots of other checkpoints with drugs that are in development. There's one for something called LAG-3, all these different things. And those are all still being studied for the most part in early phase clinical trials where people with all sorts of tumor types come on. And there's nothing yet, I would say, that's compelling that one of these other checkpoints is going to be the winner and going to have a great new drug that's better than the existing ones. So what do we have right now? We have the CTLA-4 inhibitor ipilimumab. For PD-L1 directed therapies, we have atezolizumab, which had a really good study done with it along with bevacizumab for peritoneal disease. We have durvalumab, which has been the subject of these trials all built around the name DREAMer. And then we have the PD-1 drugs, which are nivolumab and pembrolizumab. And again, you can see here in a sort of still version of a cartoon how the drugs come in. And so they don't really turn on the immune system. What they do is they undo the cancer's ability to suppress the immune system. And as many of you also know, they can cause a lot of different side effects. So this is all came from the Checkmate 743 trial, and that was the study that took those two drugs, the ipilimumab, the CTLA-4 inhibitor, and PD-1 nivolumab, and combined that against chemotherapy, and the immunotherapy for most people was beneficial. I put this slide in here just to highlight the fact about toxicity. So these columns here are the immunotherapy, and this was the chemotherapy. And increasing grade of toxicity is increased severity. So we consider a grade 3 or 4 a very severe toxicity, because grade 5 toxicity is actually death. So 3 and 4 are pretty serious. And what you can see here is there were actually more treatment-related deaths, small absolute numbers, but more than twice as many with the immunotherapy. So one of the challenges is that people will have side effects. When we release that inhibition of the immune system, sometimes the immune system then attacks not just the cancer, but it attacks things that should be there in the body. So the question has been, well, how do we improve beyond that? So then there were some studies that looked at combining chemotherapy with one immunotherapy drug. So maybe you get the benefit of the chemo, you get the benefit of the immunotherapy, but not without as much side effects. What you can see here again in that study with the combination is that chemo and immunotherapy was more toxic substantially than chemotherapy. I think if it had been massively improved activity, that would have been more of a conversation. But the differences were there, but they were small. So what this has left us with is, in the treatment guidelines, you can kind of do anything. You can do chemotherapy alone, you can do 2 immunotherapy drugs together, or you can do chemotherapy with immunotherapy. So how do we improve on that? So this is where we come to the current clinical trials. There's a drug right now called volrustomig, and that's a drug that targets both the PD-1 and the CTLA-4 at the same time. And the idea there is that because it has to bind both things, and if you think back to the cartoon, they were kind of separate in space, those 2 receptors. If you have to bring them in close proximity, the idea being that that's going to disproportionately only happen when there's a cancer cell where it's taking advantage of both of those checkpoints. And so normally in the pancreas and the colon and the other places that can get inflamed, you wouldn't necessarily have CTLA-4 binding near PD-1 binding. So by localizing that in one molecule that has to bind both things at the same time, it could have that same effect on cancer with potentially not having the same amount of toxicity. So there's a new clinical trial. It's called Evolve Meso, and that's for folks who haven't yet gotten any treatment, and you're randomized either to get this volrustomig drug with chemotherapy or get standard of care. And standard of care is at the discretion of the doctor that's treating you. And this study is looking to treat folks and then see if by getting the advantage of combining immunotherapy with chemotherapy, but using 2 drugs, but hopefully with less toxicity, if we can still get some of that benefit, but mitigate the complications that can arise from that. So that study is actively recruiting elsewhere, and in the US, the first few sites have actually opened and are screening patients. There are also some other recently completed or ongoing clinical trials actually done by many of the people who are here at this conference, but really looking about how to integrate immune therapy sort of around the time of surgery. So there's clinical trials looking at giving immune checkpoint drugs before surgery, after surgery, before and after, combining it with or without chemo, and with or without additional drugs like bevacizumab, which you may have heard about this morning. There's also just a very newly open study that Dr. Ripley is running, looking at immunotherapy around the time of surgery. So that's where the conversation has focused, where while we're waiting for this new trial, the Evolve, to accrue, and also to figure out, remember, to keep in the back of your mind those other checkpoints that people are developing drugs for. But I think that really summarizes most of what's going on at this moment in time related to checkpoint inhibitors for mesothelioma. So the second thing that folks asked me to touch upon was targeted therapies. So the way targeted therapies work, it's a little bit of a misnomer, right? Even when you get a chemotherapy, it's targeting something, right? But we use the sort of euphemism of targeted therapy when we're going after something that we think is only or excessively disproportionately expressed in a cancer. And so what you can see here, there was a collaborative effort called the Cancer Genome Atlas, where hospitals all around the world, through the generosity of patients, donated some tissue, and it was all profiled and sequenced and looked at all of the different genes we know to look for to see what kind of mutations are there, what kind of genes are deleted, abnormal, and can we go after some of those abnormalities, right? So if we know in a particular person there's a messed up expression of a certain gene that leads to a misshapen protein, can we then come and give a drug that targets that misshapen protein? Or somewhere else, if there's a loss of a gene, so you don't make that protein, and therefore you become totally dependent on some other pathway, can you then inhibit that other pathway and then make that cancer cell uniquely susceptible to your intervention? So these are the data as we see them in these publications and projects that we participate, looking at different profiles of patients and the gene mutations. And so these are looking at genes that actually have an alteration versus here there's more or less expression of a particular gene. So one of the pathways that really shook out from a lot of this research, and there's been a lot of focus on over the years, is something called the Hippo pathway. And it's a cascade of signals, a lot of which has to do with something called NF2 or Merlin. But here's a little kind of graphic. But basically what happens is this all cascades down, all of this signals competing in the cell for attention to basically communicate, should this cell copy its DNA and divide and continue to grow? Or are the signals overwhelming that it should just stay as is? The ongoing copying of the DNA and cell division, that's what makes a cancer or any cell in the body grow. So all of these pathways you may be able to see here kind of come down to something called YAP-TAZ and TEAD. And those are things that actually engage with the DNA and the proteins involved in unwinding and copying the DNA to either turn that process on or to block it. So there's been a lot of focus now on looking at if we can inhibit these types of proteins and enzymes. So there's one drug that's been reported recently, and it's still early. It only has the letters and names. It's called VT3989, and this was presented at one of the meetings last year. And this drug actually had a substantial effect on mesothelioma tumors. So this is what we call in research, we call this a waterfall plot. So places where the bars go up are showing you the amount a tumor is growing, and the places where the bars go down show you the amount a person's tumor burden is decreasing. And what you can see here is that there were a fair number of folks who had tumor shrinkage, and there was actually people with both pleural and peritoneal disease who had their cancers shrink. So this has generated a lot of interest, and there's actually a lot of other molecules in this space. So I looked this week to see, in addition to the drug from the company Vivace, which is the VT drug, there's all of these other 5 drugs from different companies, all in slightly different clinical trials, some of which are focused on mesothelioma, some are focused on tumors that have alterations in this Hippo pathway that ends at the bottom with the YAP-TAZ, but they're all studies I am keeping an eye on and I think are interesting for folks with mesothelioma. And certainly there's additional new ones that haven't launched that are definitely in development and in conversation with many of the researchers about how to best design studies in this space. So One of the other common alterations that we see in mesothelioma is loss of this gene called MTAP. Again, another cartoon that you can see here, but basically MTAP does a very, very critical function in cell cycle signaling. And when you lose MTAP, you become entirely dependent on the backup mechanism, which is done by a molecule called PRMT5. So if the cell doesn't have MTAP, and it's totally dependent on PRMT5, and then we give a PRMT5 inhibitor, we can shut that cell down, hopefully. So there's a whole space of drugs that are targeting PRMT5 for mesothelioma. So I'll show you pictures from 2 patients that received this drug, Mirati 1719, a PRMT5 inhibitor. And what you can, and I tried to show you here, but this is what scans look like at baseline here on the left. So this is, you have to imagine the person sort of lying there with their head, and the left and the right are on the opposite side. So this is the left side of the person's body. This is the right. This is the front of the chest. This is the spine. This is the heart and the aorta and all the things that are supposed to be there. But this sort of gray blob with the red arrow, that's the cancer growing. And what you can see here is in this person, they got treated with the Mirati drug, and then it really, really shrunk down, and you can hardly really see anything in that same space. And similarly, a different patient on the same study had this growth of an abnormal kind of area here where this red arrow is, this sort of gray blob again. And here it's not gone, but it's definitely shrinking. So this drug was actually recently acquired by a bigger pharmaceutical company, Bristol Myers Squibb, and they're in the process of trying to figure out what their next study for mesothelioma is going to look like and where they're going to focus and how they're going to develop it. But I think this is very encouraging data for mesothelioma. And then the last thing I'm going to talk to you about is something a slightly different kind of perspective on targeted therapies. I hope you'll indulge me. So one of the things we think about, and often is my mentee who works at Memorial Sloan Kettering, but one of the things that he and I have been working on for quite some time is figuring out, well, how can we iterate faster, iterate better? And one of the ways to do that is to build better models. So what we've done over the past 9 years now is I've been collecting, again, through the generosity of patients coming to us for care, but at the time that someone's having a biopsy, getting an extra little nip of tumor. And then we take that to the lab and we try to grow it in a mouse. And so we can create a model of Mr. Smith's tumor in a mouse, and then we can preserve that, we can replicate that, and we can test some of these hypotheses that we make. Like if you have this mutation, then that drug might work. And we can create actually a huge library of different tumor system models with all sorts of variations and combinations of this mutation with this deletion. And so we can go when we have a question and go to our library and say, hey, I want to know if this type of a drug, let's go back to that Vivace drug. If Vivace drug seems to be working in NF2 mutated mesotheliomas, but what if there's also deletion of this gene? Will that respond or won't it? And we can actually start to study that and probe that in these model systems that we build. So one of the interesting things we found related to something called TROP2, which has been talked about and studied in lots of different cancers, but not so much until recently in mesothelioma. And what you can see here are just some ways that we think about when we induce the expression of TROP2, what happens to cells, and when we suppress it, what happens. And what we were able to show in these mesothelioma models is that it really is important in the development of cancer and then the propagation of cancer. So then what did we do? We took a drug that targets TROP2 and we tested it in these mice systems that we had built. And so these are the types of experiments we do where we measure the volume of a tumor in a mouse. And so you can see here, here's just the mouse without any special treatment. Here's the mouse in red who gets a chemotherapy called gemcitabine. And then here in green, you can see the mouse when they got treatment with this drug called sacituzumab that targets the thing we're looking at, which is called TROP2. So, and we were able to show that even in tumors that didn't express a lot of TROP2, that inhibiting it was meaningful in terms of stopping the cancer from growing. I think what's interesting here is that you don't really see regression, which is a feature of how some of these models work and the way the mice are raised and grown and sacrificed. But you definitely see here some slowing of the growth. And here you actually see it really stops growing and that persists. So that for us became the justification to go to companies that manufacture drugs that target this and say, hey, we have this really interesting preclinical data, right, from a living model. We can replicate in cells, we can replicate in mice that this drug is working, and we think we know in which types of tumors and why. And will you help us run and support a clinical trial? So a trial that is just opening this fall is giving one of these TROP2 targeted drugs. This particular one we're working with is called sacituzumab, and it's giving it to people who have mesothelioma that expresses the TROP2. And that's really how we go from an idea and an observation to bringing a trial to fruition. From support from the pharmaceutical companies, support from the federal government, through a DoD grant. And this is a study that's launching as we speak that should be interesting to follow based on some of the preclinical data. And I think that that's just a really concise example of sort of how we get to the trials that wind up being executed and designed. So I think I'm going to leave it there and just, of course, thank everyone, all the patients, all the families, the caregivers, the folks who, show up and sign the extra forms and let us take the extra punch of a tumor and the extra tubes of blood. And I know sometimes it seems so remote and abstract, but it really does fuel the advances in really important and meaningful ways. And then, of course, thank you to all the people that fund our research, the pharma partners, the federal organizations, and also the Meso Foundation for gathering everybody together and trying to do this work. Thanks.
Thank you, Dr. Thank you, Dr. Zotterer. We have a next presentation is by Dr. Melina Marmorelis from the University of Pennsylvania, and she will be discussing anti-angiogenesis, thank you, little tongue twister, and viral and neoantigen therapy. So please welcome Dr. Marmorelis.
Thank you. Awesome. All right, there we go. Got it.
Just go to present.
Yeah, I can do it right here.
There you go. And if you want the electro pointer, it's right there.
Electro pointer. Oh, okay. I got it.
I'll just get it set up for you. So just do that, and it's there. Okay.
Wonderful. Thank you. I'm so happy to be here with you all. I'm Melina Marmorelis. I'm a medical oncologist at the University of Pennsylvania. I'm going to be talking about two different topics. The first one is anti-angiogenesis in pleural mesothelioma, and I'll tell you a little bit about what that is. Those are my disclosures. So first, just what is anti-angiogenesis? So this is a picture of a tumor, and the tumor sends out a signal that we'll call VEGF, vascular endothelial growth factor, and it sends it out into its environment, and it says, I need more food. Please grow blood vessels to bring me food. So here we have our food truck that's bringing the food to the tumor through now new roads that the tumor has basically signaled to create. And when we talk about anti-angiogenesis, we're talking about actually blocking that feed me signal. Is there a way that we can stop that signal from being sent or stop it from being received? So there are several drugs that work on this. The most common one is bevacizumab, which is an anti-VEGF antibody. And when that's successful, then we have less of the actual blood getting to the tumors, and they grow. Their growth is slowed. So we also call anti-angiogenesis anti-VEGF. So I'll refer to them in both interchangeably. And the first thing I'm going to talk about is combining anti-angiogenesis with chemotherapy. And that's really where this all started. So this is a study that was done in France. It's called the MAPS study. This was a combination of bevacizumab, that's that anti-VEGF drug I was talking about, and chemotherapy. And they were really asking the question, we know that chemotherapy can be effective in mesothelioma. What if we add this drug? So they had a group that got the drug and a group that didn't. And they found that those that got the anti-VEGF drug actually had better survival. And it was one of the first studies to show that adding something to chemotherapy actually was improving survival. So this was actually a really important study, but it was published back in 2016. So this is something that we've been building on. In terms of the next steps, the next question that was asked was, okay, that was the first treatment with chemotherapy. What about some of the chemotherapies that we use as a second treatment or a third treatment? So this is gemcitabine, a very commonly used chemotherapy, not usually as the first treatment, but maybe as a subsequent treatment. And they added an anti-VEGF drug again to that. And they saw again that there was an improvement compared to people that got only the chemotherapy, and again, an improvement in survival. So it's starting to sound like this is actually, a fairly effective drug and can be combined very safely with chemotherapy. So the next question is, what else can it be combined with? Can we actually use immunotherapy, which can be a very effective treatment in mesothelioma? And the answer is yes. This is a recent study looking at pembrolizumab, which is an immunotherapy, and a pill actually called lenvatinib. This was a study done in Europe. And I just wanted to highlight, here in the star, I mentioned that these patients did not have any prior immunotherapy. So, here in the U.S., the combination of ipilimumab and nivolumab is a very common combination that's either given as the first or second treatment to probably the majority of people with mesothelioma. They have a little bit more stringent rules in Europe, and so they actually had a population of people that had never seen immunotherapy before, had never seen that combination. So these people got one single immunotherapy, and they added a drug, lenvatinib, that has some anti-VEGF properties. So again, blocking that feed me signal to the tumors. And again, I think Marjorie showed you some nice versions of waterfall plots, but anything now going down and mostly here in the green means that the tumor is shrinking compared to what it was at baseline. And for this particular trial, they look at a cutoff of 30% of the baseline. It shrinks by 30% of the baseline, and about 45% of patients did actually, meet that cutoff. But even still less than 30%, there were some that had a nice response. So just a side note that they also actually did a trial like this in peritoneal mesothelioma, which, as you guys have been hearing probably throughout the day, this is a very difficult thing to do. It's very difficult to run a trial for just patients with peritoneal mesothelioma, and this was 20 patients run out of MD Anderson, and they combined an immunotherapy called atezolizumab, so very similar to our other pembrolizumab study, and they added bevacizumab, which is an anti-VEGF. And they again saw that about 40% of patients did have that nice, greater than 30% reduction in the size of their tumors. So again, showing that both the combination of chemotherapy and anti-VEGF as well as immunotherapy and anti-VEGF can actually be quite promising. Now, the two trials I just showed you with immunotherapy, unlike the chemotherapy trials, they didn't have a control arm. So they didn't have an arm that just got immunotherapy. And we know that immunotherapy on its own can also be effective. So there was no comparison there. But still, the numbers that came out of those small trials were definitely encouraging. So in oncology, we like to add things to other things. So the question was asked, if chemotherapy and anti-VEGF is helpful, and immunotherapy and anti-VEGF is helpful, what if we combine all of them together? Can we get more here? And in fact, is there synergy? So there are some preclinical studies in animals and in samples from patients that have shown that combining, in particular the anti-VEGF, can maybe make the delivery of immunotherapy even better. So in addition to reducing the roads, you actually are making the roads that are already there more normal. And so maybe your drug is actually getting to the tumor in a better way. That was the BEAT-MESO study, which was chemotherapy, bevacizumab, and plus or minus immunotherapy. That was presented last year at ASCO, so last June. And that was 400 patients that had never received any sort of surgery or treatment. So this was their first treatment. And those that received the whole combination had a numerical improvement in their recurrence rates, but they did not see a survival advantage compared to those that had just the chemo and the anti-VEGF. So it was a little bit of a mixed result, but certainly something to pay attention to. And just looking back kind of at some of these trials that we've mentioned, I just wanted to bring this figure up. So I think the overall message here is that histology, the subtype of mesothelioma, is so important in determining which treatment is the right treatment. And this is also important in how we interpret clinical trials. So I've put up here a few clinical trials. The BEAT-MESO clinical trial, which we just talked about, is the combination chemo, immunotherapy, and anti-VEGF, but then some of the other trials looking at chemotherapy plus or minus immunotherapy or chemo versus the double immunotherapy, Ipi/Nivo. And what this shows is that everything, I guess I have my little laser. Let me see if I can get it out. I didn't see it moving last time. Okay. Yeah, okay. Everything on this side means that it favors the arm that has immunotherapy in it, okay? Everything on this side means it favors the arm that had only the chemo. And if it crosses this line in the middle, it means you can't tell. It means there was no definite yes or no. So what you see is, and I've split it up by histology, so you have epithelioid, non-epithelioid for each trial. So what you see is each of the non-epithelioid groups are, very squarely in the group favoring immunotherapy, whereas the epithelioid groups, they are, certainly on the side of immunotherapy, but they're crossing that line. So all of these trials that were positive, they were positive because the non-epithelioid group did so much better in the immunotherapy arm. So where does that leave us? And I know this is a little bit of a segue from what we were talking about before, but I think it leaves us with a lot of different treatment options in both of the subtypes, including a lot of the ones that I've mentioned that include anti-VEGF. So in the epithelioid group in particular, we have an array to pick from, but we don't have good evidence that one is better than another. In the non-epithelioid, we certainly have some evidence that containing immunotherapy, at least initially, is probably a good idea. So with that, I will say thank you. I'm leaving you with a quote from Leonard Bernstein, who is a little known fact, actually he had pleural mesothelioma near the end of his life. He said, to achieve great things, two things are needed, a plan and not quite enough time.
Thank you, Dr. Marmorellis. Any questions for Dr. Marmorellis? Any questions? Right here. Here you go.
Yeah, hi. Lots of the clinical trials is for newcomers, not assessed. What about this group where?
Yeah. So, for instance, the trial looking at gemcitabine actually was in people that had already had at least one prior treatment. So that was one looking at subsequent treatment after the first treatment. I will say the other ones, you heard a lot about, Dr. Zauderer mentioned many of the other trials in that space looking at some of the targeted therapies. I would say that's one of the biggest areas that has grown over the last few years, the TEAD inhibitors, the PRMT5 inhibitors, things that are actually starting to target aspects of mesothelioma that we haven't been able to in the past. And probably the other big group are the cellular therapies, the CAR T cell trials. Those are certainly in subsequent therapy, the subsequent line of therapy spaces. And then actually it's like you're a plant, because I'm going to talk about another group of trials. Yeah. Unless there, yeah, thank you. Unless there are other questions.
Thank you again, Dr. Marmarellis.
Okay. All right. So, no worries. Would you like to introduce her? Okay. So I'm going to talk about viral and neoantigen approaches. These are slightly a little bit different than what we've talked about before. So we'll get right into it. Those are my disclosures. So oncolytic viral therapies. So there are two main components to this. One is you need a way to target a tumor and not normal tissue. Okay, you can't just inject something into a patient that is going to attack everything. You need it to be somewhat specific to the tumor, and if you're going to preferentially kill the tumor. It turns out viruses are actually very good at that, and there are a number of reasons why. But viruses that have been modified, so they're not going to be ones that are causing like the common cold, but then been modified so they're not replicating as fast, actually preferentially will go to a tumor. So when this was figured out, they said, well, we could use this to our advantage. We can actually, create some cancer therapies. So they developed a number of modified viruses. There are two main ways to deliver them. You can give it through an intravenous delivery, through an IV. But actually in mesothelioma, they said, well, why don't we just give it directly to where the disease is? Why don't we put it into pleural fluid that's right there touching along the lining of the pleura? So that we'll talk a little bit about that. And then what is the virus delivering, right? If you can get it to the right place, what is it actually going to give to the tumor? And it's a variety of things, but in most cases, the ones we're going to talk about are actually delivering something that causes a lot of inflammation. So it's a little bit like a local immunotherapy. It's trying to stimulate the immune system, but right where the tumor is. And I see Dr. Sturman in the audience. But there was a very exciting version of this, which was an adenovirus expressing interferon, so another thing that's causing local inflammation and local immunotherapy. This was given through, into the pleural space through a Pleurex catheter, and they saw really nice preliminary activity. So again, here we are with that waterfall plot. Anything going down means that the tumor is shrinking. And this was really exciting. They started a phase 3 global trial. There are a number of, there's some media about it, and the trial opened for patients that had, had more than one prior therapy. And unfortunately, it closed early. It was very hard to actually accrue patients to this. And one of the things that came out of it is that we started to realize that actually we were seeing fewer and fewer pleural effusions. Fewer patients actually had that fluid around their disease, around their pleura, which was required in order to deliver this drug. So that might be part of the better effective treatments for mesothelioma. We're seeing or better and effective treatments for pleural effusions. We're seeing less fluid than we were before, but it was a barrier to actually seeing if this drug was going to work. So unfortunately that trial closed. There is another approach, which is the Wilms tumor protein vaccine. So this doesn't involve a virus, but it does involve essentially a peptide vaccine, which means like a protein that's being injected. And WT1 is not expressed at high levels on normal cells, but it is present at pretty high levels on pleural mesothelioma. So it satisfies that targeting criteria. Can we target the tumor over normal cells? That's why it was a really nice candidate for that. And peptide vaccines basically, if they're injected into the body, they are disguised as cancer to stimulate the immune system. So if you pretend that it's little pieces of cancer floating around, your immune system then all of a sudden picks that up and attacks your actual cancer. So that's the idea behind it. So there was the first study that looked at this, looked at it after surgery in pleural mesothelioma. And what they saw was that numerically, there were improvements in the recurrence rates and in survival. The study was very small, though. So they ran another study out of Memorial Sloan Kettering that looked at it in the setting outside of surgery. So this is now, patients that have had other therapies and then move on to this therapy. And they have treated about 10 patients, have seen mostly stable disease, and safety-wise, it was well tolerated. So I was hoping Marjorie was going to be here to tell us the status of this, but this is something we'll look out for, and this was combined with immunotherapy, so putting a peptide vaccine together with immunotherapy. And then many of you may have seen some of the press releases over another cancer vaccine called UV1. This is targeting something called telomerase, which is part of the cell machinery. And this was a study, about 118 patients in Europe that after chemotherapy, so after first-line therapy, got immunotherapy plus this vaccine injected versus just immunotherapy alone. And actually, the preliminary results looked really great, and the FDA, approved it for fast track as an add-on to Ipi/Nivo back in February of 2024. But then the trial, unfortunately, didn't really see a significant difference, not a statistical difference. So I don't know where this stands. I know they had another first-line trial planned, and I haven't seen the full results of that. So again, I'd like to thank you for your time and all your contributions and for being here today.
Thank you. Any final questions for Dr. Mamourelis? Oh, there we go.
Hi. Would you mind talking a bit about the mRNA vaccine? So I see that in Europe it's been rolled out a lot, especially for lung cancer as a potential treatment. And I'm just wondering, on the back of, if it's for lung cancer, can there be research into our cancer too, to use that technology?
Yeah. So the mRNA vaccine, so this most recently and most successfully has been shown in melanoma. So there is now actually an approved vaccine in melanoma. In lung cancer, it's still experimental. It's still something in clinical trials, and there have been discussions about applying that to mesothelioma. It depends a little bit about how they structure the vaccine. So they have to pick certain targets. And if those targets are similar in lung cancer and in mesothelioma, the same vaccine could actually be used in both diseases. But I think we're still in a very early phase of those, but I know there definitely are discussions about whether that's possible. Yeah.
Anyone else? Oh, over here. Okay. I feel like Phil Donahue here. He has better hair.
Yes, over the course of the last couple of days, I didn't hear anything about T-cell exhaustion. Is that still a factor?
Yeah, that's a great question. So T-cell exhaustion basically refers to, we've been talking about stimulating the immune system, right? But everything gets tired. So the immune system also can get tired. And so this is something that's been looked into a lot in lung cancer, is if you have exhausted T cells, no matter how much you stimulate them to respond, they're not going to respond. I don't think we have solved that by any stretch of the imagination in lung cancer or in mesothelioma. But there are certainly things that we're looking into. So in lung cancer, we recently published a study looking at adding a JAK inhibitor, which is actually an immunosuppressive agent. We gave it for 6 weeks in patients that were getting immunotherapy. And what we saw is that we saw fewer exhausted T cells when we gave them a little bit of a break. So I think that type of an approach would be really interesting in mesothelioma, and I think it's definitely something we have to pay more attention to, but I don't think we have clear answers on it.
We have one more question, and then we'll move on to our next presenter.
Thank you very much for your presentation. My question has to do with long-lasting effects of some of the peptide vaccines and whether or not there's been a look back at those studies?
I don't know the answer to that. The WT1 would probably be the one that we would have the most accessibility to. So I'm not sure, but in general, the studies on peptide vaccines, I have not seen safety signals that have been concerning, but I think your question is more to not the immediate safety signals, but perhaps the longer term safety signals, and I don't know. I don't have a good answer to that.
Thank you. Final show of gratitude for Dr. Marmarellis. We're going to juggle up our presentations just slightly. Dr. Dan Sturman needs to head to the airport, and Dr. Woodward has graciously allowed him to swap times with her, so he will be going first. So I'd like to invite Dr. Dan Sturman from NYU Langone up, and he'll talk about how to read data and studies.
So good afternoon, everybody, and thank you to the organizers for having me here today. I think this is 25 plus years that I've been involved with this organization, nearly the beginning, so I'm getting younger. I don't know how that works, but I appreciate being here, and this is always one of my favorite medical conferences of the year because the ability to interact with my colleagues in science and in medicine, with patients and with families is incredibly unique, and thank you for all of the questions that you've asked so far. My goal today is actually a lot easier than all of the preceding speakers because I'm going to just tell a story about development so you can understand what it takes to actually get one of these trials done and ultimately, hopefully, get a new treatment for you. And some of what I'll be talking about, you might have already heard from the previous speakers, including Dr. Marmarellis, who gave a great overview of many of the trials that we had done when I was at the University of Pennsylvania. I'm just telling you a little bit about a story about how we develop trials and then a little bit about how to interpret the studies. When you're reading and hearing about them, it's important to be able to discern, especially if you pick up a medical journal and trying to read that medical journal and trying to figure out what it's trying to tell you. There's a lot of nuance there that's really important, some of which you've heard already today. So these are my disclosures, nothing directly related to this specific talk. But just an idea, when you're thinking about clinical trials and enrolling in clinical trials and thinking about drug development, you're hearing about this new thing that's in a mouse and you can't wait to have it that you can use for yourself or for your loved one. Remember that the timeline from first concept for development of a new drug or a new agent, a new therapy, to actually getting to the patient for routine clinical use is incredibly long and complicated. And it's longer if you're initiating this process at a university, at a medical school, than it is in industry, in a pharmaceutical or biotech company, but it's still, in either way, it's a long time. And the process, we hope, is going to get shorter over time, but it is long. And so we ask your patience with us as we go through this process. And just as you're thinking about the different types of studies, it's important to understand the nuances and the size of the study and the timeline in which these take. So we hear about phase 1, phase 2, phase 3. Some of you may hear about phase 4 clinical trials even. And remember that a phase 1 trial is a small study, generally in mesothelioma, probably closer to 20 patients or maybe even fewer. Takes several months to a year just to enroll all the patients in that study, maybe sometimes a little bit longer. And the primary purpose is safety. Is this new drug that we're testing, is it safe? Phase 2, maybe more. In mesothelioma, probably 50 to 100 patients, maybe. May take a couple years to get that phase 2 study done. And we're looking at some safety, but mostly you're looking, does this work? Is this effective? And then phase 3 in mesothelioma, probably closer to a couple hundred patients, not 1,000 to 5,000. Those are more for hypertension studies or diabetes studies, but they take several years to do a phase 3 trial. And this is where you understand whether something works definitively. And this is where things can be really disappointing. You may see a really promising phase 2 study being published in your local newspaper, and that doesn't necessarily mean that as it's translated to a phase 3 study that efficacy is going to be shown. So you'll see many things that work in the phase 2 setting, but when they expand it in phase 3, they're unfortunately not very effective. So the problem, why are we all here today? We're here because we haven't solved the problem of really effective, safe therapies for mesothelioma. We are far better than when I first came to this meeting 25 years ago, but we have a long way to go. So what do we need to do? We need to do research and development. This starts in the laboratory, and that laboratory could be at a medical school, it could be at a university, it could be at a biotech firm. But it requires thinking about, what is the nature of this cancer? What does it make up? What are the genetic abnormalities? What are the predispositions? And how can we attack it, right? So you've got scientists and doctors thinking about these problems all the time, and then thinking about, well, what are the ways to do it? So you heard from Dr. Momborellis that years ago, again, 25 plus years ago, when I was training at the University of Pennsylvania, it was the early days of being able to manipulate the genes of cells. And so we were really thinking about, could we manipulate the genes of cancer cells to make them die, and specifically mesothelioma at that time. And so just note the date of this paper that we published, 2001. So this is 23 years ago. We published our first paper on a mouse model showing that we could give a gene to a mouse that had mesothelioma, and we could cure that mouse of mesothelioma. That red line at the top are mice, that's survival, 100% survival of mice that receive this modified cold virus expressing this gene called interferon. And so in this model, again, curing a mouse is very different than curing a human, but you got to start with helping mice first to see if they can live. And so this was 23 years ago, just to keep that in mind in terms of, and that's when you published it. The experiments were done in the couple years before that. So then if you have something that's promising in a mouse, then you have to go to the FDA. And you have to say, we would like to take this novel compound, and back then we were talking about genetically modified viruses. So this wasn't a simple, we have a small molecule or a protein. We were talking about delivering viruses to human beings which were genetically modified. So there was a long conversation with the FDA, and you have to put in what's called an investigational new drug application, or an IND, which by itself, the one we put together was about this big, multiple hundred pages in size, a year's worth of work just to submit the application to do the first in-human clinical trial. This was done by my primary mentor, Dr. Stephen L. Belda, and then we were able to get approval to go ahead with the first phase 1 study with this. And again, remember what the phase 1 study is. You'll see it in bold. What are the safety issues with the new drug? What is the optimal dose? And is there enough of a signal to proceed with additional studies? And understand that we're hoping to see some glimmer of hope in a small number of patients, 15, 20 patients, enough that it will justify going forward. So this is what a phase 1 study is. A phase 1 study does not definitively tell us whether something works or doesn't work. It just tells us whether it's safe, whether we have the right dose, and do we have enough information to go forward. And so then we developed a series of early phase clinical trials that we published 2007, 2010, 2011, because we were tweaking the virus itself and the doses and the time interval of delivering. And each trial took a year or two, and then we had to analyze the results and then put it together and then publish it. And again, all we're showing at this point is, what is the correct dose? What is the sequence? And is it safe? And do we have enough of a signal to go forward? Because if you don't have a signal, it can be perfectly safe, but if we don't see any benefit to patients, we're not going to go forward to the phase 2 study. So we saw this. So this was a PET CT scan of a patient who had been through surgery with mesothelioma, had recurred in the right side of the chest. You may see circles on the left panels. All those areas, circles surrounding white dots, are areas of recurrence after a pleurectomy, decortication, chemotherapy. Immunotherapy with checkpoint inhibitors didn't exist at the time when we were doing this. And that in this patient, a single dose of the virus injected into the chest cavity with no other treatment within 6 months almost led to a complete response. So again, this was not every patient, but this was one patient. And in this one patient, it was enough that it said, okay, we can go to the FDA and get justification for a phase 2 clinical trial. Again, this is 10 years after that first study in a mouse. So then we went to a phase 2 study. This is a moderately sized study that preliminarily defines the effectiveness. Again, we're hoping that if we do more patients and we study this better, that we can assess how effective this is and hopefully have even more of a signal so we can go to a phase 3 clinical trial. Now, there are some phase 2 trials which are definitive enough and large enough that you might be able to skip the phase 3, go directly to the FDA, and be able to get approval for that drug that you're studying. One of those, for example, is Tumor Treating Fields. I saw someone who was walking around with their Tumor Treating Fields here before. That actually, a large phase 2 study was sufficient to go to the FDA. Actually, it was a single-arm phase 2 study. They were able to get that approved. So there are some situations where you can skip the phase 3 portion. But this was a very complicated phase 2 study that we designed and published 2016, 15 years after the initial mouse study was published. And this is where we combined the delivery of the virus into the chest cavity, 2 doses, with an anti-inflammatory drug, celecoxib or Celebrex, with chemotherapy, either for patients who had never received chemotherapy before or patients who had failed frontline chemotherapy and then were getting second-line chemotherapy. And what we hoped would be that we would see benefits in both. First line and second line, there would be addition. Notice that although we have 2 different groups, combinations in first line and second line, that we don't have this is not a randomized study. So there was no one who just got chemotherapy in this trial. So this is a stratified single-arm trial with no randomization. So this is a classic phase 2, although we did a little bit of a safety, so it's a phase 1/2 because we looked a little bit of safety of the combination first. And what we saw, this is the waterfall plot you saw from Dr. Marmarellis earlier, which showed that we had a number of patients that had responses. And this is the survival curve on the right-hand side, the Kaplan-Meier survival curve. And again, this was about double the historical survival for chemotherapy alone for patients in the second line. So it's not where we want to be, but at least compared to historical controls, showed us that we think we were improving survival. Now, the downside was we didn't show benefits in patients who had never received chemotherapy. So getting the first chemotherapy, that combination, for whatever reason, didn't work. So that was counterintuitive to us. We couldn't figure that out. We're still studying why that is. But we decided that it worked for patients who had been through chemotherapy, had progressed, give it in combination, and then we went back to the FDA at that point. Again, another year and a half of discussions with the FDA to design a phase 3 randomized controlled trial. And again, the goal of this was to determine definitively whether this was an efficacious treatment for patients with mesothelioma. So we designed this trial. This is the Infinite study that you heard about this from Dr. Marmarellis. This was a global clinical trial which randomized patients who had been through frontline chemotherapy to getting virus plus chemotherapy plus the anti-inflammatory drug versus chemotherapy and the anti-inflammatory drug. So this was a randomized controlled trial. It was called open label because the people who got the virus injections, you knew you got a virus injection because you had a procedure to have it put in. So it wasn't blinded. People were aware of what they received. And this was, again, a global study with multiple centers across the world, including 11 centers in Russia, which is important as we think about this. Now, the timing of this study, and timing is everything in life, is that the first patient enrolled in this study, which I'd been spending most of my career developing, was August 2019. Little do we know that 6-7 months later, a global pandemic occurred. So when you heard that the study was closed, it wasn't closed because of lack of efficacy. The study was closed because we couldn't get people into clinical trials because many clinical trials in cancer and other diseases were slow to get people in because no one wanted to leave their house in the middle of one of the worst global pandemics in the history of humankind. So it closed in the spring of 2021 after randomizing 53 patients in the study. Again, this was the first ever randomized controlled trial of a gene therapy in patients with mesothelioma, but yet we are going forward in analyzing the data from those patients. And I'm hopeful that now that the pandemic hopefully is over and no further pandemics are coming, that we can consider revisiting this because perhaps combinations with immunotherapy may be even better. So in the next few months, we'll be analyzing the data from these randomized patients. I'll be publishing the data and presenting it hopefully next year at this conference so I can show you what the data shows. And hopefully, if there's a signal, we can go forward and hopefully work to getting to this to patients. I'm going to skip through the next slides just because of time, but just to say that once you go through that process, once you go through that phase 3 trial, then you have to put through a new drug application called an NDA. So you have to take all of the data that you accumulated from your phase 1, phase 2, phase 3 trials, and your preclinical studies in mice, and put that all together and submit that to the FDA. And you hope that the FDA will approve it. And just because you've shown efficacy in your phase 3 trial doesn't mean that the FDA automatically is going to approve this for use in patients. There's no guarantee of that. So just think about that process. We started these experiments 25 years ago. We're now analyzing the data from the phase 3 trial, which was curtailed by an unanticipated global pandemic. And we're hoping we can get to a new drug application that we can get this to you to use in your patients now. So I really thank you for your time and your patience with us in this clinical trial development and understanding that we really want to get these therapies to you as much as we possibly can. Thank you so much.
Thank you, Dr. Sturman. I see one question for Dr. Sturman, and I know he's headed out to the airport shortly, so we'll take a couple of questions if we can.
Thank you very much, Doctor. Is that on? Can you hear me?
I can.
Okay. You referred to a number of things here, including the pandemic and so forth, and the length of time, generally what it takes to get a new drug into the general population for treatment. I guess my question is this. It seems to me that when that pandemic occurred, there was a fairly terrific acceleration of drug testing and experimentation to get those drugs that would take care of the COVID virus onto the marketplace. So my thought is, however uninformed I am, is that there are two major components to the development of a new drug and finally getting into the population. There's the scientific time and activity that has to go through it, and then there's this bureaucratic time with the FDA and all the things you have to go through with that. Do you see from the COVID process any opportunities to streamline this current process that you've described for any new drug?
I think that's a great point. So you're referring to Operation Warp Speed, which helped really saved millions of lives worldwide. We heard about the mRNA vaccines. I was head of pulmonary critical care at a hospital in New York City where we were absolutely inundated. It was apocalyptic in New York City at that time. And without those vaccines, I can't even imagine that our hospitals and our health systems would have survived. The miracle is that the pandemic hit in February, March of 2020, and we had vaccines rolling out by December of that year. Absolutely remarkable. But this was a concerted worldwide effort. Everyone focused on one biomedical intervention, right? So that's, I would love for everything to be able to be rolled out in 10 months. We can get this to you. But this was an absolute global imperative with multiple billions of dollars poured in to this one initiative that the world was focused on. But are there lessons that we can learn? Yes. First of all, take for a grain of salt the timeline that I gave you. The timeline is for what's called investigator-initiated clinical trials. I was a junior faculty member. This was a concept I developed with my mentor. We're trying to get grants approved through the National Cancer Institute. Very different timeline than in industry, than in biotech, than in large pharma, where they've got hundreds and hundreds of people working on a problem, not just me and a postdoc in a laboratory sitting in Philadelphia somewhere. So again, industry has a more accelerated timeline than I do. But I think that your point is well taken, which is if there's enough initiative, this is where advocacy can play a major role. You can go to FDA and say, we want acceleration of development. The classic example of that is HIV drugs. Right? In the 1980s, the community came to the FDA and said, people are dying. We need to fix this problem faster than you're acting. And Dr. Fauci, to his credit, agreed with them and helped accelerate drug development. So this is where this foundation can play a major role in accelerating this process. Thank you very much.
Thank you, Dr. Sturman. while we are queuing up Dr. Woodward, Dr. Amanda Woodward from Michigan State University, who is speaking to us today about the study that we're engaged in to improve psychosocial support for mesothelioma caregivers. Just a reminder that if you feel the need for a mid-afternoon snack or a drink, there are some small snacks out in the lobby commissary area. But I think everybody ate a good hearty lunch. So if you feel you can sit through and keep moving, then we will just keep plowing on. And Dr. Woodward has got her own slides up, so she's very self-sufficient. Dr. Woodward.
Thank you. I'm Amanda Woodward. I know I've been pointed out a couple of times, and you've heard about the caregiver study that we're working on. My goal here is to give you a little bit more detail about it and talk particularly about the phase that we're currently recruiting for. I'm on the faculty in the School of Social Work at Michigan State and doing this in partnership with the foundation. So as you've heard a couple of times, this is a DoD-funded project. Just started September 1st, so very brand new. This is kind of the kickoff for our recruitment. It's a 4-year project. There are, well, I'll talk a little bit about why caregiver support. I feel as though I'm speaking to the choir here, so I won't say tons about it, but we know that caregiving is hard. We know that mesothelioma has unique characteristics to it. But there's also really limited research that just focuses on caregivers and mesothelioma. So as we were writing this grant, we found 4 studies that focused exclusively on caregiving and mesothelioma. There were other studies that looked at patients with caregivers enrolled, but it was still very focused on the patients. So we only found these 4 studies, and they were not in the U.S. They were in other countries, and of course we know the healthcare context and the social service context is different here. And then there's even fewer studies on the transition from sort of providing care to the death of a loved one and then moving into the bereavement. And so those were 2 pieces of information that sort of shaped the focus of this study. But also the Meso Foundation did this survey in 2021. And one of the things that came out of that was an interest, a need in different types of support for caregivers and the bereaved community, and that as being a place of improvement. So these things together are sort of what led to the current focus for this study. We're taking a community engaged approach. So you heard about the phase 1, 2, 3 for clinical trials. That was a nice segue for me because there's also a parallel process through NIH for behavioral and psychosocial interventions called the STAGE model. Instead of phases, we have stages, and this is a stage 1 study. So it's parallel to a phase 1 study for drug trials and clinical trials in that it's a developmental phase focused less on safety and more on feasibility and acceptability. So what's the experience like for participants? Can we enroll people, and do they feel like it was worthwhile, and getting more participant feedback? We're taking a community engaged approach to the whole process of this study. So the research question and the focus, again, was sort of derived, at least in part, from needs identified by foundation community members. And then it's this partnership between MSU and the foundation with our roles and responsibilities sort of divvied up by our strengths. So the foundation really helping with recruitment. They'll be providing oversight of the intervention when we get to that stage. MSU being the research arm, doing data collection, analysis, and then we're working together on sort of overall project management, dissemination, and communication of findings. And then the other community engaged approach of this is that we are really using community voices in order to help build, develop, structure the intervention. We have some ideas from research literature related to other types of cancer and caregiving, but we want to tailor this to mesothelioma. So there's 3 phases. Phase 1 is what we're in now, doing semi-structured interviews. I'm going to talk a little bit more about each of these. Phase 2, which we will do next year, is focus groups, and then in years 3 and 4, we'll do this feasibility study of the intervention that emerges from the first 2 phases. So phase 1 that we're recruiting for now, our goal here is to better understand the caregiver experience from the diagnosis of a loved one through the end of life and then beyond into bereavement. So we're kind of at this point defining caregiving broadly as current and former caregivers. And I'll talk a little bit more about that in a minute. We're doing in-depth interviews with 20 to 30 patients, caregivers, and bereaved. So we're focusing on the caregiving experience, but we want to interview patients because we want to get the patient perspective of the caregiving experience as well, in terms of the one being cared for and the observations of the patient, of what they see their kind of loved one dealing with, right? These are 1 to 1.5 hour interviews. They'll be by Zoom, and we do have gift cards for completion of the interviews. Phase 2, we're doing focus groups. We're going to take what we've learned in our phase 1 interviews and use that to develop an initial sort of rough draft of the intervention. And we're going to use the focus groups to get feedback on that, further refine the intervention, and including the types of outcomes we should be measuring. So what sorts of things would be important, like if you were going into this intervention, like what are the outcomes that you would want to see at the end? What do you think should be the goal? So what's going into the intervention, but also what should we be measuring in terms of outcomes? So this is, again, focus groups with patients, caregivers, bereaved, and then we'll also do focus groups with healthcare professionals as well to help us kind of put some of the community's experience in the healthcare context. And then the third phase, testing the feasibility and acceptability of the intervention. So we're using an intervention-only design, so no randomization at this stage. Again, as with this stage 1, the goal is to see, do people sign up? Do they have a good experience? And are there, as in the previous presentation, are there any signals that it is working that we justify then moving on to a pilot study? We'll do 3 of these online groups. There'll be 10 weeks each, at least that, unless we learn something different in the first 2 phases, with 10 participants each. And there will be pre and post data collection, measurement of outcomes, but also some more qualitative sort of questions around the experience and input and satisfaction type of measures. You've seen this a couple of times already. I thank you to those who have already completed the screening interview. So the screener asks some questions that help us sort of figure out who to enroll in this phase of the study. So if you complete the screener, does not necessarily guarantee that you'll be enrolled in this phase. We want to try and get as diverse a range as we can in the 20 to 30 folks that we'll be interviewing. But there is a question that, if you end up not being enrolled in phase 1, are you interested in the focus groups or phase 3, so that you can kind of keep your name in the pot so as we move forward. And I went through all of that pretty quick, but I'm happy to take questions.
Any questions for Dr. Woodward? And as before, Claudine and Maria are available if you would like to sign up for the study, have questions about it. There's flyers on the tables or passing around, and the QR code is up there on the screen. So again, a round of applause for Dr. Woodward.
Thank you. Thank you for your time.
Our final presenter this afternoon before we move into our legal panel, and we are mercifully very close to being on time. So thank you for all of your cooperation in all of that. It is a Friday afternoon, and it is Chicago. Traffic will be a nightmare. So please welcome Alexandra Lebenson from the National Cancer Institute, presenting on mesothelioma and genetics.
I don't think it's open. We have to go here, and we do this. Where are you? I know you're in here. Levinson. And then we go to presenter, right there.
Great. Can you show me? Yep. Can you show me the arrow?
I'll set it up for you. It's right
perfect.
there, and you do laser, and then it's do-do-do-do.
Wonderful.
Okay.
Thank you.
And this works.
Okay. Well, thanks so much for having me. Thanks for sticking around. My name is Alex, or Alexandra Lebenson. I'm a genetic counselor at the National Cancer Institute at NIH. It's an honor to be here. It's my second time And it's just such a wonderful community, so I'm grateful. I'm presenting today on genetics and specifically on the BAP1 tumor predisposition syndrome. And it is kind of a weird setup. I'm realizing what everyone's talking about. Okay, so I always like to start out by reviewing some really basic concepts because genetics is really complicated and confusing. So we're just going to take it step by step. All cancer is genetic. Cancer is always caused by genetic mutations. Genetic mutations are changes in the spelling of our DNA, and that doesn't allow our bodies to work the way they're supposed to. And this is just a very, very basic visual so that you can see our bodies are made up of billions of cells. Every single cell has a nucleus, which is like the brain of the cell. Our nucleus is what contains all of our genetic information, our DNA. And our DNA is bundled up into these packages called chromosomes. If I were to stretch out those chromosomes, we would see that DNA double helix that you're probably familiar with. And our DNA is divided into little segments called genes. Our genes are basically our body's instruction manuals. So our genes are what tell our bodies how to function, what to look like, how to grow. And, you know, this is just another simplified picture of that DNA stretched out. You can see that our DNA or our genes are made up of 4 letters, A's, C's, T's, and G's. And it's any combination of those letters that make up those important genes, those important sentences, those important instructions that are telling our bodies what to do. So you can see that, you know, a simple sentence with a single letter misspelled can change the entire meaning of that sentence and therefore the entire instruction. So changes, you know, in our DNA change the way genes can work. So again, all cancer is caused by mutations. It's always genetic. There are 2 different ways we can get mutations. So let's start with the first type, acquired. These are genetic changes that happen during our lifetime, meaning that we acquire the mutation and our body is then susceptible to cancer because of it. So acquired mutations can occur due to environmental factors like asbestos, excess exposure to radiation, and other things. We're all living on planet Earth and all exposed to harmful things. So acquired mutations are found in our tumors. Somatic testing, or you may have heard of tumor testing, or many of you may have had Foundation 1 testing. That's a type of somatic testing. For example, that's the type of testing that looks for mutations in the tumor that have occurred sporadically, so during a person's lifetime. Somatic or tumor testing is performed on the tumor tissue itself. So that's removed at the time of surgery or biopsy. And tumor testing specifically is used to understand mutations that are present in the tumor and that can help with treatment decisions. You've heard a lot about that today. So you can, you know, learn about what drugs are best to target what pathways based on what we see in that tumor. And sometimes it can give us prognostic information about how aggressive a tumor may behave or how not aggressive it could be. And most cancers fall into this category of sporadic. So 90 to 95% of cancers just happen, and you know they're caused by somatic mutations that happen during our lifetime. Inherited mutations are different. These are genetic mutations that can be inherited from a parent, and our bodies are born with them, and that therefore are born with a predisposition or an increased risk for cancer. Clues that we might find inherited mutations or what a genetic counselor might look for are early ages of onset, multiple primary cancers in the same person, multiple affected generations. So when we're looking for mutations that might be running in a family, we perform something called germline genetic testing. So that's the test that we do on blood or saliva because that's representative of every cell of the body. So not the tumor, but germline testing is on blood or saliva. So inherited germline mutations may cause an increased risk for many different cancers. Only a minority of cases, so 5 to 10% of cases of cancer in general are caused by inherited mutations. Somatic or acquired mutations are only found in the tumor again. So they cannot be inherited by a future child. Germline or inherited mutations are found in every single cell of the body. And so that includes our reproductive cells like our sperm, the egg. And so that's why these can be passed on to children. This is kind of a busy slide. It shows something we call the two-hit hypothesis, which is in a very, very simplified way, the difference, it shows the difference between sporadic cancers and inherited cancers. So in most cases of cancer, we start out with 2 working copies of every single gene, one from mom and one from dad. And over time, the longer we live, the higher the chances that we may get mutations in a copy of that gene. But we still have a backup copy. And so the problem occurs when a second mutation, at some point down the line, occurs in the same exact cell, damaging the only working copy that's left. And so that may develop into a tumor in that particular cell. A person with an inherited cancer from one parent is born with only one working copy of that gene in every single cell of the body. So there's no backup. And so as you can imagine, it only takes one mutation to that particular gene in any given cell for a tumor to develop. And that's really why we see in sporadic cancers, we tend to see that happening at later ages. The longer we live, the more mutations we accumulate. And in the case of inherited cancers, we do see early onset disease. We see people getting more than one cancer during their life, and that's just because they have less protective genes in place. Okay, so switching gears now, why are we talking about genetics at a mesothelioma conference? This is a figure that's just adapted from a study done in 2019 with NCI and University of Chicago. But this particular figure just shows a patient cohort from the National Cancer Institute. So it was 239 patients with mesothelioma that underwent germline testing by panel. And they were trying to understand whether there was a hereditary component to mesothelioma. And what they found is that 12% of that cohort actually did harbor a germline mutation in an important gene that had implications. Of that 12%, 7% actually had a mutation in a particular gene called BAP1. So the BAP1 tumor predisposition. BAP1 is a tumor suppressor gene. So that means that it's a really, really important gene. It's protecting us throughout our whole lives. It's working to suppress tumors from forming. We want it to be working because it's protecting us against cancer. So mutations or changes in this gene are actually what cause a predisposition syndrome. Mutations in BAP1 cause many different types of cancer, and they happen at earlier ages than we would see in the general population, usually about 20 years earlier. The main cancers seen in this syndrome, so if I were to see a family with BAP1 tumor predisposition syndrome, these are the types of cancers I would tend to see. The main ones are on this slide, and unfortunately, most of the cancers associated with BAP1 tumor predisposition syndrome are less common, so not typically routinely screened for unless we know about BAP1 carrier status. So sometimes cancers can be detected at late stages if we don't know about this. The lifetime risks for each individual cancer generally range from 10 to 30%, but the cumulative risk for cancer during a lifetime is high. The main cancer that we see in the syndrome is malignant mesothelioma, and about 50% have pleural and about 50% have peritoneal, which is different, right, from the general population where we usually see more lung involvement. The other cancers that we see are uveal melanoma, so cancer of the eye, cutaneous melanoma, and other skin cancers like basal cell carcinomas, kidney cancers, meningiomas, which tend to be more aggressive or malignant, and we're starting to see a higher signal for bladder cancer as well. Cholangiocarcinoma, breast cancer, and hepatocellular carcinoma are other cancers we're looking at in their association with BAP1. There are some benign features as well in this syndrome. So BIMs, or BAP1 inactivated melanocytic tumors, which have also been called BAPomas or MBATES or even atypical Spitz tumors a while ago. They're highly indicative of BAP1 carrier status as well. They're sort of dome-shaped raised papules that can be either flesh-colored or reddish-brown. don't really cause problems. I mean, no sensitivity to temperature or touch. They don't itch. They're very sort of subtle. But, this study in 2017 showed that about 75% of BAP1 germline carriers who underwent a total body skin exam had at least one of these BIMs. So if a dermatologist knows what to look for, this seems to be very common in BAP1 carriers. And of dermatology patients found to have a BIM on clinical exam, 51% were found to carry a germline mutation in this gene. So dermatologists are now more frequently using this as a heads up. They can perform IHC testing on biopsies of these skin findings and see if there's loss of BAP1, and that prompts a genetic test referral. Our group at NCI very, very recently found that the BAP1 tumor predisposition syndrome is also associated with a high rate of nail abnormalities. This was very recently published. We did a prospective analysis of 40 BAP1 carriers that happened to be coming in through NCI for their annual surveillance during the months of October 2023 and March 2024. And we did extensive exams, medical photography, and nail biopsy in a subset of patients. And we learned that most of our BAP1 patients had similar unique findings on their nails, actually. They were presenting with something called onychopapilloma, and that was predominantly in conjunction with something called longitudinal leukonychia. And this was typically seen on multiple fingernails and toenails. So to back up for 1 second, onychopapilloma is a benign tumor of the nail matrix. It's underneath the nail. There's often what we call a hyperkeratotic spicule sticking out. So a lot of patients complain that it gets caught in things, and that's kind of how they realize they have this annoying thing. And it can look like a toothpick kind of running along underneath the nail. Leukonychia is just a term for white nails. So longitudinal leukonychia is specifically when there's a vertical white line running down the nail. And we can predominantly see the leukonychia, the white vertical lines over the onychopapilloma, but it does also present with erythronychia, which is a red line, splinter hemorrhage, nail splitting, or even hyperkeratosis, so just like a buildup underneath the nail. And to the best of our knowledge, this doesn't seem to be associated with much else. There are 3 other genetic syndromes in the literature where we can see this, Hailey-Hailey disease, Darrier disease, and tuberous sclerosis, 2 of which are very severe skin disorders. And in all of these, it's usually a single nail or the thumb that's involved. So this is, along with other significant differences, this seems to be quite unique. Given the rarity of the onychopapilloma on multiple nails in the general population, this might be a very unique finding to BAP1 tumor predisposition syndrome. Our study demonstrated that these onychopapillomas occurred in about 88% of adult carriers ages 30 and above. So not everybody, but it's, and we're still looking. This is very new, but it seems to be a good indicator right now. And these benign and sometimes very apparent nail changes seem to occur decades again before the average age of cancer onset, so it might be another very important identifying feature. And actually, let me just back up to show you. The top figure shows sort of the typical way that it can be seen on multiple fingernails versus a single thumb or digit, just the white lines. And the bottom left, you can see onychopapilloma when you see the finger presenting this way. And you can see it in conjunction with erythronychia and splinter hemorrhage. And on the other side, you can see that it also can present quite subtly, but you do see white vertical lines and little onychopapillomas under the nail. So this syndrome is inherited in an autosomal dominant fashion, meaning there's a 50% risk for first-degree relatives to inherit the familial mutation. So first-degree relatives are children, siblings, and parents. When this occurs, there's an increased risk for multiple cancers during the lifetime, and within the families, there's something called variable expressivity. So different family members can get different, within the same family can get different types of cancer. And I just want to say that it's important to realize that this information has a big impact. It carries a big psychological impact, right? Many BAP1 carriers experience a lot of guilt associated with passing on a hereditary risk to their children. I always remind my patients this is something completely out of our control. The same way that we pass on a familial mutation, we pass on all of our amazing traits to our children as well. I also heard the term survivor guilt when talking about cancer in general, and that's something that occurs in the BAP1 population as well. It's a common feeling when family members do not inherit a familial mutation because it's very difficult for them to watch family members going through these struggles and just know that they did not inherit that. But again, I remind my patients that we have no control and that, your family members benefit so much from the support that, that unaffected family member can give them. In addition, I should also just mention that it's the other thing that patients carry around with them is this responsibility to inform family members. And I can't stress enough how important that is. Sometimes we get caught up in the moment and it becomes a very sort of nuclear family issue, but this information can be life-saving. So we just always encourage our families to share with, cousins and extended relatives. And it's just so important. I know not everyone wants to know and not everyone wants to hear it right away, but I just encourage our families to share the information. There is reproductive technology available today for patients that have cancer predisposition syndromes in general, and BAP1 is included in that. So pre-implantation genetic diagnosis in conjunction with IVF can be used to test embryos for familial mutations. So during the process of IVF, embryos are biopsied and very specific genetic testing can be performed. And then only the embryos that do not contain the familial mutation are actually implanted back, or I should say transferred back for potential implantation and potential pregnancy. So that's a way to avoid transmission into the next generation. So when to seek germline genetic testing? I actually encourage every patient with mesothelioma to consider genetic evaluation. It's also very important that when you have genetic testing that you do it in the setting of a genetic consultation with a healthcare provider that's trained in genetics, versus just having blood drawn as an afterthought or being tossed a kit and spitting in a tube without being consented. It's really, really important that you receive the information about the risks, benefits, limitations of genetic testing, and that you give informed consent. This information will impact you, will impact your family, and so it's so important that you understand what the testing is about, what the information will give you, what information it will give you, and also just to have the opportunity to ask questions. BAP1 mutations are more likely to be found in patients who develop early onset meso and or have more than one BAP1 associated tumor. The highest risk exists in mesothelioma patients with a family history of mesothelioma and or uveal melanoma or kidney cancer. And benign indicators of BAP1 tumor predisposition syndrome include these BIMS and polydactylous onychopapilloma, so the nail changes on multiple fingers. Those are things that should prompt genetic evaluation to find out more about personal and family history. How can genetic testing make a difference? It can provide important prognostic information, and it can allow providers to consider a specific treatment or management plan. It can alert patients to a higher risk for other cancers and allow for proactive screening. Proactive screening then leads to early detection when treatments are most effective. And it can allow family members the chance to undergo genetic testing and understand whether they may need extra cancer surveillance or not. Finally, it may also allow family members the opportunity to use reproductive technologies like PGD to prevent transmission. At NCI, the National Cancer Institute, we do have a study that focuses on BAP1 tumor predisposition syndrome. We're aiming to better understand the syndrome by following BAP1 carriers long-term with a comprehensive screening protocol. Eventually, we'd like to make formal screening guidelines. And at this time, our goal is early detection for better outcomes, but we're also hoping to keep advancing in the direction of targeted therapies for BAP1. This is the name of our study and the clinical trials identifier. Our protocol includes yearly full body derm exam, yearly full ophthalmology exam. Every other year, starting at age 18, we do MRI of the brain. Every other year at age 30, we do MRI of the chest, abdomen, and pelvis. And every other year, we're doing bladder cystoscopy screening. All participants meet with our medical oncology team annually. And at that point, they receive health assessment. We discuss the screening results from that week. Patients provide their personal and family history updates. They obtain updates on BAP1 related information, and we discuss and facilitate cascade testing in the family. Currently we have about 220 patients. I've seen some familiar faces here. And patients travel into Bethesda, Maryland once a year to receive the care that they need by providers that know and understand BAP1. Coordinating that much screening, you can imagine, is a tremendous burden. And so we're able to consolidate the screening into about 4 days a year, which makes a big difference. And my patients talk about scanxiety. That's a real thing. And so I hope that, this study is one way to mitigate that by really making that happen 1 week a year instead of, every week of a year. I really emphasize that I want my patients to live their life using this knowledge as a tool and not letting it control their lives. So with that, I will, if I can. And before I acknowledge my team, I just want to say for our listeners out there that carry a BAP1 pathogenic variant, know that you're not alone. You're part of a really amazing community. I've had the pleasure to meet many of you. And so just know that there's a lot of people here and around the world that are working on this, understanding this syndrome better. And again, really important to live life knowing that you're using this knowledge as a tool, okay? For everyone else, please, feel free to contact me if you have questions about genetic testing or the study. I think that's really important for everyone to talk to their healthcare providers about. Thank you.
Thank you. Any questions? We have a couple of questions here.
Sure.
Are you familiar with Michael Carbone's studies
I
on
am.
Turkey and so forth? Can you give a little explanation to the people here, because I'm sure they're not familiar with it, where the people in Turkey who lived in asbestos homes years ago when things were rebuilt because of Michael Carbone there, where people were getting mesothelioma, and it ran through the families, multiple families, where there was families next door that never got it until there was an intermarriage, and then the intermarriage caused their offspring to have it and so forth. Because I love what you're doing, but could you explain that to the audience with what you're doing? Thank you.
Yeah, I think you did a great job. I think the key is, you wonder, asbestos exposure is awful, but not absolutely everybody that has a shipbuilding job or, those mine workers or professions that are just in the asbestos. Not everybody gets it, right? It's definitely there's definitely something to it. With our families that have an inherited predisposition, we still believe that there's a sensitivity, an increased sensitivity, whether you have BAP1 or a DNA mutation, DNA repair mutation. It always takes, a second hit. You still need mutations from the environment. I'm not sure if I'm exactly answering your question, but I think it's important to understand that the asbestos exposure is still part of the genetic and environmental combination.
I don't really need a microphone, but you answered some of it. But we've had people at conferences years ago where the 3 of the family members were here at the conference, and it was just interesting where people in a town would never get it living with the asbestos, but the cross marriage and the cell, whatever happened there, and then the offspring would catch it because of respect.
Well, I think Dr. Carboni was the one who isolated BAP1, right? And so these are families that did have BAP1 predispositions.
Hi, over here. I'm Joe Bellick from Bellick and Fox, and I appreciate so much that the work that you're doing, but there is a little bit of a historical context to this. My firm actually sponsored the initial BAP1 research that Harvey Pass and Dr. Carboni did, and we did it mostly for early detection. The idea was if you could isolate BAP1 in certain populations like steam fitters or insulators, you might be able to do some early detection of mesothelioma. Unfortunately, Dr. Carboni and a number of other doctors have used the BAP1 research in the litigation context to argue that the mesotheliomas are not caused by BAP1 and are spontaneous or idiopathic based just on the BAP1 mutation. So I just think it's important for patients to know that these BAP1 results can be used aggressively and negatively in their litigation cases, even though that's not the intended purpose. It's not why you and other researchers and counselors are doing it. But I think they should be aware that in this present moment in time, it is due in almost every case that's litigated, where the companies that we sue are seeking results, attempting to do their own BAP1 testing, many cases going to court to try to get judges to order BAP1 testing of our clients. And I think people should just understand the context that a lot of the work that you have done, Harvey Pass did, is being misused. And I'm sure me and Dawn and Kathy can talk more about this during the legal panel, but I just wanted to sort of give a context to it.
I appreciate that. I have had some patients who are not ready to undergo genetic testing because they're in litigation, and I completely understand you have to factor in all of these things. So important to do what you need to do, but then also weigh the risks and benefits. So.
That's one question that we need to transition to our final panel.
I was just going to ask a question about the genetically targeted fractional chemotherapy, GTFC.
And I'm going to say that I'm really not qualified to answer that. I think you need to talk to the medical oncologist. I'm sorry about that.
Wonderful. Thank you, Alexandra. Applause for Alexandra and her team. Well, we've come to the end of our actual presentations. It's time to move into our legal panel section. We're going to take 5 minutes to get our panel up here and assembled, and our board member, Cheryl Brunner, will be the moderator for this panel, who is herself an attorney. So please, we'll be back in about less than 5 minutes, and we'll start.
Rows between the two thorns? Sure. It doesn't matter.
Final stretch here. I would like to welcome our moderator again, Cheryl Bruner. She's one of our board members here at the foundation. And our panel includes Joe Bellick from Bellick and Fox, who is in the middle. Kathy Farinas with Dean, Omar, Branham, and Shirley. She is on your left as you're looking at the stage. And Dawn Besserman with MRHFM, and she is on the right-hand side. Cheryl, take it away.
Thank you, Brian. So yes, I am an attorney. My mother passed away from mesothelioma. I don't practice law in the area of mesothelioma litigation, but I have a personal experience with it. So I'm glad to moderate this panel with these three exceptional attorneys whose firms focus on this area of work. And I like to just say also thank you all so much for being a sponsor of our foundation. I hope that you feel the thanks because it means a lot to the work that we're doing. So we really do appreciate it. So I'll start into these questions. So let's start with, Dawn, I'll ask you the first question. So if someone here has meso, but they have no idea where or if they were ever exposed to asbestos, what do they do? What happens? How do you handle that?
Sure. Thanks, Cheryl. Can you guys hear me okay? Yes. All right.
Hold it close.
Hold it a little closer. Better? All right. Thank you. Again, my name is Dawn Besserman. Thank you all for sticking around. I know it's been a really long day and your brains are full already. So, we do appreciate you sticking around to listen to what we have to say about the legal implications because they are important for you all to understand. I think all three of us would tell you that all the time when we first meet with a client, it happens so frequently that someone comes to us and we start to talk about their diagnosis and their history, and they have no clue how they could have possibly been exposed to asbestos. And that's why you need a lawyer. You need someone who is skilled at investigating these exposures. All three of us here on this panel, this is what we do. We dedicate our careers to representing people who have mesothelioma. At my firm in particular, I can't speak to how their firms are set up, but at my firm in particular, we have investigators that are assigned and attorneys that are assigned to every case, and you will have a whole team of people that are working on your behalf to try to go through your entire life history to find out how you were exposed. And often it's very surprising to clients. A lot of clients don't know that products like their facial makeup powders contained asbestos, and some of those powders are still on the market today. A lot of people don't realize that other products such as brakes on cars contain asbestos. There are a myriad of ways in which people were exposed. There are a myriad of products that contained asbestos through the 20th and 21st century. Hundreds, thousands of products contained asbestos through time. And, we've spent our careers developing that history and knowledge of those products. And we work with our clients, our investigators and attorneys work with our clients to uncover the particular exposures that a particular client has had.
Yep. Thank you. Kathy, so if someone has just gotten their mesothelioma diagnosis, how soon should they contact an attorney?
I think that's a tough question because I think the diagnosis itself sends people reeling, right? You've just been met with some of the harshest information you're ever going to get in your life, and you're trying to balance your medical care, your family, all the things that you are having to go through at that time. And it's hard and it sounds crass for one of us lawyers to be saying, but at the same time, please include us. And that is because this disease can be cruel and can take people very quickly. And often you are the best source of your information. You know what you've been exposed to. You may know more than your spouse does, most likely, about the places you've worked, the products you've personally used through your life, what your parents may have used in your household. And so as rough as it is, getting all of this information at the same time, I encourage you all to talk to a lawyer who will come and really work with you in a very earnest way
to determine the exposures and to just know what you're kind of up against in that world. We're not going to tell you this is an easy process. At least I'm not going to. We work with our clients, and we work with them a lot to get the information that we need to do a good case for you and your family. And so while it is a difficult time, I think the earlier you can involve legal counsel, it's going to benefit you and your family as the disease progresses or you seek treatment. Sometimes we need to do things to preserve tissue, to make sure that there is enough evidence to move forward with litigation. And so involving us early versus late makes things just better across the board.
Right. Joe? Oh, so go ahead, Dawn.
It's the lawyer in me. I can't help it not add this. You have to keep in mind, too, there are strict rules, statutes of limitations in every state that start to run as soon as you're diagnosed. So it is important that you don't put off seeking legal counsel for too long, because you may, in fact, wait so long that you are barred from pursuing any claims.
Yep, yep. That was a follow-up I was going to ask Joe. Yes. Yes.
And for me, getting started on that process felt like something that I could do, I could control. In addition to all the appointments, if we just kind of got on this merry-go-round, this roller coaster, and we were dragged along, and this was one thing that I felt was constructive that we could move forward on. And I agree that, my husband was gone in 9 months, but all the depositions were done. I would not have been able to tell a tenth of what he was able to share. So.
Right, yeah, thank you. So Joe, on that kind of flip side, if your loved one has passed away and you haven't seen an attorney yet, maybe for some of the people watching on our live stream, it's not too late. So what would you say to those people?
Well, first of all, I just want to thank Marf and Cure Meso for all the work that you folks do. We've supported the organization for a long time and encourage our clients, if they're looking to make contributions, to do it to Marf, because in a lot of ways you're the only independent organization in this space. You're not a law firm, you're not a medical institution, so we appreciate that we're in a position to help you guys. And I want to echo what Dawn and Kathy said just about the timing. Every day that we have to work on your case, you're going to get a better result. We know this, and people who have lived through this know that people who have mesothelioma can turn very quickly. And every day that we have to work with you, get information, do depositions, file your case, you're just going to get a better result. If your loved one has passed away and they didn't hire a lawyer before that happened, it's not too late. Most states, like for example New York, you get a new statute of limitations for what's called the wrongful death claim. So, again, I would encourage you to reach out to a lawyer as quickly as possible, hopefully before your loved one passes away, but if not, as soon after their passing as possible. There are some things legally that we need to do to get the case set up so we can try to help you with it. And, one of the key things about this is you want to hire a firm that has expertise in asbestos and mesothelioma cases. The three of us work at firms that are expert in mesothelioma cases, and if your loved one has passed away, we know how to find coworkers, we know how to find other witnesses, we know how to get documents from the facilities and plants, from the unions that your loved ones worked at. There's a lot of resources and techniques that we've built up over the years. A lot of them we have already in our law office: Navy ship records, muster rolls from Navy ships. So it's not too late, and I would encourage you to seek out a firm that specializes in this to let us try to help you investigate it.
Mm-hmm. So is it possible to have mesothelioma and not have a legal case?
Yes, it is. Anything is possible.
What your answer is. Go ahead.
Of course it is. I am a firm believer that even with a BAP1 gene, it takes the extra dose. It takes something to mutate that cell. And so I don't think you often see a BAP1, what the defendants often argue is a spontaneously caused meso. I think it means that somebody hasn't dug deep enough to figure out where that person was exposed or how they were exposed. That's my personal theory. I will stand up on a soapbox and defend that every single day of my life because that's what we do. I shudder to think I've been doing this for 24 years. I've been a lawyer for 27, 24 of them have been dedicated to mesothelioma cases. I shudder to think, and I'm sure that the people sitting up here with me, we just started doing talcum powder cases in about 2016. Some stuff started coming out. I remember sitting across the dining room table from a woman in Evansville, Indiana. And she had a father who was a banker. Her husband was an accountant. She was dying from mesothelioma, and I could not figure it out. Never a break change around her, never anything that I could put a pin on, no donkey, to pin that tail on. And now I wish I could go back in time and ask her, did you use baby powder? Did anybody use Gold Bond around you? What kind of makeup did you use? Because now those are all the kinds of questions I would ask. And I shudder to think at how many, especially women, all of us turned away and said, I can't figure out who to sue for you. We've looked at everything. I can't figure it out. And it literally breaks my heart to think of those people that we did at some point tell, I'm sorry, I can't do anything for you. So are there cases? Sure. But my theory is you just haven't looked hard enough. And so that is a dedication of our firm, is that we will not literally leave a stone unturned. I will try my best to figure out where. I think the thing we all struggle with right now, even if we can figure out some exposures, some jurisdictions treat their citizens different than other jurisdictions, and it sickens us as well. There are certain states where if that is your sole source of your exposure, it's very hard to bring litigation. So there are going to be times you could be told by lawyers, I'm sorry, we can't do much to help you. But I urge you to at least go through that process, because I think the number of times that we can find something to do for you far outweighs those cases that we say there's absolutely nothing I can do for you. But I think we have to be honest about that with our clients.
Right.
So there, you guys can.
So you're going to take that case I'm trying to send you in Kentucky, right? Okay.
Okay, so, all right, John wants to ask a question.
My question is, and I think you almost stated on it, and I hope I get corrected and they're better. Like Massachusetts, there's issues about suing employers, other people, and all that. Pennsylvania has issues, New York is good. Certain states are good, and there's certain states, it's like the red and blue states.
Every state has an issue.
But Massachusetts, I was on a trip, and I was talking to a judge in there, you can't do this, you can't do this. I says, if it's neglect, I'm going after you.
All right, so John wants to know about how do you decide and how do you choose where your lawsuit will be brought?
Take that or shall I?
I'll take it.
Go ahead, Dawn.
So my firm is a national firm. We practice throughout the country. We have offices throughout the country. So I'm very familiar with a lot of jurisdictions. And you hit the nail on the head in one way, which is there are some places that are much better to file a lawsuit in than others. But a good lawyer, a good law firm, what they're going to do is they're going to look at your case, they're going to look at your whole history of exposure, and they're going to try to find the best place to put your case where we can get you the most recovery.
Well, let's say you lived in Massachusetts and that's where everything happened, and you're.
Oh, we file cases in Massachusetts.
And you still work with.
Oh yeah, yeah.
I mean, Massachusetts, you know, part of what Dawn is saying is each state has some things that are good and some things that are bad. So, for example, in Massachusetts, they have a particular law there called joint and several liability, which means that if you sue a whole bunch of companies and only one of them is responsible for 1%, they have to pay 100% of what's owed to you. New York, which has really good law, does not have joint and several liability. Okay, so the reason why you get one of us involved is because we're going to know where's the best place for your individual case.
And thank you for answering that, because I want to make sure everybody else was aware of that.
So why don't we talk about your question right here?
Okay, so this is going to be different. So what if you came to the US in 2008? You're a US citizen. So I'm a US citizen, but I came in 2008. Probably exposed, probably, well, definitely talcum powder and makeup. Do I have a... Sorry. There you go. Thank you. So from my accent, you can tell I'm not from New York. But my question is, we came to the US in 2008. I'm a US citizen. Am I still able to claim in the US?
That's a good question, and it's hard to say without knowing more information about you and your history and your product exposure. If you were exposed to talcum powder products after you came to the United States in 2008, there is probably something that someone can do for you. If you were exposed to products overseas that were manufactured in the US, then perhaps that's also another route. So again, that's why we're telling you, you need to sit down and talk with the lawyer and figure out what your options are. Because just like with what you guys have all heard today, and I think you're gonna walk away, and you already knew it coming in here, that everybody has a different experience when it comes to their treatment and their prognosis and what works for them. It's the same thing with your legal case. Every legal case is different, and there are so many factors that go into a determination as to whether you can successfully pursue a claim and where it should be pursued. And you're not going to know that until you talk to a legal expert. You're just not.
I mean, we're working on a case right now involving a gentleman who was born in Taiwan, lived there for a significant period of time, worked on cargo ships in Taiwan that were built in the United States, and after their use here were sent to Taiwan. And the companies that manufacture the equipment on the ship, like Dawn was saying, are U.S.-based companies, General Electric, Westinghouse. And that case we filed in New York, where the gentleman lives now, and we're pursuing the American companies for the exposure in Taiwan. So, you know, just to reinforce what Dawn was saying, what Kathy's been saying, is that's why you want to sit down with a lawyer and explore all the possibilities to see if there's some way we can help you.
What about these big trusts that have money? Sometimes our patients have heard about things like this. So can you give a little bit of information on what that is and how that factors in?
Well, I'll start, I guess, but this may surprise you, but lawyers don't always tell the truth. And the reason I'm saying that is if you watch ads on TV, you would think that there are billions of dollars available to you in these magic trusts that are very easy to get money from. And that's not the reality. There are a lot of trusts, probably about 50 of them. And if you added up the money in all the trusts, it is billions of dollars. But what's available to any one individual from the trusts is actually quite small and is really not a large part of the compensation that we all get for our clients. So there are these trusts. All of us will file claims for the appropriate trusts, but it's really not the biggest part of what we do. Most of what we do is file lawsuits against companies that have not set up trusts. So when you're going into this, you should understand that the trusts are a very small part of it, and it's not just like a real easy thing that you file these trust claims and people are handing over millions of dollars. It's not the way that this works. That's more about how lawyers are advertising for claims than really reflective of what we do in your case. And anybody here who has gone through it knows that the bankruptcy trusts are a relatively small component of what we do. So.
I was just going to add real quick. If you speak with a law firm or an attorney and the only thing they talk to you about is trust claims, you should talk to other law firms. Every firm has its own business model and its way of doing things, and you want someone that's going to pursue every avenue of compensation for you. The trust claim avenue is not going to result in as much compensation for you. It's also less work for the attorneys than pursuing litigation. So you want to make sure if you have a potential case that could be litigated in courts, you are hiring litigators, people who are going to go all the way to the mats through the trial.
Yeah. Kathy, let's talk about the time frame of how long does a case take. Can you give people an idea of what that typically looks like?
Sure, I can do some generalization, and then this also speaks to where we put your case. When you sit down and you meet with the lawyers and you go through all the exposures of where you have had asbestos exposure, one of the things, I literally make a chart of, okay, these are the states that we're looking at. This is potentially where we are going to file this case. I go through and I look at the law. And I think everybody up here, when I'm saying I mean we sit down, we look at the law that applies to those jurisdictions. And then at the same time, I'm looking at how quickly can I get you deposed? How quickly can I get you a trial date? How quick is this judge in this jurisdiction moving cases? I want to pick the best law and the quickest route to put your case in. So the long-winded version of this is it's going to depend. Where we can put your case is going to factor in how quickly your case is going to move. There are some jurisdictions where getting a trial date is literally like pulling teeth. There are other jurisdictions that you can get a trial setting in probably as quick as 6 months. I practiced initially in Indiana most of my career, and now nationally. But in Indiana, we have a rocket docket that's 8 months from the date you file your case to the time you get a trial, as long as you have a living mesothelioma plaintiff. If somebody passes, unfortunately, they go to kind of the back of the first in, first out. That is typical of quite a few different jurisdictions. But I think the goal of our practice is always getting you the fastest trial date we can, because that's what promotes the compensation. The defendants will sit back and really not want to do much of anything till their feet are really on the fire, literally. And so it is part of the consideration of where to put your case as to how quickly your case is going to move. I would say an average from the time you hire an attorney till the time your litigation is done, and I am not talking about the bankruptcy claims. We have some horrific bankruptcy stories. I think Pittsburgh Corning declared in 2000. They opened their trust in 2017. It was a 17-year process for a bankruptcy claim. But as far as the litigation, what we're actually doing in a courtroom somewhere with you, those are running on average for a living case anywhere, like I said, from the earliest 6 to 8 months to completion up to about 2 years, I think would be my estimate in most jurisdictions. Sometimes you're fighting all the time, and the defendants are going to fight back and try to push that trial. As some of you may know, that once someone passes, you in lots of jurisdictions lose different claims. You might lose punitive damages. You might lose pain and suffering in some jurisdictions. So the defendants have a goal of stretching these cases out as long as they can. Number one, it keeps the money in their pocket longer. And number two, they benefit from dragging these out and you losing some of your compensation rights. So our goal is always push, 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 trial date, trial date, trial date, get you deposed, get you a trial date.
So on that note of that bankruptcy, can any of you update us on the Johnson & Johnson bankruptcy and what's going on there?
Okay, I'm just going to say this, that all of us are really good at what we do, but Kathy's firm is probably, in terms of Johnson & Johnson, the firm that's leading the fight on this. So I'm going to give her back the mic to talk about this.
Very kind of you, Joe. Go ahead, Kathy.
This is my soapbox. I'm just going to get it out right now. Johnson & Johnson has now declared bankruptcy twice. They are a multi-billion dollar company. It is a fraudulent bankruptcy every single time. We are now going on name changes, liability shifts 7, 8, and 9 for Johnson & Johnson since the year 2001. I'm not going to go into the Plato Project and everything else that they did, but this was a very long, thought-out process by Johnson & Johnson. I actually am arguing this in a court on Tuesday. I'm arguing this in a court on Thursday. They are trying to escape liability every chance that they can by renaming and redressing what Johnson & Johnson truly is. So right now they have created new entities. So they have a mesothelioma track that is not in bankruptcy right now. They've created a new company called Pecos River Talc. And then they've created another entity called Red River Talc. For those of you who don't know where those names come from, they're rivers in Texas, where they like to do this thing called the Texas two-step. So that is where they go create a new company, dump liability, run, go file bankruptcy in North Carolina. That is the Texas two-step. All of us have gone to the Hill to oppose this. We are working legislatively. We are working in the court system. We are opposing things in the bankruptcy court. Right now, for your cases, people with mesothelioma, they have not declared bankruptcy for this new entity, Pecos River, yet. Doesn't mean that they're not going to. Interestingly, what they did is they created this company, Pecos, which has all the liabilities, but no assets. And so they have to get their money from another entity they created called Holdco. Holding the money company is what I call it. And so they have to beg for that money to be put into Pecos right now. So it is a name game like no other I think we've ever seen in this litigation. We are still going after them. We are trying cases against them. We just got a $15 million verdict 2 days ago against them. And I hope many more. So it is currently for mesothelioma patients and clients, it is not in bankruptcy at this time.
And I also just wanted to say it's probably appropriate around Halloween time to talk about what we call zombie corporations. But we're not just doing this work for Johnson & Johnson and tel companies. My firm, Kathy's firm, we are resurrecting companies that bought insurance, and the insurance money has been basically taken by insurance companies through dissolutions and bankruptcies and changing of corporate structures. And we are literally going into states around the country and reviving these companies and forcing the big insurance companies like AIG and the Hartford and Travelers and Liberty Mutual to fork over the money that they took in policies to make it available for you and our clients. And it's in a lot of ways we've become insurance lawyers in addition to mesothelioma lawyers, but it's a massive fraud that was perpetrated by these companies. And right now, a lot of that insurance money is controlled by Warren Buffett, who has stockpiled a lot of the cash that these companies paid to buy insurance for these claims. And when the companies disappeared, the money was just put to the side. So it's not just Johnson & Johnson. It's a lot of companies that expose people to asbestos that we're fighting to get basically back and get the policy money back.
I'll just add, like Joe was just saying, it's not just Johnson & Johnson. That's the one that gets a lot of press. They weren't the first to do the Texas two-step. They were the biggest name, recognizable name that's done it. But there are other companies that all of our firms are in the process of fighting their attempts at bankruptcy because they are, as Joe said, fraud. These companies have money. These companies harmed you. And just to go back to the Dr. Carboni comment, not to beat a dead horse, but I'm going to. With BAP1, the defendants in these cases tried to fabricate this defense that people that have mesothelioma and a BAP1 mutation have mesothelioma solely because of that mutation, and that is not true. You have mesothelioma because you were exposed to asbestos, and that's why you need a lawyer, because you need a lawyer to figure out how you were exposed so the lawyer can go after the companies, whether they're solvent or bankrupt or faking bankruptcy to hide from you, so that you and your family get the compensation that you deserve, because the reality is that this disease is a man-made disease. It is made by corporate greed, and that is why you're all suffering.
Ooh, I want to clap.
That was my soapbox.
Yeah. So let's hear some from you all about what questions should people ask when they are interviewing firms. How do they know which attorneys to go with? And let's see. What are you looking for, the microphone or no? Okay. So.
She can be Oprah now.
Just speak closely into the
I Googled my diagnosed and I was looking for the book to get the information, and I found a site, and I went and I got the book and information, whatever, and I was educated. Not like I'm educated right now, but I had a little clue. Your firm educated me. She came to the house. She was so nice to me. She met my mom and my daughters, and I felt comfortable. I felt at ease. And when she broke it down, like you just said, I'm like, for anyone to know this can happen to somebody and die, and you're gonna do bankruptcy? It's like, oh, my life doesn't matter. I have kids I want to see grow up and have. You see what I'm saying? It hurts, but I'm glad I was educated, broke it down. I did what I had to do, and I thank you because your firm helped me a lot. You educated me every step of the way, and this is how I got to get with this group. Good. Thank you.
Good.
Thank you.
Yep.
It's all been very interesting, especially for my wife, since she's an attorney as well. Last evening, we happened to share a few moments with Kathy, and there were two things we talked about, so I'd like to ask you two questions that we discussed. What are your thoughts about unsolicited contacts from mesothelioma lawyers, unsolicited, number one? And number two, as a client, do you like to represent that individual as an individual, or what is your view about placing clients into class actions settings?
So, with respect to class actions, none of us do that. In fact, there's a U.S. Supreme Court case called Georgine, which many of us were involved in, which prohibits class actions for mesothelioma victims. And the reason is because there are a lot of individualized factors in each case that make class actions inappropriate. And if you have mesothelioma, to be frank with you, the last place you would want to be is in a class action, because mesothelioma cases in the asbestos world have the most value. And if they get grouped together with other types of cases involving asbestos, the value gets pulled down, and the individualized factors that allow us to increase compensation disappear. So any lawyer you go to who mentions a class action, you want to get up and walk out, because that's not the way these cases are handled. In terms of unsolicited contacts, I think the ethics rules are pretty clear that that should not be happening. Even if it's a physician or medical provider, they should be asking your permission before sharing any information with a lawyer. Unfortunately, we know that there are unsolicited contacts that go on, but whether it's mesothelioma or any other personal injury cases, the rules are pretty clear that that's not something that should be happening.
I don't have any experience of lawyers ever, and
You're lucky.
yeah, well, apparently so. So I've been watching a lot of American soap operas in my past, and you guys are the bad guys or the good guys, depending which side you sit on. So for me, so far, I've put my head in the sand over lawyers. I've had unsolicited calls. I've got fed up with them. I don't know which way to go. I don't want to go and sign a contract which, quite frankly, I wouldn't understand. Even if I read through the whole lot, I just would not. So it's a bit of a wing and a prayer. You don't know, is the fee structure reasonable? Is the, if we're going to court, then we're going to pay the fees and you're going to get this amount of fees. I don't know whether you can put in that contract, if you're going to go and have fees, it's going to be limited to this, because sometimes on the Facebook group, there are people who say, I wish I'd never gone to lawyers, and I'm getting this and I'm getting that, and it's a burden for my family, and I don't want to go and do something that's going to create a bad situation and make it even worse. And I'd appreciate your honesty, if it's not an oxymoron, about how would you handle people like me who just, I really would like this to be wave a magic wand and it all to go away. I really would. But if there is compensation on the table which can help my family in the future, or me, or to go and pay for medical treatment in Germany or wherever, some miracle cure will happen. But I also don't want to spend the time I have just dealing with crap that I don't want to deal with.
Before you answer, can you summarize the question? We couldn't hear it.
Yeah, I think essentially her point is that she doesn't have any experience with attorneys, and her experience with American attorneys is limited to American television, which doesn't always paint the best picture of lawyers. And she has concerns about spending her time and energy working with lawyers, and she's concerned about how she would even know what is a fair fee structure or what that looks like. So just to answer your question, and there's a lot there, but when you are considering retaining a law firm to represent you, in this situation, in these types of cases, it should be at no risk to you. It should be a contingent fee agreement arrangement wherein you're not writing checks to the law firm. The law firm is going to work on your behalf. They are expending the resources and the time and the money to investigate your case. And then if the law firm is able to obtain compensation for you and your family, then the law firm gets paid out of those funds. So it should not be a financial burden on you. The level of your time commitment, that's going to vary depending on cases. But at the end of the day, the client is the client is the boss, and you can limit what you're willing to put into the case. It may reduce your overall compensation, but if you meet with an attorney and you decide that the only thing I really want to do is pursue the trust claims because it is less intrusive, it is less burdensome on me, that is something that you can choose to do. If you do want to pursue a litigation case, that is going to take more time and commitment. And that's something that you're going to have to talk with your attorney as they learn a little bit more about your background and exposures and what the potential routes of compensation for are you. I would just recommend you talk to somebody. I know it's overwhelming, but the goal at our firms is to make it as least intrusive, as less overwhelming as possible. We want to minimize that because we know what you want to focus on is your family and your health. And let us focus on the legal. And that's really what, when you hire an attorney, you should feel that relief, that burden, because you're putting it on your lawyer. And we're happy. That's what we get paid to do, to take on that burden. And we want to make your life as litigation light as possible, right? Mm-hmm. That's our job. Your job is to focus on your health and your family, and just to provide as much information as we need, and hopefully it's little time as possible for you.
Yeah, keep talking about that and the questions that clients should ask you all. What should they ask lawyers? What's a good answer? What would you all say?
Well, first, just let me say to you, being involved in any type of lawsuit or litigation stinks, okay? It just does. Whether you're the person being sued or you're suing somebody, it's certainly not how I think any of us would want to spend their time given another option, especially if you have a limited amount of time left. But there's a lot of important purposes to it. I mean, one is to get compensation. So if there are medical treatments that are not covered, if there are things that you need to do, if you've been supporting your family or doing things around the home that need to be replaced by hiring people. But there's also a civic reason to do it, which is to hold these companies accountable for what they did and to send a message that they have to act responsibly. And that still goes on, even though the history of asbestos is decades old. The message is still understood. So there's a very important public purpose to deter corporate misconduct. And also, having gone through this with a lot of people, there's a sense of purpose and a cathartic value to doing this. A lot of our clients are people who are used to being very busy, used to providing for their families, used to having a sense of purpose. And that's taken away by this type of cancer. And in some ways, what we do working with them gives them back a sense of purpose and a sense of providing for their families and doing something positive. And there's a lot of clients that we've all had that were reluctant to get into this, and at the end of the day felt that they had accomplished something important at the end of it. The most important thing if you're hiring a lawyer is to make sure it's a lawyer who's experienced doing mesothelioma cases, has the type of experience the three firms up here have, and also that they're going to treat you like an individual and they're willing to go to distance on your behalf. And you want to ask them if they take cases to trial, how they work up their cases, how they assign lawyers to your cases. Are they going to send your case to another law firm? Are they going to work on it themselves? Those are the types of things you want to ask to make sure that you're getting the appropriate firm on your behalf.
And we'll give the last word to Kathy.
I reiterate everything that my colleagues here have said. I think it is important to understand the role that you want to fill in the litigation. And so I think sitting down with a potential attorney to represent you, I would have a list of questions. And I think it's important to go into those meetings with knowing what you want to do, how much of your time you want to give to this process. And it's often a question that people are asking, not only how long do these cases take, but what's going to be required of me? And am I just doing this for nothing? You hear, I think all of us hear that question a lot. I've had a gentleman and I'll use this as an example to kind of wrap it up. I had a client in Minnesota who, talked with them initially, and then it just was something. They had been in some really negative litigation before due to an unfortunate loss of a daughter, and they did not want to do this again. And so I let them, I am the worst salesperson up here. I am not a hard sell person. I will come, I will tell you the pros and cons of everything, and I'm not going to force something on you. I let them have some time, and I called them back and I said, I just want to check back in with you and let's talk about what this case is going to require of you. And so we talked about a lot of activity up front, getting the deposition done. And then it kind of goes quiet for a little bit. Those of you who've been in litigation probably understand this. It's when we're working behind the scenes. And it's going to be a period where not a lot is going to be asked of you. And then it'll pick back up again. It sort of ebbs and flows like a wave. we recently are very close to wrapping up his case, and he called me the other day and he said, remember when you came back to me and said, I still think this is worth your time. I don't think you're doing this for nothing. And he called me and he was just sobbing on the other end of the phone. He said, you didn't lie to me. And I think when you find the trust that you will know about with the lawyer that you're sitting maybe in your living room talking to, you're going to develop a rapport with that person. And when you feel comfortable, that's the attorney who's answered your questions, who's been earnest and honest with you, that's the attorney you want to sign up with. And you're going to have your questions answered. When they can't answer your questions, I would be leery, because there's probably not one of us up here who can't answer these kinds of questions when it's truly their passion and it's what they do for a living, is working with people like you all in this room to make something hopefully a little bit more right for you. We're never going to be able to give you back your health, and it's something that all of us wish we could. But holding these companies responsible, like Joe said, for what they've done, they made conscious choices that put you here in this room, and they need to answer for those choices. And that's just, I think you will just know. And it sounds kind of corny, but I think that when an attorney can answer your questions openly and honestly, and just be that person that you are comfortable going to for those questions for this extended period of time while this is in litigation, then that's the person you want working on your case.
Yeah. Dawn, Joe, Kathy, thank you all for being here. They are going to still be here. I'm sure that there's still more questions that want to be asked, but since we are after 5 p.m., Brian is going to come back up with a quick thank you and goodbye, and Dawn, Joe, and Kathy will be here to talk to you.
Well, folks, you made it. Applause for everyone. You made it. Thank you for your support again to our sponsors, Bellick & Fox, Dean Omar, Branham & Shirley, MRHFM, Merck, the Gorey Law Firm, Bristol Myers Squibb, and the Early Law Firm. That was a lot over the past 2 days. A lot to assimilate, a lot to listen to, a lot to ponder. So please feel free to reach out to any of the resources that you encountered over these past 2 days. They'll be happy to talk to you, whether it be a scientist, a social worker, or someone in the legal profession. They'll be happy to speak with you. The foundation wants to be there to support you in your meso journey, so please reach out to us as you are able. And we look forward to seeing everyone next year in Philadelphia. We'll be in Philadelphia next year. The dates will be coming out right after the first of the year, so please look forward to that. Save the date notice. Goodbye, thank you, and have a safe travels home.
Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick & Fox. We support the mesothelioma community by providing first quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
Hi, I'm Trey Branham. Dean Omar Branham & Shirley is proud to sponsor this year's Mesothelioma Applied Research Foundation Conference. The 34 lawyers at Dobbs have more than 400 collective years providing legal representation to victims of this insidious cancer. We applaud the leadership of MARF and this community for its tireless dedication to finding a cure for this totally preventable disease.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.